ஓ! இது ஹோஸ்ட்டா? விஷ்ணு பிரசாதா?
எஸ் சார். இத நீங்க ஸ்பீக்கர சேஞ்ச் பண்ணுங்க. பெரிய நேம். இந்த ஆப்ப க்ளோஸ் பண்ணுங்க சார்.
அது ஆடியோ. ಇಲ್ಲ ಸರ್ ಇದು ಈ ಕ್ಯಾಮ್ರಾಯಿಂದ ಹೆಂಗ್ ಕನೆಕ್ಟ್ ಆಗುತ್ತೆ ಇದು ಆಡಿಯೋ?
இது கேமரா ஹிட்
ಇದು ಕ್ಯಾಮ್ರಾ ವಿಡಿಯೋ ಇದು ಆಡಿಯೋ.
ஆடியோ
ஆடியோ எங்கேருந்து இது?
ஃப்ரம் தட்
அங்கேருந்தா?
மிக்சர் போர்ட். எஸ். அங்கருந்து கீழ வந்து இதுல
ஓ இங்கேருந்து. ஓ ஓகே ஓகே. அது ஒன்று இருக்குல்ல அது மட்டும்.
ஹலோ ஹலோ ஹலோ. சொல்லுங்க ஜி. இங்க ஃபோர்த் ஃப்ளோர்ல இருக்கேன். இது கான்ஃபரன்ஸ்ல சர்ஜரி கான்ஃபரன்ஸ் 9:00. 9:00ல அங்க இருக்கேன் சார். வசந்த் இன்னும் சாப்பிடணும்னு நினைக்கிறேன். நான் இனிமேதான் வரணும். நீங்க வசந்த் கூட்டு போறீங்களா? ஏன்னா இங்க ஸ்டார்ட் பண்ணிட்டு 9:30 தான் ஆகணும் வர்றது. மோர் ஆர் லெஸ். ஓகே ஓகே தல ஓகே. பண்ணல சார்.
Here that will see. There or here, here will be AC. There will be non
Last time here only. Let's take the results.
YouTube recording, no? These two people voice also from it. From this, yes, from this. Because we are getting all audio in from this one. Connecting. Then this system microphone should be switched on. But if you cannot,
I think it's not system.
but we come here to sitting.
Who is a hall person who is sitting? There's somebody will be there in charge of this.
Right.
ఎవరు కెళ్ళిందా ఏసీ ఆన్ పనియాచా ఇల్లియా
Power off.
Power off అయి ఉంది.
दोपहर में
नहीं वाली को रिपेयर करेंगे
वहाँ खड़ा हुआ है ना
Yes, in the left way, man, that is how. So power is not that. And then, I don't know, they didn't change much of it. That is not really, the same, the same. First, the first answer, and the second, But I think what is that person? Because outside they can say you have to be easy, but they don't feel like a farmer and the family in the latter. That's what I need to figure out. That is when somebody has said it. It should be. Yeah.
Very good morning to one and all present here. Welcome back to the day 2 of the JIPMER surgery update. We start today's session with a case presentation on breast lump by our postgraduate students, Dr. Sai Kiran and Dr. Shalini. I kindly request the examiners for this case, Dr. Kadambari, Dr. Ravishankar Pichya, Dr. Venkatesh SP, and Dr. Ramya V to come to the rise. Good morning, John. We are presenting today a case on breast lump. Here is Kanagi 48 years old. And she is a homemaker who is living from Vilupuram district. Presently with chief complaints of lump in her left breast. She presented with the chief complaints of lump in left breast for last 6 months and associated pain in the lump of her last 1 month. She was apparently asymptomatic until the last 6 months. Then she noticed a lump in her left breast, which is insidious onset, initially the size of 2 crust to centimeter. Then rapidly progressed around 5 times of its initial size over a 6 month. Then she also had a history of pain in that lump for last 1 month, which is dull aching type, intermittent, and reduced with taking analgesics over the counter. There was no history of skin discoloration or ulceration or fungation over the. There was no history of nipple discharge, and there was no history of another swelling or other swelling in the opposite contralateral breast or axillary or supraclavicular region. There was no history of pain in the back, hip, or the shoulder region. There was no history of cough with expectoration, chest pain, abdominal pain, seizure disorder, or focal neurological deficit. She had no history of trauma prior to noticing this lump. Past history, she is not a known case of diabetic, hypertension, tuberculosis, or epilepsy. She has no history of previous breast lump or breast surgery, or no other any hospital admissions in the past. She has no history of radiation exposure to the chest. Family history, there was no history of breast lump or any breast cancer in her first degree relatives. She has no history of uterine or colorectal or ovarian cancers in family members. Menstrual and obstetric history. She attained her menarche at the age of 12. She had a normal menstrual cycle and the flow of 3 to 5 days per month. And she has 2 children, and her first child birth was at the age of 22. She breastfed both her children for a duration of 6 months each. She had no history of use of oral contraceptives or hormonal therapy. Personal history, she takes a mixed diet. She has normal sleeping pattern. She has a bowel and bladder habits as normal. She is not habituated to alcohol, smoking, or tobacco or chewing. She has no drug allergy. Treatment history. She is not being evaluated or treated for the above mentioned complaints, and she took analgesics over the counter to relieve the pain. Summary: 40-year-old premenopausal woman with a lump in the left breast, with associated mild pain or the lump, with no significant family history and no symptoms suggestive of metastasis. History-wise, it is a functionally malignant breast. Right. So when you're asking for nipple discharge, what kind of other questions are you asking? If there is a nipple discharge in a patient with breath complaints, how frequently it discharges there, and what is the nature of it? Whether it is serious or bloody or bleeding, whether it comes frequently or whether it comes at one point or at multiple points. So in other words, whether it is spontaneous or on expression, whether it is from a single opening or multiple, either bilateral or only from one breast. Again, the nature of the discharge. So
So, why do you say that is, you have mentioned it's customer yes. Or what are the features, or what are the clinical features that may make you tell it's carcinoma?
next is the age.
It's with the age that the carcinoma is common. For 40 years is not a common age to have a diagnosis of carcinoma of the breast. When you say the summary about this one, be very specific. Why you say you mentioned about the rapid onset. You mentioned about history of variation. And what are the you mentioned no history of trauma, no history of biopsy. Is it we have some relevance to the clinic?
There are other like breast history of trauma to the breast related breast necrosis. So classification and numbers are present as a hard lump. That may be misdiagnosed as a breast cancer.
Any history of any previous biopsy?
She has not. She has no hospital admission or hospital visit previously.
Any okay, you mentioned no history of variation. What is its significance?
Chest radiation is a radiation exposure because of carcinoma. So previous history of Hodgkin lymphoma and chest radiation.
So we have some the decision based on that. Any history of variation has usually which age we give variation to chest, particularly. Nowadays it's not that much common. Previously, the lymphomas and that we used to have variation. The posterior data has a relevance which we discussed. So basically, history of breast biopsies, history of previous surgeries, all had a increased risk for the breast cancer. And history of radiation, not for the malignant change per se, but we have the decision making to where we come for the treatment part. The history, we go back to previous steps. The history of metastatic symptoms. Previous. Yeah. So you started asking about cough, chest pain, abdominal pain for metastasis.
Okay.
Yes, sir. So is it enough you ask cough? What will be the symptoms if the metastasis is going to the yeah, breathlessness is more important because cough is a symptom of obstructive disease. So here we have a malignant diffusion. So breathlessness is more important than cough. And about jaundice, why jaundice? Yeah, that's what. So if the baby is having see a breast with liver metastasis, that doesn't mean that she will develop jaundice. Okay. So even up to 20 to 30% of the liver is enough for conjugation. So unless if it is extensive involvement, where the other presentation are coming. So usually jaundice is not a feature of a metastatic disease. Okay. Other than abdominal distension, loss of appetite, that is important. Why, what pain in the back you asked? Specifically, you asked pain in the back.
low back,
Why?
bone vertebral metastasis.
Which vertebra? You cannot tell thoracolumbar. You want to tell only one. Which part of the vertebra is very common for the bone metastasis? Lumbar. Yes. Okay. Reason?
Sir, the introduction to veins, these are the valves which communicate with the back.
That's what I wanted to know.
What are the various hormone related risk factors that we've asked for? How does menstrual history, breastfeeding history of endocrine ossifil, how are these relevant to breast cancer? Prolonged estrogen exposure is a risk factor to develop breast cancer. With early menarche, late menopause, nulliparous, late first childbirth, expected to interrupted estrogen exposure. So why is it? How does that affect breast person? What is the pathophysiology? Estrogen helps in difference this breast such to difference. Estrogen is required for proliferation of breast. Okay, you're saying that estrogen increases proliferation. Yes, that could be one reason. What we say is uninterrupted estrogen exposure. That means the progesterone, which is causing completion of growth of the breast into as we know that during lactation and almost towards the end of pregnancy is when the breast glands show complete growth. So they become more mature. If that is not there, the growth probably stops at 70 to 80%. And during the cycles, it goes a little bit more growth and then reversible. We know that, right? So that completion of growth doesn't happen. So immature glands are more prone for development of malignancy. That is the proposed theory.
You mentioned about family history. What you specifically ask the patient?
Usually in a first degree relatives like
Who are first degree relatives, who are second degree relatives? Because many times we don't ask it specifically. Whenever you ask family history, they always think only about father and mother. But who are first degree relatives, second degree relatives?
mother, father, elder sister, younger sister. First degree.
Okay. Then
Second degrees are like mother's sister.
the first degree relatives are your parents, siblings, and also your the son or daughters. They are the usual first degree relatives. Second degree relatives, it goes to maternal and paternal uncles, aunts, then grandfathers, then the cousins who are they all the second degree relatives. Third, the great relative goes to the great grandfathers, and their generation comes like a third degree relatives. We have to, whenever we ask, we particularly ask them whether your relatives, cousins or everyone has. So we had a case who had the second degree relative also very important. And what cancers you specific ask them pertaining to this case?
Ovarian cancer, breast cancer in them also.
Breast cancer,
Ovarian cancer, uterine cancer, and other cancers.
main is the breast and ovarian cancer.
Suppose she gives a history that my first cousin had CNS. What is it going? How is it going to affect your approach to her? The diagnosis and management, and what will you say? How are you? What difference is it going to make in the way you approach?
That means she is carrying a risk, the gene, the
Does
family.
it? Does it? What are the other characteristics? One is family history. What are the other characteristics you will inquire about in the family history to think strongly of a possible genetic susceptibility? Simply asking whether you have family history is not enough. You need to know a little more. Suppose she says, yeah, so and so had. What else will you ask? Does the age of onset of the cancer matter? Yes. Then which organ was involved? What type of cancer was it? How does age matter?
They will present in early age.
Hmm.
And
Okay, so earlier age and younger age, if it involves younger age and number of relatives who are involved. Suppose two sisters have had, or mother and her sister have had, then the number of relatives, age of onset, type of cancer, if it is possible to. Right? What was whether it was a triple negative malignancy. If you can get that history, that also impacts that gives you a little more. What are the common genetic mutations that you have heard of, which affect the incidence of breast cancer? Common
BRCA T53, T10.
T10. You know that? Cowden. Never heard of T10. Okay. These are rare. Cowden is not correct. So move on to examination.
Examination, she was examined in a well-lit room, taking the verbal consent in the presence of the female chaperone. General examination, she was conscious to be at a time, place, and person. She is moderately nourished with a BMI of 23. There is no pallor, icterus, or no generalized lymphadenopathy. Her epoch status is 1, and the pulse rate is 72. It's a good volume. It's measured in the right radial artery. Blood pressure is 116/70, measured in the right upper arm in the sitting position. Respiratory rate is 16 per minute. Examination of the breast inspection. First, by the sitting with arms by the side, the left breast is enlarged and slightly elevated than the right breast. The Buzeron's appearance was noted over the left breast. There is no ulceration, satellite nodules are noted. There is no dilated veins or eczema. There is no edema of the ipsilateral upper limb. There is no visible supraclavicular swellings. The previous core needle biopsy scar was seen. Nipple position, the left side nipple is slightly in upper position than the right breast. That is retracted. No nipple discharge was noted. Irrilla is brown in color. There are no cracks or fissures. Sitting with the arms raised above the head. The left breast was noted slightly above the right breast. Lump becomes more prominent with puckering of the skin noted over it. The inframammary area looks normal. And in axilla, there is no visible swellings. Sitting with leaning forward, the left breast falling was less compared to the right breast. Palpation, right breast was soft with no nodularity or lump. Left breast, there is no localized increase in warmth or tenderness. A firm to hard, well-defined lump with a regular surface of size 10 cross 10 centimeters was felt involving all quadrants of the breast. The skin over the lump in the perioral region is not pinchable. The Buzeron's was noted over the left breast. The lump is mobile and it is fixed when the arms are pressed against the hips. Multiple firm mobile left axillary nodes are palpable, largest of 2 + 1 centimeter. There is no edema of the left arm. Bilateral supraclavicular nodes are not palpable. Percussion, there is resident area noted over the parasternal region. Systemic examination, in the abdomen there is
Let's go back to your. So, you mentioned, the palpation. So overall, an infected funny, you already mentioned it, you need not repeat it here. And lump is mobile and fixed when arms are pressed against the hips. What does that mean?
Making the contraction of the pectoral.
What do you mean by lump is mobile?
When the arms are by the side, the lump is mobile. When the arms are pressed against the hip, like on contact with the pectoralis together, the lump is fixed.
So when you talk about mobility of a breast lump, okay, because it is a pointer towards a possible diagnosis. So you have to qualify. Simply saying mobile is not enough. How do you say it? So that means is this a benign condition? Clinically, it's mobile. You have to qualify that term a little more. Is it really mobile within the breast?
It's not really mobile within the.
So what do we mean when we say really mobile within the breast? And which swelling is typically described as really mobile within? So, right? So to distinguish generally, when we talk about mobility here, we are referring to
The mobility in relation to the pectoralis nature.
yes, or just one the deeper issues. So you have to explain this and describe it a little more clearly.
How did you palpate the breast lump?
Or the palm of the
The flat of your fingers.
flat of.
So we don't pinch the breast. We roll with the flat of the breast. So did you palpate in the sitting posture or lying down posture?
This palpate on the leg.
Any particular reason? Do you prefer that or do you prefer to do both?
If the breast is engorged, to make the more prominent, we can better to make the patient examine the lying position so that the breast tissue will be spread.
Actually, there's no particular dictum that you should palpate either in sitting posture or lying down posture. We can do in both positions. In case of larger breasts, of course, we get better findings in lying down posture. But the most important thing is to roll with the flat of our hands rather than pinching.
So as ma'am told, still this mobility, you have to be more clear in respect of the breast lump, okay? Whether it is having independent mobility or moving with the breast tissue. When you try to move the lump, whether skin is also moving. Okay, those things you have to be very clear. Here, since the skin is involved, no?
Yes, the skin is
So definitely when you try to move the lump, it will be moving along with the breast tissue, and also the skin also will be moving along with that. Okay, so those things you have to be very clear. Now, when you put the pectoralis major into contraction, you mean to say the mobility is restricted.
Yes.
That's what. So the pectoralis major is involved. Will it independently alter the stage? Okay.
Here you have, when you talk about mobility on contracting pectorals, you do it in two directions, parallel to the fibers and perpendicular. So that also you have to check, which is more relevant.
It's perpendicular to the.
No.
It will be
Along the direction of the fibers. That is the more important finding. Okay.
Yes,
And
if the muscle is involved, the perpendicular movement will still be possible. Okay. Because the fixity is only to the muscle. Okay, the lump is in the breast tissue. It is just going and involving the muscle. Okay, it's not entirely intramuscular. So the perpendicular movement will still be present. Okay, even if yes.
this again, one statement you have made here: skin over the lump in the periareolar region. What does that mean?
here where the puckering was not there it was not properly, it's not pinchable.
So then you have to be specific because periareolar is I mean, it's a circumferential around the areola. That means the entire skin. If it is in one quadrant, then you have to mention that in that quadrant, in the upper outer or whatever it is, how many centimeters beyond.
Internal skin not pinchable directly.
What is the pathophysiology of orange skin appearance, purely orange?
Malignant cells which are infiltrating the dermal lymphatics.
So what? Causing?
Blockade of the lymphatics.
Yes. So blockage of lymphatic.
There will be edema.
Edema, skin.
Systemic.
So here also a little bit more clarification is needed for axillary lymph nodes. You can mention which are the group of lymph nodes involved. You cannot just tell multiple and just leave it. Okay, so what are the you have any idea what are the group of
Central quadrant lymph nodes and anterior group of lymph nodes.
that you can mention, no? Okay, that you should mention. Whether it is how many nodes, whether it's mattered or not. Those things. Individual group you can mention.
What are the groups anatomically?
Anterior group of lymph nodes, posterior group of lymph nodes.
Where are they? Anterior, where are they?
Pectoral, along the pectoralis major muscle, and posterior group of lymph nodes are along the subscapularis muscle.
See, you are a student of anatomy. Yeah. So when you describe the location, you have to be precise.
Along the
Pectoral is major as the medial border, lateral border. You have to say clearly at which border do you feel the lymph nodes. Anterior,
along the anterior axillary fold between the anterior
just behind the lateral border of pectoral. Then major.
and the posterior group of lymph nodes along the posterior axillary fold will be feeling.
That is formed by,
Those are the level 1 lymph nodes.
no, that is formed by which node? Posterior axis,
Subscapularis.
subscapular.
Latissimus dorsum.
Then,
Then the central group of lymph nodes.
where are they from?
They are in between the anterior and the posterior axis. The central aspect of the axilla will be able to feel. Then the lateral group of lymph nodes and the apical group of lymph nodes.
How do you palpate for apical group?
This apical group of lymph nodes, we have to insinuate our fingers deep into the axilla, and we have to palpate in the arm with the relaxation of the axilla of the patient.
Charlie, how do you palpate for apical group?
The examining hand should be lying over the examiner's shoulder. And we have to insulate the opposite deep into the axilla so that it
Deep means what? How do you,
apex until the apex of the
how do you know you are in the apex?
head of humans.
Head of humans. You have to put one hand in the supraclavicular, right? And the other hand deep into the axilla, and you have to feel between the two hands. That is the way to palpate for the apical group, because they are, where are the apical groups situated? Anatomically, where are they located? Hmm?
Above the pectoralis meniscus.
Above means, you don't use above in anatomy. Where are they located actually? Where is the apex of the axilla? If you don't know, how will you palpate? Medial to the what is that? Muscle constrict muscle. Pectoralis minor. Okay, so it is high up in the axilla. What we call level 3 when we operate. So that is not something that you can just put your hand and feel, because it's deep in the axilla. Okay. What about the other axilla you have not mentioned, contralateral axilla? Isn't that relevant?
intraclavicular group of lymph nodes became formed in the rest. So it's just basically bimanual palpation of members.
The inspection, not just a few with the hands. Just finish the breast, then you go for the arm and other thing. There's a edema of the ipsa happen, but make it a systemic, otherwise you might forget. So if you are looking at the breast and then you're looking at the mass, then you will describe over the biopsy or other thing. Then there's a edema of the ipsa and limb becomes try to avoid it. Just make it systemic, it will be easier. And any relevance of no dilated veins?
Really seen pilots tumors where the rapid
What is the eczema? Particularly you're looking eczema somewhere?
pages. The various cases where you'll be seeing the eczema complex.
You don't mention the eczema, but the skin changes or anything that's eczema is a differential diagnosis.
Systemic examination. Summary of my examination: a 40-year-old premenopausal lady presented with a breast lump of 10% centimeter hard lump in the left breast, the left axillary lymphadenopathy with no features suggestive of metastasis. My diagnosis is carcinoma of the left breast, clinical staging T4B N1 MC.
You can add some more information also that might be helpful. 40-year-old premenopausal multiparous premenopausal lady, multiparous with no significant family history. So this gives more information. And why do you say it's T4B?
It is involving the skin uterine difference.
So what are the clinical features are suggested of T4B?
Involving the satellite nodules, ulceration,
what is T4A?
involvement of the chest walls.
What do you mean by involvement of chest wall?
It's involvement of the intercostal serratus anterior. Involvement of the ribs.
Pectoralis major muscle? Pectoralis major muscle is not considered chest wall. What is the N1, N2?
N1 these are the mobile ipsilateral group of lymph nodes partable in the axis.
Ipsilateral mobile is 3 centimeter ipsilateral mobile. What is the N1? What is N2 clinically?
Sir, N1 is mobile ipsilateral non-weighted axillary lymph nodes present in the ipsilateral axilla.
Usually up to 2 centimeter you can say this N1 no. But more than 2 centimeter it becomes normal. Usually call it as N2. Fixity most and M0 clinically.
Yes, sir, clinically. I want to proceed with basic investigations in hemogram and selectrolytes and elective application.
Diagnostic.
First, I want to do the bilateral breast mammogram. The first view is showing the craniocaudal view, and later it is showing the mediolateral oblique view. The mediolateral oblique view, we can see the skin changes noted over the ipsilateral region and the axillary nodes. Axillary nodes are noted. Next, I want to do a true cut biopsy from the lesion. Here the true cut biopsy report. It is showing the invasive breast carcinoma, most special type, grade 2 score 7. Receptor status was ER positive, PR positive, HER2 positive, and the K60 is almost 14%. Next, I want to proceed with C.
Why did you do mammogram?
To see the multicentricity of the disease. And this
In
case,
this
see,
situation, are we worried about it?
in this situation, we want to, since it's a T4 state, T4 disease, I want to neoadjuvant chemotherapy. So I want to see the response after the neoadjuvant chemotherapy. Prior to chemotherapy, I need a mammogram to compare the response after the chemotherapy, after giving 2 cycles of chemotherapy. Sir, age is 40 years. So what?
You can get the patient relation. No, if you want to certain the size reduction, I mean the response, only if you want to know the size, then very well do an ultrasound.
What are the, in other words, what are the findings that you expect to see on a mammography versus ultrasonography? And what is your first?
Microcalcifications and it's architectural distortions.
So, why do we prefer ultrasound in younger women and why we prefer mammographies in older women?
Because younger women will have dense breast, so we'll be falsely will be identifying the glandular. In the mammogram, also will be identifying the glandular tissue as a hypertranslation compared to the breast carcinoma.
What are the types of mammography that you are aware of? Can you go back to the film? So what are the various kinds of, what are these views of mammography?
First one is the cranial caudal view,
Okay.
and next one is the middle lateral oblique view.
Is it an adequate mammography for you to take a decision based on this? And how, when do you call a mammography adequate? What areas should we be able to see? Like you have to decide whether what kind of surgery, to what extent, whether there's BCS or not. I mean, based on the appearance on mammography, right? So what areas do you expect? Is the posterior inclusion adequate in this? We can't see the pectoralis in
Posterior.
CC. So we can see axillary nodes clearly. And how do you, what other findings do you see in the skin? How do you make out that it's skin edema or beauty orange is confirmed on mammography?
Here,
Look at the skin thickness. So you can also make out on CC view the nipple, I mean, if of course to an extent even on MLO view, the nipple retraction, and these all confirm your findings. Especially sometimes you can actually see the tumor infiltrating along the ducts and you can see the pattern of pulling in. So just to name, what are the types of mammographies that you're aware of? The conventional mammography and digital mammography. And what kind of digital mammographies are we having? What is the latest technology in digital mammography that we have? So we have 2-dimensional, 3-dimensional. This is the print, 2-dimensional print. We have 3-dimensional mammography, which is called as breast tomosynthesis, where the radiation, I mean the exposure goes in an arc manner. We're able to move in and out of the breast, and we're able to see even the smaller lesions that we're not able to see on 2D, because on 2D there is compression and there is an overlap of tissue. So that is called as the breast tomosynthesis, or in other words, 3D mammography. So that is available in many parts of India.
Would you like to see the other breast?
yeah, because I didn't include them, but
No,
like,
for what? Why would you like to see that?
to see for the lesions with the breast, like clinically
That
not.
affect your stage? Staging? your lesion in the abdomen? Will it affect the way you approach the management?
Yes, ma'am.
That is the main reason you do sonogram in this situation. Okay, to see if there is any disease. Okay, proceed.
Next, I want to do a CECT thorax. Next, I want to do a CECT thorax abdomen pelvis for the patient. This is the image which is showing the lesion which is involving the skin and involving the pectoralis major muscles. And here we can see the multiple axillary nodes present in the ipsilateral axilla. Next, I want to do a bone scan for the patient. The bone scan was showing no evidence of osteoblastic skeletal metastasis. Next, I want to, since it is a locally advanced breast carcinoma, I want to consider an neoadjuvant chemotherapy for the patient.
What do you look for in the CT of the abdomen?
You will see liver metastasis over there. And followed with that nodes present in the
Yes. Do you get abdominal in breast carcinoma commonly? What can you get in it other than liver metastasis?
peritoneal deposits.
Any other organ is involved, especially in a spinal deposit?
Ovaries,
What are they called?
Gutenberg tumor, transient.
Do you want to give neoadjuvant?
Chemotherapy for the patient.
What regime do you do?
If I want to do this 3 cycles of 5-fluorouracil, epinephrine cyclophosphamide, and 4 cycles of docetaxel. FEC regimen, 3 cycles of 5-fluorouracil, epinephrine cyclophosphamide, and 4 cycles of docetaxel. Currently, following research now.
And what about HER2 targeted therapy?
This trastuzumab also I want to give and see for the response. If it is not responding, you want to add particular. Also,
What investigation is necessary before starting adriamycin, eberubicin, and trastuzumab?
echo was noted because there are cardiotoxic drugs. This Adrian was
What in echo is specifically?
we are looking for the this level ejection fraction and the related cardiomyopathy features are there.
Can you give FEC and trastuzumab together? Or generally, how is it given?
It is
Vaccines and trastuzumab.
axis and trastuzumab was combined.
These two cardiotoxic drugs you cannot combine. Okay, so how long will you continue trastuzumab?
This trastuzumab course should be continued for 1 year. Should be 3-weekly regimen should be given 1 year.
In other words, how are you going to counsel the patient? Like, what will be the plan? If I'm your patient and I come with this disease, so how will you explain to me that how will the treatment be carried forward?
We will be explaining the patient that we will be giving a cycles of neoadjuvant chemotherapy. Following the 2 cycles, we will be assessing the response.
Why do why do we start with neoadjuvant chemotherapy in this patient?
Since it is a T4 lesion and a node positive locally advanced breast carcinoma, I want to get the pathological clearance, pathological complete response, and since it is a large tumor, so we want to achieve the shrinkage of the tumor also.
So you're expecting pathological complete response for this patient?
No, since
I'm a patient.
I want to just downstairs.
Undergo surgery first. Doctor, I want to undergo surgery first. Can I skip chemo and or maybe take it later? What are the advantages of giving it now?
We want to downstage the stim because it's a large lesion with the total positivity. We want to tackle the systemic metastasis also.
But doctor, we have done CT and bone scan, there are no metastasis.
Micrometastasis will be far possible, so that we want to tackle by giving the ancient.
Can I not do the same thing after my surgery?
Not in this case.
Like, in other words, how will you, what are the different, why are we preparing your joint? One thing is operability, the other thing is the risk of having micrometastasis and what you extrapolate, what is the disease-free survival versus overall versus between neoadjuvant and adjuvant. That is what you're going to tell the patient, right?
One more advantage is, if you give the chemotherapy upfront, you know that this is a chemo-responsive tumor. You know that this tumor is going to respond to these drugs. You give it in the adjuvant setting, you cannot really gauge the response. That is one of the other benefits. So your decision to treat or your decision to make a plan of management will have to be a multidisciplinary discussion, right? Taking into consideration all the other things. Okay. So what is, you said downstaging, right? So what is the aim of downstaging to do in this situation?
We can reduce the reduce the size of the lens, but it is amenable for excision.
No, you mean you want to make it amenable for breast cancer patient?
This one not preparing for breast cancer.
So what do you mean by excision?
This patient, we can plan MRI for that. Since it is huge lesions, we can reduce the size of the lesions, we can achieve the flap. We can reduce the skin flap closure to achieve the closure.
Margin negative.
Margin negative.
You have given neoadjuvant treatment. How do you assess the patient? How frequent you want to see the patient?
Sir, every after 2 weeks, after 2 cycles of chemotherapy, after 3 weeks gap of the 2 cycles of chemotherapy, we will be assessing the response. Every cycle of chemotherapy, clinical examination of the size of the lesion can be done. If the size of the lesion is not clinically, it is not reducing. After 2 cycles, we can confirm the mammogram compared to the previous mammogram.
When you say the patient is a responder,
Sir, we'll say it as a partial response if there is more than 30% reduction in the size compared to the previous lesions. And if it is a progressive disease or if it is more than 20% increase in size of new lesions are okay. Non-responder if there is less than 50% reductions. Complete response, if clinically there is no lump and axillary roots are complete response.
the patient wants to tell you that I want my breast like structure. So what are the options you want to see?
This patient will go for probably since it's a T for we consider modified medical mastectomy with accent dissections. Following that, we can advise the patient at the same setting also we can consider for a flap or an LD flap or a trap flap. Or if you're not planning for a flap or you can keep it tissue expanded in the subepidural plan. It depends on the options. I discuss it the multidisciplinary treatment based on the plan of the
Don't tell about the tissue expander. The patient will be needing radiations. So radiations are contraindicated. Yes, the other flaps are fine. You can do immediate reconstruction. You can do secondary reconstruction after a condition of treatment, but not tissue expanders. Okay, thank you. You have done a good job.
Thank you, Sir, for that informative session. I now request the examiners to award the certificate with presentation to Dr. Sai Kiran. Dr. Shalini. I now request Dr. Indian Samarism to felicitate Dr. Venkatesh SP. Thank you, sis.
Next on, we have a panel discussion on carcinoma stomach, current concepts in management, which will be moderated by Dr. Indian Samarisam. As we all know, Dr. Indian Samarisam is the head of Upper GI Surgical Unit in Christian Medical College Hospital, Vellore. He has authored more than 80 journal publications and book chapters. Sir's area of special interest include benign and malignant diseases of the esophagus and stomach and advanced laparoscopic surgery. I request Sir to go on to the dais for this session. I also request the panelists for the session, Dr. Ramkumar Ji, Dr. Biswajit Dubashi, Dr. Parnivel M, and Dr. Devashish Naik to proceed to the dais.
Very good morning to you all. And welcome to this panel discussion on carcinoma stomach. So if you can have a presentation.
Open this presentation, bro. No, that was a laptop. Once the screen is shown. That once it's short.
So at the outset, I'd like to thank Vishnu Prasad and the organizing team for inviting me. So what we'll have in the next maybe half an hour, 45 minutes is looking at the current concepts in the management of carcinoma stomach. So we've got our eminent panelists here, so they need no introduction. So, the questions, Dr. Parnivel and Dr. Thank you for joining us. So, how I'd like to do this is basically we'll have two case scenarios. One is a early gastric cancer, and the other one is a locally advanced. And if we have time, we can just discuss about metastatic gastric cancer. So, if possible, I'd like the students here also to get involved so that it's more interactive. It's just not sort of questions here and there. So our first patient is a 60-year-old male. He presents with dyspeptic symptoms for the last 5 months. He's had a trial of PPIs outside. He's had no improvement. He's then had an ultrasound of the abdomen for his dyspepsia. Which did not reveal any gallstones, and clinical examination was also unremarked. So this patient went on to have a gastroscopy for his dyspeptic symptoms. So this is what was seen on the endoscopy. So you can see that there is a lesion in the near the pylorus of the stomach in the antrum, and it was a very small lesion, a 1.5 centimeter elevated lesion in the antrum. and the rest of the stomach was normal. Okay, so basically, it's a very early gastric cancer. There is no ulceration at all. Now, biopsy, unfortunately, this came as a well differentiated adenocarcinoma. So this is the case scenario. So, with this in mind, I'd like to ask Dr. Palegan, with regards to early gastric cancer, what's the role of narrowband imaging? Obviously, what we saw here is just a normal endoscopy. This narrowband imaging, and when would you advocate something like this, and what are the actual findings that you would say in narrowband? Yes.
So in this case, we have identified a lesion, a small lesion in endoscopy. So now with the improvement in endoscopic technologies like image enhanced endoscopy, one of them is narrowband imaging. It is different from conventional endoscopy in that it uses an optical filter where a narrow spectrum of light, like 415 to 530 nanometer, is used to enhance the surface pattern as well as the vascular pattern. So in case of mucosal irregularities that are picked up on a standard white light, we can use magnification and use these optical filters and enhance the surface pattern and vascular pattern. For example, in the slide, you can see a well demarcated line, and the center of it has abnormal vasculature. The vasculature is pronounced. Generally, the normal glandular pattern of antrum is different from body of the stomach. So they have the normal pattern. So when that normal pattern is different, like in body of the stomach, we have honeycomb appearance, whereas like tubular pattern will be normally seen in antrum. So in this, you can see a circumscribed, well demarcated lesion with pronounced vascular pattern. So, so this is the history of early gastric cancer. Provided, like on further imaging, we just go on to prove that it is limited to mucosa or submucosa.
Sure. So basically, for the students, what you look at is the surface and also the microvascular pattern, as was mentioned. And obviously, you can do targeted biopsies when you do this. So if you see an abnormal mucosa, so you can take targeted biopsies using narrowband imaging. Now, sir, again, chromoendoscopy. This is also something that can be done for early gastric cancer. For the benefit of the students here, can you just tell us a little bit about this?
In this, anyway, what we were speaking earlier is a virtual chromoendoscopy, where dyes are not used. Just by the switch of the button, changing the filters, we see. Whereas earlier, people were using dyes like indigo carmine, which accentuates the surface pattern so that any irregularity comes out prominently. And there are also some dyes like methylene blue, which are actually picked up by columnar cells. So any irregularity in the cell or the vascularity can be easily picked up by these dyes.
So are these being used now, or are they being sort of, historical nowadays?
The thing is, like, screening for these lesions are most of the times picked up on screening thing, or like in patients with elderly dyspepsia, we accidentally, so we usually do not do, but we have narrowband imaging. We do narrowband imaging.
So if you have narrowband imaging, it's much better, but in picking up these lesions. But in the absence of a narrowband imaging scope, this is something that you can do. And for squamous cell carcinoma, correct me if I'm wrong, is Lugol's hybrid. Yeah. So if you have a squamous cell carcinoma of the esophagus, then perhaps Lugol's iodine is the dye that you would use. Whereas in the stomach, you would use these two dyes. So we'll move on. So this patient has been biopsied, has got a adenocarcinoma. So again, what is the role of endoscopic ultrasound? Basically, obviously, for early gastric cancer, again, this is not something that we see on a regular basis. This type of patient is very rare. So I'm just taking this example for an early gastric cancer. But sir, if you can tell us the role of endoscopic ultrasound in such
this scenario is common in countries where a lot of screening for gastric cancer goes on, like in Japan, where gastric cancer incidence is more. The role of EUS in 2002, at least in early gastric cancer, is to identify if the lesion is located to the mucosa or submucosa. Irrespective of lymph nodal involvement, it is actually an early gastric cancer. So to decide on treatment modalities, like whether patient can be subjected to endoscopic resection or whether the patient needs a gastrectomy, can be decided based on the EUS findings. And there are two types of EUS scopes. One is the radial EUS scope. The picture here is the picture that has come out of radial EUS scope. There's also another scope which is linear echo endoscope. The advantage of linear echo endoscope in case of nodes, FNA can be done using a linear echo endoscope. So in early gastric cancer, to decide on treatment modality, whether patients are amenable for endoscopic resection or patient need the gastrectomy, EUS has a role. Also, EUS today in 2023 to decide on selecting patients for neoadjuvant in case if there is muscular ectopia beyond locally advanced disease also, it helps in scale. But having said that, with the multi-detector row CT and multi-dimensional CT is available, the EUS in T staging is actually on par with other imaging modalities. For end staging, maybe if FNA is added, there may be a slight superiority in EUS.
Sure. Dr. Prabhashan, would you like to add anything more with regards to endoscopic ultrasound?
This for early gastric cancers, I think better for staging T1, T2 lesions, endoscopic ultrasound is good. And beyond that, CT does most of the job.
Yeah, so basically, as shown here, you've got the different layers of the stomach, which can be delineated by the radial scope. And if there is an early lesion, this can be picked up by an endoscopic ultrasound. And so that is the overall diagnostic accuracy for the T stage. It can vary anywhere between 60 to 88%. And for the end stage, it's a little bit more. And of course, if you have nodes that can be biopsied as well, if you use the appropriate scope. So this particular patient had US, and this was 1.5 by 1 centimeter lesion. This was confined to the mucosa. So basically, it was a T1A lesion. So I'm sure you all know what is T1, T2, T3, T4. And in T1, T1A and T1B. Okay. So T1A is when it is confined to the mucosa, T1B when it goes to the submucosa. So this patient had a T1A lesion. The muscularis propria, which is T2 layer, was intact, and there were no nodes seen. So that is the report of this patient. It was a well-differentiated adenocarcinoma. There was no ulceration, and it is clinically T1A and 0. And this would qualify as early gastric cancer. And I'm sure all of you know what is early gastric cancer. Okay, so early gastric cancer is what? Anybody who wants to put up their hand and answer? What is the definition of early gastric cancer? Yeah. Yeah. So basically, T1A and T1B with what did you say? Without involvement of muscularis propria. So basically, this T1 tumor. This is defined as a tumor involving the mucosa and submucosa. Okay, with or without nodal involvement. So the nodal involvement doesn't matter. Okay, so this is the definition for early gastric cancer. So if you have something like this, what would your plan of management be? So this patient has got a T1A N0 lesion based on endoscopic ultrasound. So what are the possibilities? How would you manage this patient? Sorry? Okay, so you can do endoscopic surgery. Probably that would be the most appropriate if you have adequate facilities and the appropriate experience to do it. So, sir, would you agree with that? So basically T1A and 0, very rare to get somebody like this. Maybe you'll see this patient, something like this, maybe once a year. So what would your plan of management be for this patient?
If expertise for endoscopic resection is available, which is the most important thing, like patient can be subject to endoscopic resection. There are two different types of endoscopic resection. One is endoscopic mucosal resection. Other one is endoscopic submucosal resection. So the general indications for an endoscopic resection would be, as in this case, lesion less than 2 centimeter, a lesion which is well differentiated, because we saw the biopsy as well differentiated adenocarcinoma without any ulceration. So these are some of the like if there is no lymphovascular invasion, and if there is absence of nodal involvement, which we can in preoperative staging, if we can definitely, or if there is a suspicion, there is no suspicion of the lymph node involvement, these patients can undergo endoscopic resection. So
yeah, so I mean, basically, I think sir has explained it beautifully. So basically, well differentiated, less than 2 centimeters, and when there is no ulceration. So these are the three sort of criteria that you would look at. And if you have something like this patient is suitable for endoscopic resection. Now, what type of endoscopic resection you would do? Preferably
EMR would be.
Yeah. So just tell us a little bit, just for the benefit of the students. So what is the advantage of doing an EMR?
EMR
ESD is better. So why would we choose that?
For lesions which are smaller, endoscopic mucosal resections are preferred. For lesions which are larger than 2 centimeters, generally an endoscopic submucosal resection would be required. Endoscopic mucosal resection compared to endoscopic submucosal resection (ESD) is like less expertise is required. There are different techniques, basically like injection and snaring of this thing, using a cap, suction and resection of the lesion. It takes less time, and there are less complications with EMR because there is no deeper resection involved in EMR, so less chances of bleeding or perforation. The only thing is when the lesions are larger, en bloc resection cannot be achieved. So even for larger lesions, some people advocate piecemeal resection. So whereas in ESD, you can achieve an en bloc resection, larger lesions. So histopathological examination can be done in great detail. The complications are more, and it requires more training and
expertise. Yeah. So basically, so that's basically the difference. So essentially, endoscopic submucosal dissection is preferable than endoscopic mucosal dissection because it's more deeper. Obviously, you can take larger, but you need more expertise. And of course, it also depends on the site. You need a very favorable site to do an ESD, whereas EMR maybe you can even manage in difficult sites. So then moving on, what is the role of surgery in a patient with early gastric cancer? So if it is T1A, then you can do this endoscopic type of resections. Whereas if it is T1B, which means that if submucosa is involved, then obviously, as you can see here, you will have to look at surgical sort of resection. And this picture here, sort of the area which is shown in green, probably are indications where you may have to go on to some sort of at least localized surgical resections because of the depth of the tumor. Again, why you decide this is because as the tumor gets more and more deeper, the chances of lymph node involvement is there. So when you do an EMR or ESD, you do not address the lymph nodes. Because if it is T1A disease, the chance of lymph node involvement is less than 10% or even 5%. Whereas if it becomes T1B, it shoots up to more than 20 or 25%. So you have to address the lymph nodes if it is more than T1A. And therefore, you cannot stop with endoscopy. What type of resection you will do? Do you need to do a total resection like how you would do for a D2 lymphadenectomy? Perhaps not necessary. So this is an area where you can do organ preserving, like you can do local resections. So this does not require a standard D2 lymphadenectomy. And maybe, but if you want to just say a little bit about the surgical options available for something like this very early, let's say T1B lesion.
Depending upon the location now, for distal lesions, distal gastrectomy and the D1 dissection. If we are planning for surgery, would be enough for such cases.
Yeah. So you don't need to do it's not necessary to do a D2, a D1 or a D1 plus is enough, which is basically addressing the lymph nodes. And if you can even go a little bit lesser than that, where you can do organ preserving, like in terms of just local resections. And what type of local resections? Basically, this is where sentinel lymph node plays a role. So if you have the facility or if you have this is something that is routinely done, it makes it more easier. But as far as the students are concerned, you probably need to know about this trial called the Senorita trial, where they used ICG and also a radiopaque tracer, and they were this is a Japanese trial, and essentially doing organ preserving. So if you look at the picture here, if you have a lesion on the left of the screen, that's along the data curvature there, you see which nodes are involved, and you can do a local resection. You don't even have to do a subtotal gastrectomy. Similarly, if you look at segmental resections can be done, and you can even also do an endoscopic procedure along with a sentinel node. So suppose if it's a T1A lesion along with one lymph node there, then you can resect it endoscopically, and you do a sentinel node biopsy, and then laparoscopically or by open technique, you can remove the lymph nodes outside the stomach. So all this is possible. And this trial, what they did was they compared the results of doing organ preserving surgery for this early gastric cancer compared to a traditional resection, and they found that the results are comparable. The long-term results are comparable. So this is the advantage of doing sentinel node biopsy. So the role of sentinel node biopsy, I think, is much more in early gastric cancers, not so much in the routine advanced gastric cancers that we normally see. Okay, so we'll move on. So that's basically the summary of early gastric cancer. So basically T1A, T1B, with or without lymph nodes. Endoscopic ultrasound has got a key role in staging. If it is T1A, then you do endoscopic resection alone is adequate. Okay, and ESD is better than EMR. If it is T1B, N0, then perhaps a T1 gastrectomy or sentinel node navigation surgery. Or if you have T1 with positive lymph nodes, so mind you, you can get early gastric cancer with positive lymph nodes which are picked up on the scan, then perhaps you have to do a T2, proper T2 gastrectomy. All these patients, you need to screen for H. pylori because that is one of the things that can be associated. And if tested positive, again, majority of this data is coming from the East, basically Japan, Korea. So they routinely screen for H. pylori and give H. pylori treatment if positive. And these patients need lifelong surveillance. So that's in a nutshell about early gastric cancer. So we'll move on to the next patient, basically a 34-year-old female who presents with weight loss and loss of appetite, epigastric abdominal pain for a month, and one episode of black stools, no other comorbidities. So that is the history. And this is fairly often looking ulcer in the stomach. So this patient had a biopsy and it as expected came as a poorly differentiated adenocarcinoma, and there were also signal cells which were seen. Okay. So with regards to the endoscopy, this question to the students, okay? So where will you do the biopsy? How many biopsies and how deep will be the biopsies? Any volunteers? How many biopsies? Where will you do the biopsy? Suppose you get an ulcer like this. Which part of the ulcer will you take the biopsy from? Everybody? Somebody from the back? So where will you do the biopsy? Will you do it from the center? You will do it from the periphery? You will do it from normal mucosa? Where will you do the biopsy? Sorry? Anybody? I've given you the choices. So it's from the center of the ulcer, from the edge of the ulcer, or from. Yeah. You'll do it from the edge of the ulcer. Why not from the center of the ulcer? Okay. So is that right, sir? So basically,
Generally, it is taken from the margins or the edges of ulcer. There will be necrosis slough in the center. Like it will be not eating like when we go for those areas. So and the number of biopsies, can I just?
Yes, please. Yes.
Number of biopsies usually advises 6 to 8 biopsies. Because it has been shown clearly that if 6 to 8 biopsies are taken, the sensitivity of getting a diagnosis is more than 98%. But this lesion is obvious, but there are cases where the aggressive forms of cancer where the mucosa looks normal, where there is extensive submucosal disease infiltrating the muscle, like the linitis plastica. Which is one of the common reasons where endoscopy comes out negative most of the times. Those situations, we need to be careful. We need to use certain techniques like bite in bite or deeper biopsies to get the. And important thing in endoscopy, other things like in linitis plastica, very often their only finding will be poor distensibility of the lumen if you cut in the holes. The other thing is in endoscopy, one has to describe where the lesion is, the longitudinal extent, circumferential involvement. If it's a proximal lesion, we need to say whether G junction is involved or not. It's a distal lesion, whether pylorus is involved. Those findings also need to be documented. And
exactly. So all these are very crucial in deciding what type of surgery you would do. So what about the second question, sir? Suppose you get an obstructive lesion, let's say at the gastroesophageal junction or just at the proximal stomach, cardia, you're not able to go beyond. What are your options? Obviously, you've got a lesion there, and you've done a biopsy in the proximal part, and it comes back as normal. Obviously, your suspicion is malignancy. So, how would you tackle the situation where the lumen is obstructed by you?
Generally, what we do is if the lumen allows a thinner caliber scope, like a nasal endoscope or a pediatric endoscope, we just cross the lesion without dilatation and then go and see how the extent of the lesion, the proximal and the distal extent of the lesion. For biopsies, we just dilate the lesion and then take biopsies from the lesion. Sometimes brushing also can be used from the lesion, but we think the yield is less and compared to biopsies.
Yeah. Would you do any like dilatation?
Yeah, we do dilatation, but not aggressively to end up in perforation. We just do dilatation minimally so that will help us in taking biopsies, at least to pass the conventional gastroscope 9.2 millimeters and then take biopsy.
Yeah. So if asked in your exam, basically the options are: one is you put in a smaller scope, a pediatric scope. You can do balloon dilatation very gently to allow at least a pediatric scope to go in. Or of course, brushings which are not so very sensitive in your diagnosis. We saw the endoscopic features of linitis plastica, so it can look normal. The only feature may be the loss of distensibility. And of course, this is the group where you can get false negative biopsy results because of the involvement of the submucosa without being the mucosa being involved. So again, we discussed this. If the initial biopsy is negative, then let's say if you get an ulcer like this, you do a biopsy, the pathologist says, there's just necrotic tissue, no tumor seen. Then you have to rebiopsy it. I guess you need to go back to multiple biopsies and go to deeper biopsies and bite on bite biopsies as we described. Now, the different types of histology, the differentiation, etc. So I'm not going to go into the details of this, but essentially the interstitial and diffuse type. the intestinal type being the better one. And of course, this patient had signet cells, so you should know that this is the diffuse variety of tumor where you get these signet cells, significantly worse prognosis as compared to the intestinal type. So this is all well known. Now we'll move on. So this patient now has had a biopsy, has now got a poorly differentiated mucinous adenocarcinoma with signet cells. So, Dr. Debashish, what staging investigations, just list out the staging investigations that you would do for this patient?
In this patient, I would go for a CT, contrast enhanced of thorax, abdomen, and pelvis to look for the local extent of the tumor, to look for regional nodal status, any metastasis which could be picked up on CT, be it peritoneal or in the liver. Ascites can also be seen on CT.
So CT scan, anything else? So CT scan to look at the local extent of the disease and to look at any obvious spread.
MRI in case of any suspicious lesions in the liver to characterize it better.
So if necessary, if there is a doubt, we can look at an MRI.
And for PET CT, there is as such no recommendation. But since most of around 50% are non-FTG, FTG non-avid, because they lack this GLUT1 transporter, they have lower expression of GLUT1 transporters.
So PET CT scan, not a routine investigation. So the investigation for staging is a contrast enhanced CT scan of the abdomen. And of course, a staging laparoscopy if this patient is going to have neoadjuvant treatment. So we'll go into a little bit of more detail for this. Dr. Ramkumar, please can pitch in now. So this patient is going to have a CT scan, CT scan of the abdomen. So firstly, does this patient require a CT scan of the chest abdo-pelvis or just abdomen pelvis? What would be your institutional preference?
Here we do practice doing a chest with abdomen. But abdomen we do a dual base. Chest is including one of the bases. Generally in the total base, we include the chest also as a means to stage. Basically, we are doing a stage which is to look for lung metastasis and mediastinal nodes, and to see possible abdomen nodes also. So that is included when we do a chest. And
so, what is the protocol that you would follow for this patient or for a patient with carcinoma? What is your CECP?
Two things which I would like to emphasize. One is distending the stomach. So what we use here is a negative contrast. We use water to distend the stomach. It is 500 ml of 800 ml of water is given. That's before we take out the patient for scan. So that the stomach is adequately distended. The whole problem is if we non-distended stomach, it's difficult to delineate the exact area of vertical actually, and even the mucosal folds can mimic like vertical. So adequate distance of stomach. Second is doing a multi-phase CT. One is the arterial phase, the late arterial phase for the knee, where the tumor enhances much better. We also look at the vascular anatomy to see for any variant vascular anatomy plan for the surgeon. And then we do a second phase, the venous phase, around 70 seconds, where that's where we include the chest circles, the entire abdomen pelvis to see for nodal disease and metastasis.
So basically, you said you give negative contrast. So that is your so basically that would give you a good delineation of the wall of the stomach as well. As far as the contrast that those that we give in our institute, of course, we do an arterial phase, as you said. The arterial phase also helps in delineating the vascular anatomy. Sometimes that would help, particularly if you're doing this operation minimally invasive, then it is good to know if there is any vascular anomaly present in this patient. What about the position, supine versus prone? I mean, you sort of select this.
So not as a routine, we do initial scan is done in super. Sometimes when there is a doubt, a lesion, there is a doubt that there is infiltration. Scan where lesion just double stay about, and we do. Sometimes we do. After looking at the spine scan, we do a prone or sometimes a lateral to see to separate the stomach and see whether there is actually involvement or infiltration.
Sure. So basically, supine picture like that is routine. If it is arising from the posterior wall, particularly if there is doubt of infiltration of the pancreas, then you would do a view as well. So this is the CT scan picture of this patient. So would you like to comment on this one, sir?
Basically, the role of CT is to see for the local extent. And we do have a limitation in differentiating T3 from T4D. But T4D involvement of adjacent organ, then it is obvious. So that is one area where there is a limitation in CT. So basically, you have to look for the surface, the serosal surface of the tumor, whether it is smooth or there is any evidence of extra serosal extension, or there is a perigastric fat stranding that is on about the tumor, and then the longitudinal extent of the tumor and the circumferential extent of the tumor in the stomach. That is what another thing we comment about. So, like in this case, you can obviously see that the tumor is, you can just distal to the tumor, actually, you can see the gut signature of, you can see the hypointensity of mucosa, which may not be evident in all places. Again, depends on the degree of distinction. But this tumor is definitely involved, it looks like involved all the layers of the stomach. And the only thing is the surface looks relatively smooth, though at some point it seems to be in contact with the transverse column.
Sure. And there is some fat stranding as well, I guess, in this area here. So this patient at least has got T3, got T4A, T4A list, M0 probably. Okay, but there is a doubt of whether there is this mental deposits. Again, as sir had mentioned, basically standardization of radiology reporting, the T stage, N stage, the peritoneal disease. One needs to look at distant metastasis and the vascular anatomy as well. Now, with regards to malignant lymph nodes, what are the features that you would say this lymph node looks more malignant, this lymph node looks more benign? In addition to the size of the lymph node, is there anything that you would say or look at?
Yes, again, commenting about the new lymph nodes in CT is always a challenge. One is the size criteria, which we say 6 mm for perigastric for more than 8 mm. But more than the size, one is to see the node is looking rounded rather than looking a wide shape. So if it looks rounded, if it is more enhancing, similar to the primary tumor, or if it is showing its features of heterotherapy like areas of necrosis inside, and all these point towards a malignant.
And fatty hilum probably more than
Fatty hilum,
yeah, more benign rather than malignant. So basically, the size of the node, the shape of the node, whether there is a fatty hilum present or not. And of course, this quite often question arises in the MDTs. So if you have a lesion in the liver in a patient with such a tumor, then the question of the doubt of whether this is benign, malignant, and if there is still a doubt, then the role of MRI. Can you just tell about the role of MRI in such situations?
Honest, because we do a dual phase imaging, most of the times we'll be able to confidently diagnose a melanoma because of its typical enhancement with peripheral puddling, interpretal filling with paralleling the blood flow. So if it's a very typical hemangioma, you may not have it out. Again, cyst, if it's relatively larger based on the attenuation. Sometimes we actually in our institute will go back and do a targeted ultrasound to make sure that it is a clear cyst and a good cyst out. But there are cases where we still have doubt. So that in such cases, MR definitely will help, especially a diffusion weighted imaging. If there is diffusion restriction on MR, we take it as a study.
Sure. So CT scan, if you're still in doubt, you can do ultrasound screening, which is if I'm right, it's more for the surface lesions, right? The
Sometimes there are very small lesions where there's a doubt of cyst, say subcentimeter lesion. Just target, see the lesions segment in liver, go on trying to target the exact lesion and see if it is an anaerobic cyst which can be left alone or which needs to be evaluated for the biopsy.
Yeah, and the role of MRI is when it is still in doubt, you can do diffusion weighted imaging with MRI scan. So that might clear the doubt of the liver lesion. Now, in this particular patient, Dr. Pallav, what is the role of an endoscopy? Obviously, for early gastric cancer, we had seen, but for this particular patient who has got an advanced gastric cancer, only 2 months. Okay, all right. What is the role of endoscopic ultrasound?
At least in this patient, I will not see any indication of US with whatever the findings that are available from CT. I don't think additionally, in case if there are nodes where there is doubt, then maybe like if the nodes will further clarify.
Okay, so the role of endoscopic ultrasound. Can I take 5 more minutes, please? The role of because we are not come to decisions at all. Endoscopic ultrasound in early gastric cancer, we've seen to differentiate, to decide on the need, as Sir was saying, T1, T2 versus T3, T4 of adjuvant chemotherapy, neoadjuvant chemotherapy. So we'll move on. I think for want of time, PET scan we saw, we've seen basically it's not recommended as routine staging modality. Staging laparoscopy, yes, has got a role, particularly for looking at surface small volume peritoneal disease. So basically, about 20 to 30% of patients whom you think have got local disease based on CT scan end up having advanced disease if you do a staging laparoscopy. Peritoneal fluid for cytology, yes, when you do a laparoscopy, you send, and normally routine H&E staining is done. You can do immunohistochemistry if there is still in doubt, or cytology. So the role of tumor markers, basically tumor markers do not play a major role in gastric cancer. However, if any of these tumor markers are increased preoperatively, then you can use it for subsequent follow-up after surgery, but not as a routine. I'm sure you all know what is a liquid biopsy. Liquid biopsy is basically something you do from the peripheral blood, where you look at circulating tumor DNA. Now, this can have some particular mutations. So this has a potential in looking at advanced disease for surveillance, and some of these can have targetable mutations, which can be used for treatment as well. So this patient, you go on to look at the treatment options. Now, Dr. Biswajit, now this patient now has got a locally advanced cancer. Now, how would just tell us briefly about what you would decide on this, on treatment of this?
So when we discuss in MDT, I think the primary thing is to look at the general condition of the patient. That's very important. Nutrition of the patient, along with the albumin levels. We need to know whether the patient is in gastric outlet obstruction or not. We need to know whether the patient has active bleeding or not.
Sure.
So these are some few factors which are important to decide whether the patient might go for a primary surgery or for a new adjuvant. Apart from these factors, there are some, finally everything lands to institutional practices. The Europeans generally go towards a perioperative kind of chemotherapy followed by surgery, whereas the East generally they do an early surgery and then they do an adjuvant chemotherapy. So again, it's completely a divide. We do not have very strong proof which one is better than the other. And it will finally go to the institutional practice. And as a part of this, we are trying to run a study to see which is better. The questions which will favor upfront surgery would be a patient who has a complete gastric outlet obstruction. There is some retrospective data to say that if you are having MSI high, they are the patients who may not actually respond too much to chemotherapy, and you could still consider these patients for a upfront surgery. So these are some of those decision making.
And in your institute, what would your personal preference be? You would give neoadjuvant or adjuvant chemotherapy?
So we in our institute it is completely mixed. There are some patients who go for neoadjuvant. Currently, we are doing the trial, so it's getting randomized. But prior to that, it was a kind of mixed thing for resectable. T4Bs we know will definitely go for neoadjuvant chemotherapy, but T3 and T4A is completely a mixed bag in the hospital. So I personally I don't know which is better.
Yeah. So basically, as far as the students concerned, you need to know the different options which are available. There is obviously going to be institutional preference. There is obviously going to be, this is going to depend on the patient, the logistics of the patient, whether the medical condition of the patient. So there is no one answer to this question, but you should know the rationale of doing, if you select this, there should be a rationale of why you're doing this. So we've seen these are some of the trials that you may know or you would want to know about. So basically for adjuvant chemotherapy, RT is generally not necessary or not given as a routine. Would you comment on the role of RT, particularly in the adjuvant phase? Yes.
So I think very rightly put up two studies, especially the ARTIST-1 and ARTIST-2. Looked at chemoradiation, and the ARTIST-1, a subset analysis showed that if they are node positive N2 disease is there, they might benefit from chemoradiation, but that was disproven in the ARTIST-2. Hence, currently there is no role for doing adjuvant RT if you do a adequate D2 dissection. Anything less than a D2 dissection will require a chemoradiotherapy.
Yes. So basically, it's predominantly chemotherapy, either in the perioperative phase or in the adjuvant phase. Very little role for RT. Perhaps one of the indications is when you get a positive margin. In a node positive, very large number of nodes positive, where you don't want to go back in, but has got a R1 resection. So in that particular situation, maybe you would look at the radiotherapy, but generally not. And perioperative chemotherapy, basically, I guess you should know these two landmark trials. One is the MAGIC trial, which is now the latest one is the plot trial. So this is the where they give 4 cycles of chemotherapy prior, followed by surgery, and 4 cycles of chemotherapy after. So I guess you should. These are 2 landmark trials which you should be aware of. So if you have T2 disease, more than T2 disease, okay, so then you would look at giving perioperative chemotherapy. Again, this is something that you will all be aware of. So basically, what is the advantage of giving chemotherapy before surgery? Basically, it downsizes the tumor, it downstages the tumor, it addresses the micrometastasis. It can also help you to assess the sensitivity of this tumor to chemotherapy. Okay, and obviously it is better tolerated than after surgery. So these are the advantages. Like this is common for any cancer, breast cancer, rectal cancer, any cancer. These are the advantages of giving giving neoadjuvant, like giving this chemotherapy before. So our patient has underwent a staging laparoscopy, basically had negative peritoneal cytology, had 4 cycles of HOT, had a reassessment CT scan showing no progression, maybe a partial response. So the patient has been planned for a D2 gastrectomy. So we'll probably finish with this. So this what is the standard treatment for gastric cancer is a D2 gastrectomy with at least 16 lymph nodes being removed in the specimen. Why you need the 16 lymph nodes? Because that will only that many nodes will give you the adequate staging that is necessary. You know the lymph nodal stations. Now, what about the margin? Someone would you want to comment on how much margin you would give, Dr. Balaji?
Margin of at least 5 centimeters
Yeah.
would be preferred, but for proximal lesions where we won't be able to, or distal lesions where a margin of that cannot be achieved, 1 centimeter will be sufficient.
So that's what we sort of look at to get an R0 resection. If in doubt, it is good to do a frozen section, particularly for the proximal margin. Because if the patient has recurrence, then the patient gets dysphagia again. So frozen section of the proximal margin. And I would like to reinstate that having an endoscope in theater is very, very, very useful in this situation, particularly when you're aiming to achieve negative margins. Role of splenectomy.
Unless it is directly involving, or there are huge bulky nodes in the splenic hilum, it doesn't add to any survival advantage.
Yeah. So not necessary. Basically, the standard D2 gastrectomy does not require splenectomy, except when there is involvement of the greater curvature of the hilum of the spleen. Distal pancreatectomy, again, not necessary. So this is station level nodes, and then there's no room for routine resection of distal pancreas. D2 versus D3. D3 means basically where you do a para-aortic lymph node dissection as well.
Mesenteric and retropancreatic nodes. Same, it doesn't ask for no added survival in comparison to D2.
Yeah. So not routine practice. However, in select cases, suppose you have an otherwise healthy, a young, healthy patient, the only thing that would make it M1 disease is para-aortic nodes, then you would perhaps consider doing a para-aortic lymph node dissection after systemic therapy. So it's not standard practice, perhaps under in the trial setting or in very, very, very select cases. Role of bursectomy.
There is a positive tumors, there is a role, otherwise there is no added advantage of the bursectomy.
Yeah, so basically, initially this was part of a standard D2 gastrectomy, but not anymore. So you do not need to, bursectomy is removal of the layer of the fourth layer. It does not increase the lymph node yield, it does not increase this, there is no survival advantage. And actually the concept of bursectomy itself is questionable because it's not a closed cavity. So therefore routine bursectomy is not essential, no survival advantage. Total omentectomy.
T3 and T4 tumors, I would go for omentectomy.
Yeah. So for advanced gastric cancer, yes. For early gastric cancer, like what we discussed, the first patient, perhaps not necessary. Multivisceral resection, again, basically depending on if you are able to do an R0 resection, then perhaps this may be warranted. It may not benefit patients with extensive modal disease also. Reconstruction technique, what is your preferred technique?
Roux and Wine for distal and even for sphagocytostomy, the roux segment is being.
Yeah. So basically a loop and a roux, you should probably know the advantage of one over the other. A roux and wine is better because less bile reflux. And pouch versus this pouch is when you do a total gastrectomy. So if you do a total gastrectomy, whether you do a pouch to replace the stomach which has been removed. Again, not much evidence to say that it is beneficial. Even if it is beneficial, it's only in the early phase, not in. So after a year, then the whatever jejunum is there accommodates for the loss of volume. So not necessary routinely, and there is the literature doesn't say that it's recommended. Open versus lap, again, we've seen that in high volume centers, it is equally can be done with no oncological problem. Now this one we'll skip for want of time. So this patient basically had this is a post-op biopsy report, residual sickle cell adenocarcinoma. So there is residual disease. There is no LVI or BNI. So it's basically YPT1 N0 TRG2. So Dr. Biswajit, now what would you do for this patient? So basically this patient has responded, but not completely. This is the resection specimen.
We have done 4 cycles of float, so we'll complete 4 more cycles of
Yeah, so basically perioperative chemotherapy. So this patient, I would like to ask you one question. So suppose this patient did not have response at all, and if it is, let's say, TRG3, what is the role? I mean, this is just a question that I have in mind. Of what is the advantage of giving the same chemotherapy that you know has already not responded? Would you alter something or do you add on something in your practice to this kind of patients where let's suppose this is, let's say, a T3 in one disease, you know, DRG3 not responded well at all.
The problem in gastric cancer is we don't have any other active drugs apart from the plot. Let's say if immunotherapy comes in, which is there in esophagus, we know that if post NACTRT you do not have responses, you add nivolumab for 1 year, as shown at DFS benefit. So we don't have the data. Probably some data will come up. Hopefully, then we will be.
Yeah. So essentially, right now we just give the same chemotherapy what we gave before, regardless of the biopsy specimen. However, there is probably role of looking at adding other things or changing the chemotherapy if things get available. Why shooting too much? Okay, so I think we'll stop here. So any questions? We'll just finish with questions. I'm sure you may have some doubts or questions in mind. If so, you're more than welcome to ask. Role of tumor regression grading. Basically, it helps us, sir. Vijay, I think you're the right person to.
Basically, in gastric cancer, the pathological CRs are very low. Your pathological CRs are somewhere between 10 to 12%. Unlike in breast cancer, where you have very high pathological responses. So, all the pathological responses may not be the same. For example, if somebody has a minimal residue versus maximal residue, the response rates might be different. So that's why all this new kinds of regression grades are coming up, not only in gastric and colon. You have data even from lung cancer now with multiple. So they are looking at stratifying those responses better and seeing whether all of them survive same or different. They definitely do not survive the same. For example, somebody has a pathological CR, we know they do very, very well. Somebody who does not have a pathological CR, all of them do not behave the same. So the TRG helps in differentiating these two, and you could add on therapy only to those people who are really being very, very poor. So those are some of those benefits. Currently, nothing is standard of care using this. Probably things will come up with.
Yes.
Manoj, wait.
The price of the lesion is 2 cm. Biopsy proven well differentiated adenocarcinoma without any ulcer. We are doing an endoscopic mucosal resection and submucosal resection. What is that? What if the post-op biopsy comes positive? So how do we address that? Can we do a re-endoscopy or should we proceed with gastrectomy?
The important thing is which margin comes as positive. In endoscopic submucosal resection, usually the marking is done giving 5 millimeters around the lesion. If the vertical margin comes as positive, usually they send the patient for gastrectomy.
Yes.
Morning. When doing CT for CS stomach, when instead of using water as a distending agent, is there any definitive advantage of using mannitol, or is it just a choice whether to use water or mannitol?
Mannitol we generally use for distending a small bowel. Distending the stomach is not a problem. You just give adequate water just before taking the scan. 5-10 minutes before taking the scan, you actually adequate distension. The challenge is in distending the small bowel for enterography. That is where we use it.
Any other questions? You can see some of our students from CMC sitting there. Okay, so
I answer. Yeah. Currently, I came to know that that the HER2 new receptors are present up to the tune of 30%. Is there a role to detect and give them transfer of say?
So the HER2 data comes mainly from the metastatic setting. It's around 20 to 25% as you said, sir. But in adjuvant setting, there was a study where they used trastuzumab and pertuzumab together. So they are both HER2 inhibitors. But in that study, in a phase 2 study, there were a lot of toxicities. Though they had pathological CRs up to 40%, starting from, generally you get 10 to 12%, they got almost 40%. But the toxicities were so high that they were not able to proceed to a phase 3 study. So currently, there is no data in adjuvant setting, but in metastatic setting, you definitely have a data.
We are having we are saying.
Okay, so if there are no further questions, so thank you very much for the for all the panelists for that excellent presentation. Thank you for the active participation from the audience as well. Thank you.
Thank you, sirs, for that enlightening session on the recent management strategies in carcinoma stomach. I now kindly request Dr. Ilian Samarasam to felicitate our panelists, Dr. Ramkumar Ji.
So you are in laparoscopy. Doing not doing. Lap only also they don't do it.
Dr. Biswajit Dubashi. And Dr. Parnivedan.
Area of interest. When do you do?
I now kindly request Professor Dr. Vishnu Prasad to felicitate our moderator, Dr. Ilian Samarasam.
Large child, it will take some problem and nerve is there. I have to sort it out. India is problem. Which maybe India is happening.
Thank you, sirs. We'll now break for tea. Tea is being served at yoga hall, same floor.
First, I'll have to do the
There will be a surgical. Kindly reconvene in 20 minutes for the afternoon session.
Where are you from?
There is a surgical quiz being conducted today at the end of today's program. So the candidates who are interested in participating, kindly come and give your names at the register. It's a single stage quiz of 25 questions and single participant, not team. Kindly give your names if you're interested at the counter. Also,
Because it will be the question will be shared, and other will be shared in the house.
The candidates who have registered for the e-poster presentation, there are a few who have not submitted their presentations yet. So the following candidates are supposed to come give your PowerPoint presentations now. Vinayaka, Akshata, Kedar, Deepika, Shobini, Jabitosh, Fahim Rahmat, Aditya Yadav, and Aishwarya R. I request you guys to submit your PowerPoint presentations now at the desk. Thank you. Kindly reconvene in 20 minutes after tea. Tea is served in yoga hall, the same floor.
I request all the delegates to join us for tea and reconvene in 20 minutes, 15 or 20 minutes.
Why? No. Why?
Because there will be a lag videos.
So why not directly from that? Sir will still be able to see us.
I'll be able to see as well as I'll be
We'll give you
able
a
to.
clicker. Sir, are you logged out of my Gmail also when you're free?
No.
My Gmail is open there, bro.
So first it's copy, reasonably fast computers. Hmm? I will expect. Put to full screen.
Open again and see here. Link மட்டும் கொடுத்துரு வீடியோ ஆட்ல வச்சிருக்கோம்.
இங்க நம்ம click பண்ணி play பண்ணிக்கலாம்.
No, you want Surya. Surya. Surya.
அப்படிதான் சொன்னாங்க ஆனா இவங்க என்ன சொன்ன எனக்கு வாட்ஸ்அப் பண்ணி தெரியல அது 3 பிபிடி கேக்குறாங்க
இதுல சப்ஜெக்ட் எல்லாம் போடு அதுவும் போடு செமையா இருக்கும் நாங்கள் ட்ரெஸ் இருக்கு
இதை கொடுத்துட்டு வந்துடும் அவர்கிட்ட
Very. Yeah.
Anyway, it's not working. నా పెడతారు ఇచ్చాను నేను కూడా వచ్చి Yeah, like I'm making it. I'm going to have The thing is, are not toxic, okay? We want to push them to a point where they will just. There is no bond. To action put up from that. Vaidishwaran next weekend.
Yeah.
On that, the back in the Why that? Why is the making of the getting the piece of the
You have to. Everything is the same. In the case of and we told them
That's what we are. Okay, okay.
Just turn up at least. It's like that, yeah. It's like that. Not. Yeah, right.
Yes. Otherwise, judging. I think. How much is I told them to make. We have to go and they five years. Okay.
Which means it's not there.
So next is the topic.
Welcome back, everyone.
Invention
Now,
panel.
we have a video guest lecture on
Next,
laparoscopic colorectal surgery, 10 years of experience by Dr. Ravi.
On the page.
I welcome Dr. Professor Vishnu Prasad, Dr. Rajkumar N, Dr. Jaypal Reddy, and Dr. Raj Mahendra to chair this session. Thank you.
Sir, good morning all. I'm Dr. Raj Mahendran. I welcome Dr. Vaidhi sir. He's a very famous person. We all know from him. My friends, all of them went for laparoscopic training from him. So such an extraordinary surgeon. Sir is a senior consultant of GI Oncology and GI Surgery in Apollo Specialty Hospital, OMR, and Apollo Proton Center, Chennai Urology and Robotic Institute. So sir has qualified MS, MRCS, FAIS, FMAS, and has a total experience of 19 years. And sir has published more than 15 publications after having acquired medical and surgical training in JIPMER, and he trained in surgical oncology in Apex Institute, AIMS, and worked as a consultant in GEM Hospital, which has the highest volume of laparoscopic surgery.
I think we should stop and
So sir doesn't need any introduction, but sir is such an extraordinary person. Let us just have his. I'm proud that he's our living.
Thanks for the opportunity. Full video, it is not a full video lecture. I'll just evolution what has happened in the last 10 years. Quickly I'll summarize and show you two videos. One salient features of the complete mesocholic excision and central vascular ligation and TME. Next slide is this one is not working.
Sorry, wait.
No.
This one.
See, way back in 2006, when I was doing my senior residency in All India Institute, I wrote this paper and published in Tropical Gastroenterology, evidence-based management of colorectal cancers. From that time to now, everything has changed upside down. Not one thing that we wrote in that article is now practiced. This is just to show you. Most things are imaging, neoadjuvant treatment, molecular targeted therapy, endoscopic management of early cancers, complete response category, how we manage, adjuvant treatment has remarkably changed. Then PET-CT has come. Then minimally invasive surgery has completely taken over colorectal surgery, and more importance is given to autonomic functional outcomes of minimally invasive surgery. Then ERAS has revolutionized hospital stay and post-operative complications, and we are able to salvage more sphincters and metastatic disease no longer is a very bad situation. We are able to give 5 years survival commonly in metastatic disease, especially good prognosis histology. We are able to give 5 years survival in a lot of metastatic disease patients. Needless to say that MRI has become absolute indication in rectal cancer. If people are practicing operating without MRI, I would completely disagree with them, because MRI, as you see in the next slide, MRI decides whether there is threaten or there is mesorectal fascia involvement, whether there is any threatening to the mesorectal fascia, tumor is confined to the rectum or not, and whether lymph nodes are not there or not. The MRI so clearly delineates everything. Not only this, it also shows the involvement of the external sphincter and relation to the external sphincter which decides the sphincter salvage. What I told is this only the MRI does with accurate T staging and also some nodal staging. So depending on that, next, depending on this, we decide whether the patient is going for neoadjuvant treatment. In this is normal, and you see that in the tumor is very close to the mesorectal fascia. Hence, the patient will go for neoadjuvant treatment. So this summarizes how MRI influences the management. If it is low risk category, patient goes for upfront surgery. Intermediate or high risk, they go for neoadjuvant treatment. So MRI gives you the T stage, mesorectal facial involvement, nodes, diffusion restricted images show the response to chemotherapy, and EMA is an important prognostic factor, the sphincter relation and the treatment response. CT scan is also important to identify metastasis. And PET-CT nowadays is very widely used, especially in private practice, because it is much more cheaper to do a PET-CT than do chest CT separately and abdominal CT separately and MRI separately. So if you ask for a PET-CT with a screening MRI, it is much more cost effective for the patient. But specific indications are there in if the CA is very high in color, and when oligometastatic disease we are going to resect, we want to make sure that what we are resecting is the only site of disease and no other site of disease is there. Hence, it is obligatory to do a PET-CT. Next. So neoadjuvant therapy has come a long way again. So it is now for locally advanced rectal cancer. It is beyond doubt. It increases survival, it decreases recurrence, and it increases sphincter salvage rate, and it increases disease-free survival. So hence, because of improved survival, neoadjuvant treatment is a must in locally advanced. For exam purposes, you can remember any T3 with the threatened mesorectal fascia and a node positive disease, we have to give neoadjuvant treatment. What neoadjuvant treatment is a very complicated area to discuss, but standard is concurrent chemoradiation. But now there is something called as total neoadjuvant treatment is there, and very selectively in patients where chemotherapy has some problem, we give short course radiation and then take up the patient. So what has changed? We used to, when 10 years back, I used to operate at 6 weeks after chemoradiation, but slowly it increased to 8 weeks. Now we are waiting for 3 months before operating. It might go further also with the total neoadjuvant treatment. Now, early cancers, already like stomach cancer, they discussed early cancers for colon also, and polyps with high-grade dysplasia or low-grade malignancy, EMR or ESD is there. Next. When patients present with obstruction, the most common practice is to do a Hartmann's or a stoma because patient is in obstruction, and then deal with the tumor at a later date, or resect and we'll do a stoma. But nowadays, what we are doing as a kind of care, we are doing endoscopic stenting and relieving the obstruction. After a week, we are able to do minimally invasive surgery, and we are avoiding stoma, thereby improving the quality of life and single stage management of the cancer we are doing. So all the time you are hearing this mesorectal excision. It is just the ontological concept where all the lymphovascular tissue along with the facial sheath and the blood vessels is taken with the organ. So it is, the resection is done in the embryological plane. Healed, this person was the person who described this, and a Dutch cancer trial was done where they trained all the surgeons in doing TME, and they found the recurrence rate remarkably decreased irrespective of the chemotherapy and radiotherapy. So the surgery is the most important arm in colorectal surgery, and if you do it properly, it improves survival. Chemotherapy and radiotherapy are adjuvant in colorectal cancer, though some places now it is becoming the primary. So this picture summarizes when the growth is confined to the rectum and there is no threatening of the mesorectal fascia, we do an anterior resection. When the growth is involving the internal sphincter, we do something called as an intersphincteric resection. When growth involves the external sphincter, we do abdominal resection. When the growth involves the external sphincter and is coming to the outside edge, then we do something called the extra levator abdominoperineal dissection. This has, there is nothing, minimal invasive surgery has definitely changed the hospital stay and outcomes in colorectal surgery. But after 10 years, people will be surprised to hear this from my mouth. There is very little advantage now I find between open surgery and minimally invasive surgery because of ERAS. We are able to discharge our open surgery patients also post-operative day 4. If we follow a proper ERAS protocol, we are anesthetist, intensivist, and the nurses are cooperative and they are trained. We are able to discharge the patient quite early because of ERAS. Next. We have made us, I think many of you are doing thesis also in ERAS. I'm not going to elaborate. It is an important short note for you. But there are some things which we have modified. I always give bowel preparation because it is very difficult to do anastomosis in a loaded colon. And now the evidence is also going towards the bowel preparation again. We always use drains because we discharge the patients quite early. We want to detect any leak in low anterior resections are there. We want to have drains at least in for rectal surgeries. Preoperative carbohydrate loading, many of our patients are diabetic. And my thesis itself was on enteral feeding, early enteral feeding. I do not agree with many of the things. It is again another discussion. So preoperative carbohydrates we are not given. And we discharge the patient on liquid diet for a week and call them back for starting them on solids. With the liquid diet, we are able to manage the nutritional requirement, high protein liquid diet. This is the protocol we follow. We found that our adherence to ERAS is very, very good. In the second 5 years, we are able to, complication does not make any difference, but our HDU stay or our ICU stay has decreased remarkably. And we are able to start oral early. We can even start early, but most of the cases we finish late in the evening. So we don't want to start late in the night. So we just for convenience are making it next day morning, but it can be lesser also. The post-operative hospital stay is the third post-operative day we are discharging. And mean duration of surgery is not because of ERAS, because of our improvement in our techniques and the energy sources and imaging, we're able to do it much faster. There is, all of you should know, there is one person called as Abargama who proposed that patients who have a complete response to chemoradiation can be kept on follow-up. And these patients are 3-monthly follow-up with the CEA, endoscopy, and imaging. And now, for this is only for low rectal cancers where we are interested in preserving the sphincter. In Indian situation, it has not been evaluated, and we very selectively keep patients on follow-up depending on their education and resources available. Sphincter salvage, earlier it used to be how low we can get. If it is close to the anal sphincter during our PG time, if it is close to our anals 5 centimeter or lesser, we used to do a APR. But nowadays, because of new adjuvant, we are able to salvage more sphincters. And it is not only the distal margin, it is also the circumferential margin that is important. And we are able to do intersphincter resections for better circumferential margin, even if it is quite low. Next. So this is what we do. Abdominal mobilization I'll show later. We use this is called as a non-star retractor. We retract very clearly. We can see the lower margin and we can do a intersphincter resection. Next. Next. Yes, this one you can play the video. Once we make on seeing
light on light veno.
Sometimes it is not possible if it is a bulky tumor, we will do a and we can
Okay, very good.
The particular
Super.
you can see the margin, we have very good margin, and this is done under vision. Post neoadjuvant, so the tumor is not very clear. So this should be the specimen. There are your pathologist is the conscience keeper for a colorectal surgeon. because they are the one who will tell you whether you have done adequate job, whether the fascia is intact, whether there is no coning of the specimen, baby's bottom they tell. It should be like that, there is no coning of the specimen and there is no breach in the fascia and the pedicle till the IMA is a peak. So this is after intersphincter section, the covering ileostomy for ultra-low is always done. Our policy on ileostomy is that for all post-neoadjuvant chemoradiation patients, we do a covering ileostomy. For all colon anastomosis, we do a covering ileostomy. This is very important, especially with the cancer coming in much younger patients. Autonomic nerve preservation is an important part for quality of life. And the quality of surgery is the single most important factor. We cannot tell it is because of chemoradiation that patient is having urinary or sexual dysfunction. It is because of surgery. So improper TME, urinary complications are around 10 to 30% and sexual dysfunction is 40 to 60%. But if you do a proper ANP, we can decrease it to 10% and 5%. So there are many places where you can injure the nerve. Commonest is just near the prostate, lateral to the prostate. If denal Miller's fascia we are taking and injuring the seminal vesicle, mostly you're knocking off the autonomic nerves. The other places are showing the video. Other 3 places where you can injure and shows the video. The reason for our improvement in minimally invasive surgery, needless to say, is because of the gadgets that we have. All the high definition instrumentation, energy sources, everything helps us in doing this. As I told you, the staplers have improved, the energy sources have remarkably improved next. So we have so many energy sources. And metastatic disease, just an example for metastatic disease we are doing. This is the liver mets in a sigmoid colon cancer. We did RFA, it showed a temporary relief, improvement. Next. But it showed recurrence. We wanted to do a liver resection, but functional liver residue was not okay, remnant was not okay. We did a case, so hypertrophy is a left lobe. Then we did a right hepatectomy for this patient. Now coming to the CME with the CVL, it is just like for rectum. It is embryological planes we follow for a right hemicolectomy, where the right mesocolon along with the fascia is taken with the lymphatics and the vascular and the neural tissue, and the vessels are ligated very medially. This is the plane that we follow, the tall fascia, that's potential space here. We go in this plane and then take it up to the origin at the SMB. So we follow a technique which is slightly different. We go retromesocolic first, then go medially, then the hepatic pressure is the motor system. Next. These are the port positions that I follow. This will be the camera port. Nowadays, I changed this port to here slightly because the middle colic resection is much easier if my right hand working port is here, because the clipping of the middle colic is much easier. And this is the traction port and this is the left hand working port. This is a very quick video of this the complete mesocolic excision with the central vascular. This is the iliac, this is the ureter. We want to go to this is the mesocolon. We will make incision, and then the gerotas and the posterior fascia go down. The mesocolic fascia goes up. We extend it medially up to the duodenum. The duodenum also goes down. The fascia covering the duodenum goes down. The mesocolon is completely intact. The duodenum goes down. Gerotas goes down. The gonadals and the ureter are preserved if this plane is followed. So the duodenum is completely separated. We keep a gauze piece. Then we go anterior. We identify the junction of the small bowel mesentery and the right colon mesentery. Make an incision. Different energy sources you can use. So that is the right colic at the origin into the origin of the superior mesentery. So this is the superior mesentery. As I told you, so we have cleared we are ligating it at the origin. This is the central vascular ligation. Always double clip to name the vessels. All principles are same in open end. laparoscopic system. Once the right colic, this is the pancreas, inferior border of the pancreas. The superior mesenteric vessels are here. Now we are identifying the middle colic vessels. One of the branches, mostly probably the tip of the video. We are ligating it as proximal as possible. Then this is the middle colic. This is the right branch, this is the left branch. We are ligating only the right branch because it is a cecal growth. Now we are ligating only the right branch, left branch we are preserving. Though lymph nodes are along the middle colic artery are already removed. We are not leaving behind the lymph nodes, just we are preserving the left branch. Now you see the left branch and right branch, middle colic, and this is the main vessels. Then the hepatic flexion is mobilized completely. Already we have completed the part. This part is easy, not very difficult. Same thing, the lateral line is sold is divided. Then we do a extracorporeal anastomosis through a small incision. I do not find any advantage of doing a extracorporeal anastomosis because we anyway need a specimen extraction for the patient. Now you see how neatly the video, all the vessels along the superior mesenteric and the middle colic are removed, and they are there. All the lymph nodes are mentioned. This is the port position, slightly tilted. This is the port position for our low anterior section or upper anterior section. This is our camera port, left hand working port. No, this is not the left. This is the retraction port. The left hand working port for the initial part during the AMA will be anterior axillary side. Then during the pelvic dissection, it becomes the left fossa port. Sometimes we put this, sometimes we will not put this. This port is almost midway between the anterosuperior iliac spine and the umbilical, depending on the size of the patient. This is the highly edited video. I have a longer video also. Those who are interested, I can give this. This is the upper rectal growth. The growth is above the peritoneal port. We are going to do the anterior section. This is the iliac vessel and the aorta. So the sigmoid mesocolon is lifted up. This is the small bowel mesentery. That is the inferior mesentery which we are dividing. The first step is the inferior mesenteric ligation and identifying the plane. These are the nerves. I don't know how many of you are able to see the nerves. This is one of the areas where we can injure the nerves. So we have to preserve this fascia, identify the retroperitoneal fascia or the Gerota's fascia, and keep anterior to the Gerota's fascia. If we are keeping anterior to the Gerota's fascia, we will be preserving all the nerves, the ureter, and the gonadal vessels. And if we go superiorly, we enter the presacral. See the nerves. The clue is the inferior mesenteric artery is the posterior structure in that bundle. So you have to keep just posterior to the inferior mesenteric artery. The fascia, carefully if you see, the fascia is preserved. It's 3 more minutes. So this way I extend this plane up to the lateral wall. Now what I am having over my left hand is the mesentery of the sigmoid colon, descending colon, and if we extend it inferiorly, this step is so important. We have that's the ureter. We have to extend it inferiorly. Before that, I will ligate the IMA. IMA ligation 1 centimeter from the origin. That way, we will preserve all the autonomic nerves. This is one place where you will injure the autonomic nerves. If you have leave a 1 centimeter pedicle for the IMA before the origin of the left colic, then we are able to preserve the nerves. And this is the IMB ligation. We can mobilize the splenic flexure at this stage or at a later stage, medial to lateral or lateral to medial. Now I have increased the speed because it's just the paracolligator. We are detaching. Inferiorly, we are extending into the pelvis. The ureter should be preserved here. This is the left side. This is the right side. My left hand does most of the work, and I have excellent assistants who are giving traction, counter traction. Because of that only I am able to find this plane. Presacral fascia is here. The mesocolic fascia, mesorectal fascia is here. This is the mesocolic vessel. That is the posterior most structure. If we keep just the posterior, we will be in the right plane. This is the second place where we can injure the nerves. That is the sacral promontory. So if you are in the right plane, you will not injure. You see the ureter. Appropriate traction anterior and cephalic will expose this plane. Hemoperitoneum will help me in creating this plane only. So the fascia is intact, no fat is there. So posteriorly first I do, then right lateral and then left lateral. So systematically we have to do this posterior, left or right lateral and then the other lateral. So you have to follow the peritoneal fold. This is the autonomic nerve. This is the third place where you can injure the nerve. That is lateral, overzealous lateral dissection. So if you are in the right plane, you will not injure. Since this is female patient, fourth place injury is very rare because the prostate dissection is not involved here. So depending on the level of the tumor, you have to go up to the levator or not, you have to decide. Mesorectal margin is 5 to 6 centimeter. The bowel margin is 2 centimeters adequate. This is the growth. We are giving adequate bowel margin. Mesorectum is divided 5 centimeter blister. Usually I prefer the ligation for mesorectal division. Dissection harmonic is very good, especially in fast mode because it doesn't seal the plane. For division of the mesorectum or mesocolon, ligation is a better instrument. Once we do that, we fire the stapler. I always use the gold for rectal division because rectum is thick wall. See the margin, at least 3 centimeter bowel margin are given. Usually we need to do staplers and it should be bloodless. If you are in the right plane, absolutely bloodless it should be. With the splenic flexion mobilization. To have a tension-free anastomosis, only 3 factors determine whether you do ileostomy or not. 4 factors, whether neoadjuvant treatment was given. Second is bowel is prepared or not. Third is vascularity is good or not. Fourth is tension is there or not. If any one of the 4 factors you have a problem, do a covering ileostomy safely. We prefer ileostomy over a coloscopy. In ultra low coloanal, you have to go till the middle colic origin, but here it is enough if you straighten the splenic flexion. Use a circular stapler and the anastomosis done. As I told you, this patient did not receive any neoadjuvant treatment, so no ileostomy. Thank you. Any questions?
That was an excellent presentation, good video. I just want to ask you, can you give us some few tips how to take care of the splenic fracture during because there is a site where most of us face problems.
2 things I do, sir. Before you ligate the IMB, if you go posteriorly, you laterally have gone. If you go superiorly also, extend it to the inferior border of the pancreas. Once you cut the IMB, that mesocolon becomes smooth and you need it to hold it. So after ligation of the IMB, you have space. You have approach to the left hypochondrium, posterior to the mesocolon. So go as much superior as possible there. Second step is divide the gastrocolic omentum on the left side. Then third is what I showed come from this side. If you do all 3 maneuvers sequentially, we are able to completely straighten the splenic flexion. So 3 maneuvers. First, don't divide the IMB, go posterior and to superior. Second, the gastrocolic omentum you divide. Third is from lateral.
Do you use ICG?
ICG I'm not using that because I don't have access to ICG in Curie and in Apollo it costs more. The ICG camera costs more, so I don't use the ICG camera.
Too often I use robot, but
I have done only 6 cases of robotic low entry restriction. Actually, for me, people who have crossed the learning curve, I really do not find any advantage, but just to be in competition, we are doing robotic.
is the single lighting or
Single dot.
Sorry, excuse me, sir. Sir, is it mandatory to bring down the splenic pressure always, sir?
No,
Sometimes our
attention. If the sigmoid colon is long,
yes,
then we don't need it to do. The more proximal the tumor, the sigmoid colon tumor, you have to completely straighten the splenic flexion. And the ultra low, you have to completely straighten the spleen pressure. The upper and middle rectal growth, you need not to completely straighten the spleen pressure.
Please.
Thank you. That was and good to see you. I think it's been a while. Excellent video and presentation. Yeah, basically, it's a basic question I'm asking. Power preparation. I mean, I think we started from power preparation for everyone to no preparation to now power preparation, more power preparation. So, just for the benefit of students, what is the current sort of recommendation, or if you know guidelines with regards to bowel preparation? One, whether you do open laparoscopic surgery or minimally invasive surgery, and secondly, what about oral antibiotics in terms of bowel preparation? Just it's a very basic question.
Oral antibiotics, definitely there is an advantage of giving IV antibiotics also starting the day of admission, that is the previous day. Oral antibiotics also, some evidence is there that it is useful. Bowel preparation, it was proved that it is not proved. It was widely published that bowel preparation is not needed. But now the clock is turning again, and many people are showing it might not prevent leak, but the consequences of the leak, that is the toxicity, tachycardia, sepsis, and all, is much lesser if the bowel is prepared. But for me, technically, I have seen it is so difficult to handle the colon loaded with the feces and firing staplers on a feces loaded colon. So I always prepare the bowel, but evidence is turning back to bowel preparation.
Yeah, thank you.
My only this thing which I found is putting a stent in an obstructed system, because there are so many reports showing it increases over stages, perforations. So whether do you still go ahead with stenting?
We do cover the stent, and luckily we are blessed with excellent intervention in gastroenterologists. They will be able to tell that it is safe without perforation, or you go ahead with surgery. But most of the time they are able to do a covered stent. And so far we have not, 9 cases we have managed like this. So far we have not had even a single incidence of perforation. And now currently this evidence is also that bridging towards, sometimes neoadjuvant is also given. After that surgery is done. If we are not doing that, sometimes we are avoiding neoadjuvant, we get margin positive, and sometimes we have to do stage stoma we have to do. And we always have to do offenses.
Morning, sir. Nice presentation, sir. So I have 2 questions, sir. One, what's your experience with damage in lower rectal? That's question number 1. Question number 2, is there an advantage of doing deep lumpectomy in right lung?
The second question, the Japanese are the only people who have told that there is an advantage, and we are not doing it physically at all. And the minimum nodal requirement, if you see the NCCN is the 12 nodes only for a sampling. So the CMV and the CVL itself, we are able to get 20 to 23 nodes, 25 nodes roughly. And I don't know exactly where the D3 stands in Indian scenario with the adjuvant therapy that we have. Other than Japanese, nobody is removing D3. And I'm also not doing. Second thing is your TAMIS. TAMIS is almost abolished in many of the countries. Norway, some of the countries have told that it's causing more damage than good. And generally, I am a conservative surgeon. Once the evidence matures only, I will adapt to that. So especially in private practice, you have to do. So I don't use the TAMIS or transanal excisions at all, except to very low rectal. And we are sure that it is superficial.
Excellent presentation, sir. As you mentioned about the radiation and the duration is like late surgery and early surgery. Just any experience with short course radiation late surgery, sir? The evidence is.
See, I trained from a center where short course was the only neoadjuvant that was given in AIMS. So we used to give 5 fractions, 25 gray, and we used to operate on 7 days. That's what we used to do. But generally, now overall in Tamil Nadu, state of Tamil Nadu, Hardly anybody who practices short course variation. So it is still the more common in the north. And short course, now this variation of short course with the total neoadjuvant or waiting for a longer time, we have no experience. Right now, trial is going on in AIDS. Short course with a longer waiting period. Right now, trial is.
JIPMER, we used to do short course and early surgery, sir, for some cases. I understand.
I think Dr. Vishnu would have brought it from AIDS. Because the logistics, the whole of North India comes to AIMS, we cannot give mainly driven by logistics. 30 days, the radiation is waiting list is so long. They want to give only 5 days, and it was in Swedish trial shows that it's equally effective in margin stabilization.
On what kind of diet, normal diet or
That's what it's said that it is highly variable, but the people say that you can put the patient on normal diet. See, the only problem, the reasons why I have stuck on to liquid diet for as the protocol was, we used to start early normal diet, but generally what happens is the raw area is so high that small bowel gets in arrears, especially after this experience is from total proctocolor. The raw area is so much that there are so many hairpin bends in the small bowel. Usually when you give liquid diet, you manage solids sometimes, especially hygroscopic solids. And it's very difficult to control what they are eating. They take some vegetables, hygroscopic vegetables or seeds going. Then in the hairpin bend, it gets caught and it becomes obstructive point. That's why as the standard protocol, we made it liquid diet. And when you are in a costly corporate hospital, every hospital they cost so much. So we don't want to take any chance. So we put them on liquid diet and then discharge and call them back when everything is settled. Then we start them on solids. Low residue solids for a week, then only high residue solids. Thank you so much. Thanks so much, sir.
Thank you very much. Excellent.
Thank you, sir, for your wonderful presentation. I now request the chairpersons to facilitate Dr. Vaideshwaran. I now request Professor Indian Samarasan to felicitate Dr. Rajanindra. Thank you, sir. I now kindly request the following participants for e-poster presentation to assemble near the registration desk. Dr. Divakar, Dr. Manoj Kumar, Dr. Varsha Raja, Dr. G. Manoj, Dr. Divash, Dr. Sagar P, Dr. Vinayaka, Dr. Furkan, Dr. Pavan, Dr. Vedaprakash, Dr. Vikyat, and Dr. Devnanda. Kindly assemble near the registration desk. Thank you. May I please request Dr. Vishnu Prasad to kindly remain on stage for the next session. We'll move on to the next guest lecture. It's an interesting guest lecture on intestine green fluorescence guided upper GI surgery by Professor Dr. Indian Samarasan. I welcome the chairpersons, Dr. Vishnu Prasad, Dr. Rajan KV, and Dr. Vaideshwaran onto the dais for the session.
So Professor Indian Samarasan doesn't need any introduction. All of us are already familiar. So he's head of the upper GI surgical unit in Department of Surgery, Christian Medical College, Bangalore. So he is the author of more than 80 publications in leading journals. He has participated as faculty in various national and international surgical conferences. and is examiner for the National Board Examination in India as well as the Royal College of Surgeons of Edinburgh. His area of interest is mainly benign and malignant disease of the esophagus, stomach, and advanced laparoscopy. And today we would like to hear his lecture on the ICG guided surgery in upper GI cancers. Over to you, sir.
Thank you. Thank you, sir. Thank you, sir, for the kind introduction and also for the kind invitation. It's always been a pleasure. I think I missed one of the surgical updates, but this is the fourth one that I'm attending. So thank you very much for the invitation. And I bring along with me greetings from our hospital in Belgium. So my brief is to talk on the role of ICG in GI surgery, and I'm going to mainly concentrate or mainly talk on upper GI surgery because that is my interest. So for the benefit of students here, essentially fluorescence, how does this happen? So some of these molecules, when they're exposed to a certain wavelength of light, they get excited and the electrons get shifted from the normal mode to the excitation mode. And when they return back to their normal mode, they emit a certain wavelength of light. And you can capture that wavelength of light, and that is being processed by the processor, and you can see the image as a fluorescence. So that's how generally fluorescence works. And again, for the students here, the visible spectrum, the light that we see is between 400 to 700 nanometers. The near infrared is what causes this fluorescence in ICG. And this is between 800 to 1000 nanometers. So when ICG is exposed to this near infrared wavelength, that is when you see this fluorescence. Now, what is ICG? I'm sure you all know what indigocyanin means and what it is used for. As far as fluorescence is concerned, ICG gets bounded to the plasma protein. It is very safe. It has got no metabolites. It's basically just excreted back into the bile by the liver, and it takes about 8 to 10 minutes after injection. And this is when it's given intravascularly. But when you inject it outside the blood vessels, like when you inject it into the subcutaneous tissue or around into the lymph nodes, then again this ICG binds to the protein and it reaches the lymph nodes, and you can visualize the lymphatic chain. And the dose is 0.1 to 0.5 milligram per ml per kilogram. So that is the dose of ICG. It's got various clinical applications. So you can give it intravenously, you can give it very tumorally, basically for visualizing the tumor and the lymphatics. You can give it in the groin, basically to visualize the thoracic duct. And of late, there has also been reports of using aerosol for airway fluorescence, particularly when you do thoracic surgery and esophageal surgery. So these are various routes where this can be used. Now, my talk I'm going to limit to the use of this in esophageal and gastric resections. So firstly, fluorescence-guided esophageal surgery. Now, there are 4 ways it can be useful. So firstly, to look at perfusion of the gastric conduit. Secondly, to do guided lymphadenectomy. We've talked about sentinel node mapping, etc. So this is useful in that kind of situation. Third one, and I think the most useful role is in thoracic duct visualization, thoracic duct lymphangiography, when you do esophageal resections. And fourthly, as we've just seen, airway visualization, when you've got a large tumor around the upper airway where you want to preserve the airway, this can sometimes happen, although we do not have experience in the last one. So we'll look at it one after the other. First is the perfusion. Like in any GI surgery, this can be used for assessing the gastric conduit. Normally, after an esophagectomy, use the stomach as a conduit. So to look at gastric conduit perfusion. So what does the literature say? If you look at, these are some of the studies which have used ICG. Mind you, I'm not saying ICG is always necessary. But Vaidya was saying that he doesn't use. So this is something that has come up. I'm just putting this up because it's a recent advance. But I'm not saying this definitely needs to be done. But for the if you look at what the literature says, if you use ICG versus if you not use ICG in esophageal resection, the leak rates in favor of ICG. And these are some of the meta-analysis which have looked at ICG versus non-ICG leak rates in esophageal surgery, again in favor. Now, we actually did one of our students did a thesis on this one, looking at the leak rates after while you use the ICG perfusion study for gastric conduit, and we sort of categorized into perfusion as good, sluggish, and poor based on the time taken for the ICG to reach the gastric conduit in seconds. Basically, this is an Ivy Lewis esophagectomy. And once you give the ICG, you can sort of visualize the conduit getting, so it's coming into the blood vessels and then it gets into the conduit. So the time taken for it to reach the tip of the conduit, so it's measured in seconds. So you need to standardize it. So you need to give this. And once it reaches the tip of the conduit, the time was taken in seconds. Then if there was a problem with the perfusion, appropriately, this, say for example, if the ICG did not reach the tip, then we resected the tip and then did the anastomosis. So based on this, again, this is an open, it is a McEwen's esophagectomy where we take the specimen out through the abdomen. And then this was the ICG that was done. Again, as you can see, this is in blue. It's not showing up very well on the screen, but basically, based on the imaging source that you have, you can either be in green or blue. So that tip was not perfusing well. So this was excised and then we did the anastomosis in the neck. And this was the results of the study that we did. So basically, if the perfusion was poor, we almost always did whatever was necessary to remove the tip of the conduit. If the perfusion was good, there was no leaks, whereas if the perfusion was sluggish, there were 2 leaks seen in the anastomosis. Now, what are the drawbacks in this is, firstly, this is a very objective assessment. So basically, you measure the time taken for it to reach, and you also look at how much of perfusion there is, looking at the color. So we probably need more appropriate software for more objective analysis of the perfusion, which we currently do not have. And one of the ways of doing it is looking at the time-dependent fluorescence intensity curve. So basically, how much time it takes and the intensity. And perhaps if we can come out with something like this, then we can have a more objective analysis of the perfusion of the conduit. So that's about perfusion. Now, moving on to the lymphadenectomy part. Basically, lymphatic mapping can also be done with the help of ICG. So what you do is you give the ICG submucous. So endoscopically, you inject it into the submucosa around the tumor. And this can be done just pre-operatively. So after induction, you can do it. And by about 15 to 20 minutes, it reaches the lymph nodes, and then you do the dissection. Perhaps in thoracic, like when you do thoracic lymphadenectomy, you can look at doing selective supracardial dissection. So basically, dissection around recurrent laryngeal nerves. Perhaps you can do a tailored lymphadenectomy if you're able to do this kind of ICG guided lymphadenectomy. What are the limitations? What happens is that once you inject it, there is fluorescence around the main tumor itself. Now, this can affect the visualization of the peritumoral lymph nodes. And also, most of these patients have preoperative radiation, and therefore that can also affect the ICG reaching the lymph node. So it is not perfect, and these are some of the limitations that you can have with respect to esophageal resection. I think the most exciting thing is the visualization of the thoracic duct while you do an esophagectomy. It definitely reduces. So firstly, if you ask, is it necessary to remove the thoracic duct when you do a esophagectomy? The answer is no. Current evidence states that you can preserve the thoracic duct when you do the esophagectomy for cancer. And removing the thoracic duct doesn't translate to survival advantage. So that is the current evidence. So if you want to preserve the thoracic duct without injury, this is where the ICG helps. Now, where do you inject ICG for visualizing the thoracic duct? You can inject it, if you're doing an ivolus esophagectomy, you can inject it in the mesentery, the small bowel, because you will do the abdominal part first and then go into the chest. Whereas if you're doing a McEwan's esophagectomy, you can inject it either in the groin or in the web space of the foot. So basically, it will work its way up to the thoracic duct. Traditionally, this is being done by injecting, we use an ultrasound and injecting into the groin lymph node. So under visualization, you inject ICG. This is done just prior to the surgery. You inject it to the groin lymph nodes, and once maybe it will take about an hour to reach the thoracic duct. Now we actually modified this technique where we're now just injecting it into the subcutaneous fat. So you don't need ultrasound. You just inject it into the subcutaneous fat. But this has to be done in the day before. So basically, the evening before the operation, you inject it just into bilateral groin at 3 sites. And the next day when you do the surgery, you will be able to visualize the thoracic duct. So this does not require ultrasound guidance. It's very easy to do. So we are now doing this one. So what you do is basically the vial contains 25 milligrams of ICG. You dilute it in 10 ml of it, dilute it with distilled water. And this has to be injected about 10 to 12 hours prior to the surgery. And this is basically the visualization. So if you look at the course of the thoracic duct has got one is it's a variable course, because about 50% of patients, it's got a very, the thoracic duct is not in its normal location. That's where it helps. So it's usually, below the azygous vein, it's fairly constant in location. But as you can see here, above the azygous vein, you can visualize it, and this is because the robotic thing has got Firefly, so we do it for all our cases now. Which are being done robotically, and this helps with the visualization of the thoracic duct. And as you can see, it's above the azygous vein, which is there, which is where it can commonly get injured. So that is about thoracic duct. Now coming to airway visualization, it is useful in locally advanced upper and middle third tumors. So what you do is you can nebulize the ICG, like basically the anesthetist sort of nebulizes and introduces it intraoperatively, and then you can visualize the airway. That's the left and the right bronchus. Particularly the left bronchus is where you can injure it in bulky tumors. So this is being described. We have not used it, and we have no experience with this one. So these are the 4 things that it can be useful in esophageal resection. Now coming to gastric surgery, basically, again, one is for very early tumors, you can use it for intraoperative tumor localization. So the tumor will not be palpable during surgery. So you can inject it, you can do endoscopic ICG tattooing, and you can visualize the primary tumor intraoperatively. So that is one use. Second is like esophageal, it is useful in perfusion assessment. Third thing is, as we've seen in the esophagus, for lymph angiography, so for sentinel node navigation surgery. And lastly, for peritoneal carcinomatosis. So this is basically for early gastric cancer. I mentioned the Senorita trial. So this is looking at the regular gastrectomy versus the sentinel node guided gastrectomy. So this is a multi-center randomized controlled trial. And they were able to say that this type of local resections, are almost equal. You don't miss these lymph nodes, and the survival advantage is equal to doing a more radical resection. So you can do organ preserving surgery using sentinel node resection in early gastric cancer. What about advanced gastric cancer, which we normally see on a day-to-day basis? So here, this is the only trial that I could find in the literature. Is called the iGreen-Go trial. Basically, what they did was they injected ICG just before the surgery, and they did normal lymphadenectomy, how they would do. And subsequent to that, they saw if any of these lymph nodes were missed, and they did the appropriate lymphadenectomy based on if there was any residual lymph nodes at the time of surgery. So that was this trial. So to summarize, basically in early gastric cancer, sentinel lymph node navigation surgery is good. In advanced gastric cancer, the role is not very clear. It's currently basically, under trial protocol only. It's not routine use, for routine use. And lastly, for peritoneal carcinomatosis, you can use this for detecting when you do staging laparoscopy. ICG can be used for looking at when you have a nodule, you're not sure whether it is tumor or not. So you have to do a biopsy, right? So ICG can be useful in differentiating between benign and malignant nodules in the when you do a staging laparoscopy also. So those are some of the advantages of ICG in gastric surgery. So to summarize, it's got the role of fluorescence navigation in GI surgery, particularly it's useful in all GI surgery, basically upper GI, colorectal, and HPV surgery. As far as esophageal resection, thoracic duct visualization, I feel is the most useful role. It is also useful in conduit perfusion and lymph node mapping. And for gastric resection, basically for organ preserving surgery in early gastric cancer, and in advanced gastric cancer, perhaps it's still not yet standard of care, and we'll have to wait for a bit longer. If you want, this is there is a website, there is an International Society of Fluorescence Guided Surgery. There's a lot of information in this website. So if you have time and if you're interested, you can go to this website, and there is a lot of useful information on this website for you. Thank you for your attention.
Thank you very much, Dr. Indian, for this comprehensive talk on the role of ICG. I think given the most updated version for its role in the upper GI surgery, I'm sure it's quite useful for the residents, both in terms of practice as well as in theory extent. I think it will be one of the recent advances, like questions you may expect in your paper. And one question, there's always a possibility of vasospasm when you create this gastric tube. I'm just asking. Maybe theoretical, but still, that spasm can go on, can get relieved later on. The ICG shows it little less diffuse. Will that be an overkill if you try to dissect that part?
So basically,
and the timing, how crucial is the timing of injection? So when you try to activate the thoracic duct, you can have a background, as you say, you can have a background of other structures getting to the center, like within the veins can get enzyme vein. The timing makes it very crucial or
Yes, sir. So I'll answer the second question first. So as timing is very crucial. If for vascular injections, basically it takes hardly about a minute to reach blood vessels. So essentially, if you are looking for conduit perfusion, it is done intra, and as soon as you inject it, the anesthetic injects it. And then, so what we do is we dilute that vial with 10 ml of distilled water, and for perfusion studies, we inject 2 ml of that. And once the anesthetist injects, we injects the ICG and then gives another 10 ml to flush the thing into the vein. And then we start the clock, and it takes about 30 seconds to a minute to reach the conduit. So by that time it reaches and then it is gone. Now, if you are doing, let's say, if you are doing the perfusion study and then you pull the conduit in the neck. Now, you can again repeat it because again there can be some pressure in the neck once you pull up the conduit. So in that situation, there will be some residual thing in the conduit itself. It will go off the blood vessels, but the conduit itself will have residual ICG. So that can alter your visualization. So that is one of the disadvantages if you do it repeatedly. So if you do it, let's say, within half an hour, you will still have some residual in the conduit, but not in the blood vessel. So once you pull it in the neck, all you have to look at is at the blood vessel. Not in the conduit because there will be some residual. Now, as far as the thoracic duct is concerned, you need to inject it at least 10 hours before. So by that time, it has disappeared from all the blood vessels. There's now no evidence of any contrast there. So all you see is the thoracic duct. It is beautifully seen. Again, it will not be in the lymphatics and in the lymph nodes. So if you want to see it in the lymph nodes, you have to inject it submucosally into the peritoneal tissue. So that is done usually about 1 hour or 2 hours before when you want to visualize. So that is the timing. So timing is crucial. Where you inject it is crucial, depending on what you want to see. So that is the second. What is the first question? Vasospasm. Probably, yeah, I don't think it plays a major role. More than the spasm, it's like once you pull in the neck, basically there can be some pressure. That's the only difficulty we found. But vasospasm, I think, is not a major part.
Thanks, sir, for the excellent presentation. So, have you got any experience of managing thoracic duct injuries reported to you where you used ICG and identified and made it?
Yeah, yes. Basically, we started using ICG only about let's say 2 years back. So prior to that, we were just doing it by routine method. We were injecting all this cream and all those into the tip. So the first case where we used it was after a patient who had a radical neck dissection, had an injury of thoracic duct in the neck, and that had dropped into the chest and presented with a pleural effusion, chylothorax. So that was the first case that we used, and I think that was about that was during the COVID time. So that was about 2 years back, 2.5 years back. That first case that we used, and it was very useful when you were able to see that. Post esophagectomy, again, we had one patient where we have to use ICG to visualize it. So definitely it is useful to visualize the thing post surgery. But we have had only one patient post esophagectomy where we had to use it. So that is there. But I feel the major advantage is if you are able to visualize it during the surgery, then even sometimes you can have like duplicated thoracic duct. You can have like abnormal pores where you actually divided it, and there may not be much, chyle leakage at the time, and you can easily miss it. But I think it is those circumstances where we have picked up at least 2 cases intraoperative, where we think it is normal. We already see a thoracic duct, but there is another channel. We thought it was nothing, but then it turned out to be a significant thing where we just put a clip on it. We're able to salvage that. So I think it is more useful in that situation. But certainly picking it up, yes,
What instrument you have for both one as well as laparoscopic study? Or do I use during the ICT to detect the ICT?
So basically for open surgery also we use the same laparoscopic ICG.
Which
We use a source. We have that thing that we have. And for laparoscopy, basically we have a source ICT this thing. For open, when we are doing open, we just wheel it in and then use it. But the problem being that it depends on how close you use it. You know, you hold the camera to the thing to look at the perfusion, the intensity of the perfusion. So that is one disadvantage where if you hold it too closely, it may look very bright. If you hold it a little bit back, it may appear a little bit less bright. So that is one subjective thing that we have, but we don't have open ICG camera to visualize.
I think it is more useful if when you do the supracranial lymph node detection. And there is a place where you likely to injure the cigarette like you inject. What's your experience at the time?
So, basically, we have used it only in the surveyectomy. We have used it for two reasons. One is for the conduit perfusion and the thoracic duct visualization. We haven't used it for lymph nodal mapping study. But that is one area where we think it will be useful for logistic reasons because we need to do an endoscope prior. We are having because of the difficulty of that or intraoperative injection with an endoscope, the time, etc. We have not tried it. We have to try, but I think, as you rightly said, for supracranial, particularly the recurrent node dissection, you can visualize it and do a selective for dissection also. But that also we don't have personal experience.
And when you do the necrosis, we usually use the modified colors side to side. So that will actually avoid the proximal tip of the gastric cancer. In that way, we be avoiding using.
Correct. So we use the same technique, but somehow, having a not so vascular tip at the conduit makes it a little bit. But yes, you're right. I think the anastomose is not going to be. It's not an end-to-end anastomose. It's a end-to-side anastomosis.
Thanks. Subjectively, you are in a training institute, you are training juniors, that time the subjectivity is needed. Subjectively, at your experience being one of the highest volume esophageal surgeon, do you really find a difference between using ICG or without ICG, identifying whether the tip is vascular or not?
For as far as my personal opinion, thoracic duct, yes, I think that is why I said that was the most useful thing. Vascularity, debatable. I think we are doing it because anyway for the esophagus we are using the scope. We already have the scope. So might as well do this. So it is more for that. Prior to that, we were doing a thesis. So we just did it as part of the thesis. So if you ask me, currently we do it only selectively. It's not absolutely mandatory. If you have a very well vascularized conduit that you can visualize, I think it may not add much. Is my opinion.
So, is there a role for ICG guided sentinel lymph node mapping in early carcinoma or locally advanced?
No, that's all. So early gastric cancer, there is a role. We hardly see patients. So so that's something that we can easily do also. For advanced gastric carcinoma, I don't think there is this sentinel node mapping. Perhaps if you do a proper D2 lymphadenectomy, you are going to remove all the lymph nodes, which is necessary, which is a standard of care. So really, the sentinel node mapping doesn't have a role. It is only when you think that you have missed something that you want to pick up, only there it has a role. So if you're doing a standard D2 lymphadenectomy, and if that is, which is the standard of care, you have to remove all the lymph nodes, whether they're involved or not, in that between 1 to 12. So it doesn't add much.
Beyond the D2 area.
So that is a thing which anyway is not standard practice. So it's not necessary. I mean, the role for ICG lymph node mapping, sentinel lymph node mapping in advanced gastric cancer, therefore is limited because you're not going to do it in any way. But in doubt, or if you think it is necessary in select cases, you can perhaps do. But obviously, it will need endoscopic injections. The previous day. So what you need to do is you have to do an endoscope, inject the ICG the previous day, and then do the surgery the next day if you want to do it. So my feeling is that it's in advanced gastric cancer, perhaps it may be okay to do it under a trial setting, but not as standard of care.
This is in relation to the thesis on ICT.
Yes.
Sir, you made a decision based on ICT to revise the conduit.
Yes.
So was it correlating with the clinical assessment that the conduit vascular perforation is compromised and you made a combined decision, or it was purely based on the ICG?
So if the ICG was showing decrease, well, like that one case that was showing, it wasn't projecting very well on the screen. So if the ICG, that tip was like the last maybe 2 centimeters of the tip was ischemic. So you can argue whether this would have translated, because if we see that we transect it and then do the anastomosis. So we have no proof to say that this would have definitely leaked. But if there was poor perfusion, we did the revision and then did the anastomosis.
So the clinical judgment assessment also was.
Yeah, so let me put it this way, that if we had not done the ICG, we would have just done the anastomosis without that. But I cannot say that that patient would have definitely leaked like what sir was saying, because the anastomosis is not at the tip. So I cannot say for sure that it prevented a leak. But what we saw was in the other 2 categories where it was sluggish, the leak rate was more than when it was good. So that is the information that we got from the study. So I cannot say that, it definitely prevented a leak. We don't know because we revised it and then did the anastomosis. That patient may not have leaked also. So that is debatable.
The thing is, for the dose and the concentration was standardized.
Yeah, it was standardized because it's part of the thesis.
Because this depth is variation is there. So how do we quantify any?
Yeah, so that is I was telling it's subjective. So we did as much as possible to standardize it, but again, under the limitations of what we can do. So it will be good, like, for example, if we have a number to this, like if the perfume, this is what, if you point it, and if the screen says 70.
This Carl Strauss is coming with the.
Yeah, so it has not yet come, but once it comes, it'll be good.
Is there a role of ICG in locating the tumor in pancreas or to give adequate margins?
Yes, so that is for even in GI tumors, in colon, gastric also, for early tumors where you cannot palpate it. That type of tumors, you can inject ICG. Again, it has been done the day before, and then the pancreas, I'm not so sure, but for GI, luminal cancers, yes.
Thank you very much, sir. That was a wonderful lecture. Thank you.
Thank you, sir. Thank you.
Thank you, sir. I now request Professor Vishnu Prasad to kindly felicitate Dr. Rajan Kevi. Thank you, sir. Moving on, we now have a case presentation by our postgraduate students, Dr. Kedar and Dr. Manoj, on epigastric mass. I request the examiners of the session to kindly proceed to the dais, Dr. Inian Samarasam, Dr. Nandakishore Maroju, and Dr. Rajamahendran.
திருப்பி ஃபிளிக்கர் ஆகுதா
கேபிள் சேஞ்ச் பண்ணி ஃபிளிக்கர் ஆகிட்டு
ஐயோ
இல்ல சார் அன்பிளக் பண்ணிட்டு பிளக் பண்ணேன்
ஐயோ சார்
Thank you so much, sir. Good afternoon, everyone. Today, myself, Kedar, and Dr. Manoj, we are presenting a case of epigastric mass. The patient name is Mrs. XYZ. The age is 35 years, and she is a female. And the religion is Hindu, and the occupation is homemaker, and the lower middle social economic status, and the residence is Kerala. And coming to the chief complaints, she was present with chief complaints of vomiting for 2 months and abdominal pain for 1 month. And she was like apparently asymptomatic 2 months ago, following which she developed vomiting, which is insidious onset, like 1 hour of the pudding diet, like initially to solid foods and progressive liquids, like which is non-projectile, non-bilious, and it was non-plastic and containing undigested food particles. And she also complained of pain in the upper part of the abdomen for 1 month, which was insidious in onset and dull aching, intermittent and non-radiating. And like it's being aggravated on food intake and relieved on vomiting. And she also complained of early satiety and the ball rolling movements in the abdomen and the issue of militant rhythm, which is intermittent. And she suffered from anorexia and significant weight loss, like which is she is not able to document for the last 1 month. And it was evident that gradual losing of her garments. And the patient has been gradually weakened, and now she is unable to perform her work activities. And she had no issue of symptoms of jaundice, no issue of abdominal distension, and no issue of cough, chest pain, breathlessness, or non-tendency. And treatment histories, she has no issue of drug intake, and she has no issue of, and she had issue of previous to cesarean sections. And past history, she had previous history of hospital admissions. She has no previous history of hospital admissions in the past. And she has no comorbidities like diabetes, hypertension, tuberculosis, epilepsy, asthma, coronary artery disease, and cerebrovascular accident. And she is a mixed diet taker, and she is neither a smoker nor an alcoholic. And she has no history of malignancies. And the menstrual history is parietal and two cesarean sections she has underwent. And coming to the summary, she is a 35-year-old female without any comorbidities, with chief complaints of non-bilious vomiting, containing recently ingested food particles for 2 months, and abdominal pain for 1 month with loss of appetite and loss of weight.
Clinically, what do you suspect the disease is?
The age she is a young female, sir, but her complaints is like she has like the only 2 months of vomiting, like the which was most of the malignant gastritis because benign only will become like for like 6 months or more than 1 year. And also she has significant weight loss and anorexia, and also is there. And also she has the intermittent melena is there, which can be bleeding. And she is 35-year-old female, like which is the Lawrence classification, which shows like diffuse can be there, like young females, like which is the more common. And the next provisional diagnosis can be just because she has intermittent melena and not select causing like the obstructions. And the final, like the differential diagnosis will be the primary GI lymphoma.
What are the causes of vomiting in a young female? Give me the differential diagnosis of vomiting in young female.
The vomiting in young female, like as I told the Lawrence classification show like the young females might have the asthma. Coming to benign causes, there can be phytovisa or like phytovisa, and also like the corrosive poison causing pylori stricture for the like deformed pylori. And the also can be there like peptic ulcer disease causing cicatrizations. And there can be like the pancreatic pseudocyst causing the mass artery obstruction.
What is Wilkes disease?
The Wilkes disease, it's a common like due to angulation between superior and inferior aorta, it comes in the core part of the aorta, which causes the vomiting. Like
the difference between Wilkes disease causing vomiting and other cases of vomiting.
The Wilkes disease, it can be bilious vomiting will be there. So usually this gastrointestinal secondary to malignant like severe stomach can be non-porous, containing the food particles will be there, condensed food particles, whereas in Wilkes disease, the bilious vomiting will be there.
There's another important difference between Wilkes disease causing vomiting and vomiting due to other causes. What is the important difference? In all other causes, vomiting precedes weight loss. In Wilkes disease, weight loss precedes vomiting. That's the most important. So your case history is having weight loss afterwards. So delayed. So you're mostly suspecting clinically it's a case of cancer.
So basically, this is a young female, 25-year-old, with what you suspect as a gastric outlet obstruction. And you think it's a malignant etiology as opposed to a benign etiology. And what are the things in favor of you saying it's malignant? In the history?
Like the 2 months history of gastric, like the vomiting complaints are there. Where is the recent onset? And also like within 2 months, like she has significant weight loss is there, and the anorexia is there, and associated in the melena is there, which can be like low hemorrhages occurring in the severe stomach clots at least. And also like younger female most probably can have.
The age is probably against, I mean, basically, in young, somebody who's young, you think more in favor of a benign pathology, but other things in favor of malignancy you mentioned. Does this patient have dysphagia?
No, sir, she has no dysphagia.
Did you mention that? I don't think it is there. So I think in any upper GI related problem, when you are describing, I think it is very important to mention about dysphagia. Why is dysphagia important?
Like it can be happen in the like vaginal stomach, like involving GE junction tumors, like it causing dysphagia, can make like dysphagia cancers.
So if you get dysphagia because of, let's say, upper proximal gastric cancer, will it cause some vomiting like this? The predominant feature here is vomiting, right?
Vomiting
so
like
let's say you have a proximal gastric cancer or a junctional G junction cancer. Will vomiting be a predominant factor?
No, like mostly it will be like like the dysphagia content, like you take the vomiting immediately after food intake. Like if it is like the wound is not very narrow, she might have the complaints like normal.
So generally, vomiting is not a predominant feature. So if it is proximal gastric or in the junctional cancer, you get dysphagia as the predominant symptom. Vomiting is usually not seen because the esophagus cannot dilate that much to cause vomiting. Dilatation of the esophagus happens with benign conditions like achalasia, etc. So that is over a period of time. Okay, so this is a short duration history, and the esophagus will not dilate that much to cause something like this. So that is how you differentiate. But I think it is important for you to mention about dysphagia also.
Coming back to the symptoms that you rejected, when a patient presents you with upper abdominal discomfort or pain and vomiting undigested food, what are the other factors in history that you also identify?
Like coming to vomiting, we have to coming to pain, we have to ask about like the when pain is getting resolved. Like if it is getting resolved after vomiting, must be gastric like outlet obstruction on it. Like if it is like in gastric also, like it can happen. Like if it is relieving with food intake, it can might be the duodenal also, typical services.
What about postprandial fullness, early satiety? What do they signify?
The early satiety postprandial fullness must be significant the non-distance window stomach because the resistance within the stomach with involvement of muscular.
That is one. That there is the stomach as such may be not distensible because of growth along the gastric wall. That is one. Is there any other reason why they have
the mass occupying the stomach also?
That is also there. Any other reason why they can have early satiety? So one you said is mass occupying the stomach. One you said it's the stomach wall doesn't stretch. Third reason, because the stomach is already full. The stomach is not emptying, isn't it? The stomach is already full. So when they're vomiting, it's not that you eat and they vomit. It just goes on filling up the reservoir. At some point, they expel things out. So there are multiple reasons why they can have postprandial fullness. What about ball rolling movements? Is that, have you heard patients complain to you about ball rolling movements?
Like the patient, like one itself say like a chip contact. So like we like when we go with this she might have like she have doubt of feeling up.
Not necessarily, not necessarily. They can complain of ball rolling.
And you mentioned that there was no family history of we want with a history of no family history of malignancy. So what family history would you want to ask in this particular instance?
Like the family history, like the Buerger syndrome, like Lieberman syndrome, like P53 mutations, and FAP in like APCG mutation. And the HMPCC can also be there, and BFCA to also present it, like these are like the relation with the gastric carcinomas.
Those are more for colorectal, right? I mean, see, this is a young patient. She's 35-year-old, and you are suspecting malignancy. And family history is very, very important in this situation. So, what type of and you are suspecting gastric malignancy. So, what type of gastric malignancy do you get, which is familiar?
Diffuse type, sir.
What is that called?
Signet cell type. TDH1 mutations.
Yeah. So, what is that condition called? Anybody in the audience?
Lineages plastica.
That is all pathological or morphological things. I'm asking about a hereditary condition that can happen in the stomach, which which will fit into this category. Anybody in the audience or anybody, students? Yes. So it's called hereditary diffuse gastric cancer or HDGC. And as you write, the mutation is the E-cadherin mutation, but it's called hereditary diffuse gastric cancer. And it happens in young, associated with diffuse or signet cell, as you said. So those are association. But this is, and if you, in the history, which prominent figure had this diffuse, this familial history?
Like the Napoleon bone.
Yeah, okay, so you know that. So that was hereditary diffuse gastric cancer. Okay.
The examination will continue by Dr. Manoj.
Good afternoon, Professors and others. Myself, Dr. Manoj, and I'll be continuing with the examination. Coming to examination, patient was examined in a well-light room with consent in the presence of a female chaperone. She's a middle-aged lady, average build and poorly nourished with ECOG 3. Her height is 156 centimeters, weight is 35 kgs with BMI of 14.4. Patient was conscious, cooperative, oriented to time, place, and person, lying comfortably in bed and afebrile. Her pulse rate was 110 per minute, respiratory rate is 16 per minute. Blood pressure was 100/70 in right upper limb in supine position. She had pallor. Patient was dehydrated. She had no jaundice, cyanosis, clubbing, pedal edema, generalized lymphadenopathy. Examination of oral cavity. She was having poor oral hygiene. On inspection, abdomen was scaphoid. Abdomen was central and inverted. All quadrants move proportionately with respiration. A lump was visible in the epigastrium of size approximately 5 into 4 centimeter, round in shape, moving with respiration. And this is the lump, image showing the lump. Umbilicus was central and inverted. She had no evidence of visible peristalsis. She had a visible scar over the lower abdomen, probably a financial incision. She had no evidence of sinuses or engaged veins or pulsations. Seminal orifices were free. She had no fullness in the left supraclavicular region. Genital examination was normal. She had no renal angle fullness. On palpation, abdomen was soft and non-tender, no hepatosplenomegaly. A hard nodular mass of size 6 into 5 centimeter, palpable in the epigastrium with irregular shape, well-defined margins, non-tender and moving with respiration. On head rising test, mass becomes less prominent and assuming lateral decubitous position, mass falls forward, probably an intraperitoneal swelling. On percussion, liver dullness was elicited on right hooked intercostal space in the midclavicular line till lower costal margin with a span of 12 centimeters. On percussion over the months, impaired resonance was noted. And on auscultar percussion, stomach borders were delineated above the umbilicus with normal resonance. There was no clinical evidence of any free fluid. On auscultation, normal bowel sounds were here. Succussion splash was noted, no fluid. On rectal examination, stool staining was normal, no evidence of any melena, no deposits were noted. Other system examination was normal, respiratory system, cardiovascular system, and CNS. To summarize, a 35-year-old lady without any comorbidities with the chief complaints of non-bilious vomiting containing recently ingested food particles for 2 months, along with history of abdominal pain and abdominal lump, loss of appetite, loss of weight, postprandial fullness, and ball rolling movements, with examination findings suggestive of palpable epigastric lump with succussion splash the most probable diagnosis can be gastric outlet obstruction, secondary to distal gastric carcinoma.
We just go back to your inspectory findings. So basically, yeah, go one more slide. Okay, so if you show that photograph, so the mass that you're having, you're able to see a swelling here, right? And this, yeah, you're able to get all around, like you marked it here. So all the borders are palpable.
Yes.
Correct. So you're able to get above, below,
Yes.
all around the swelling. Yes.
Yes, sir.
And you mentioned this swelling moves with the respiration, or it doesn't move with the respiration?
Swelling moves with respiration. Even on inspection, I can see the swelling moving with respiration.
Okay. And why are you saying this is a stomach swell? That's your final diagnosis, right?
Yes, sir.
Yeah. So what are the features in favor of you know, both inspectory, palpatory, everything that you say it's a stomach swell?
Sir, with the history suggesting of the swelling is in the epigastrium, sir. So it moves with respiration.
This is sort of, it's lower than the epigastrium. Predominantly, it's where your mark is very umbilical. Okay, so it's lower down. It's definitely not a distended stomach, right?
No, sir.
What you've drawn is
Not a distended stomach, sir. It was a mass.
Yeah. So then you're saying there was no visible peristalsis, there was no visible gastric peristalsis, was there?
No visible peristalsis, sir. Even we have tried giving water. Patient was actually, when we examined the patient, RT was there in situ. Through RT, we have given 700 ml of water in 10 minutes. And we were waiting, we couldn't see any visible gastric peristalsis.
So my question is, then why are you saying this patient has got gastric outlet obstruction?
Sir, first based on symptoms, sir. And an examination, succussion splash was noted.
So how did you check for succussion splash?
Patient should be NPO for liquids for 2 hours and solids 6 hours. And I'll keep the bell of the stethoscope over the distended stomach, and I have to shake the stomach. I can hear some splashing sound.
Yeah. So, see that will be quite subjective also, but basically there is no visible gastric peristalsis. There is no distended stomach that is seen. And what you're describing is a lump in the epigastric/umbilical region. And there is no dilated stomach that's seen, right? Based on this, I mean, because you can get vomiting due to various reasons in carcinoma stomach, right?
Yes, sir.
What are the various reasons where you can get vomiting?
Sir, stasis of contents, one thing. If there is complete gastric outlet obstruction, or associated gastritis can be there, stasis gastritis, that can also cause vomiting. And over distension of stomach can also cause vomiting.
And loss of distensibility can also cause vomiting.
Loss of distensibility,
yes. Patient cannot take the food also. So there are so many things that can be associated, the reasons for the vomiting.
Yes, sir.
And also you describe this vomiting as, you know, recently ingested food. So basically she takes food and after 2 hours she vomits. Is that
in this patient, it was after 1 hour, 1.5 hours.
Yeah.
It was variable, sir.
Yeah. So normally in gastric outlet obstruction, it is somebody, the vomiting is yesterday's food. Like, you know, it's like food that is taken not just now. So that is classical of gastric outlet obstruction, where the food stays into the stomach, gets over distended, and it reaches a point where the patient self-induces the classical history of gastric outlet obstruction. Okay. So here, your history is not typical of gastric outlet obstruction, number one. Number two is you do not have a distended or a visible, the swelling that you're describing is not a distended stomach. It is perhaps a mass in the stomach or whichever, but it's not a dilated stomach. So that is why I'm questioning your diagnosis of a gastric outlet obstruction. I mean, your diagnosis might be right, but clinically, how can you say this patient has got a gastric outlet obstruction?
So,
neither your history nor your clinical findings seems to substantiate your statement.
So, Probably in examination, since RT was there, the distension could have come down, sir. And
So, and also it is like the line is plastic. Contradicting yourself when you say you could hear sufficient splash, then you're saying there's RT, so therefore then nothing could be elicited.
no, sir, succussion slash I have done first stage. Once when I have seen the patient.
Despite your having.
No, sir. Actually, we have done that, sir. Last night, the previous night, we have given saline. We have clamped the RT. Early morning, we have checked for succussion slash. When we came in the morning, we have checked.
Despite this much, you still have not been able to demonstrate gastric peristalsis.
Yes, sir.
So that's what sir is saying, that there is vomiting, agreed. There is a growth, I mean, there is a lump, agreed. But is this causing outlet obstruction or is it because of a loss of distensibility? Because your diagnosis clearly specified gastric outlet obstruction as the mechanism for vomiting. So that is where the question is like.
Yes.
What are the other masses which can present at the epigastric region apart from the stomach mass? Differential diagnosis of epigastric mass.
Pseudocyst pancreas.
Okay.
Any gist of stomach, lymphomas.
Okay.
Primary GA lymphomas. And any mass in the left lobe of liver extending to the epigastrium.
Very good. Yes. Left lobe tumors.
Left lobe tumors.
Very common, especially in South India, in Tamil Nadu, on another problem. Due to TB. A rolled up momentum. Rolled up momentum can also cause a mass there in the epigastric mass. How to differentiate whether it is a lobe liver mass or a stomach mass?
Resonance based on percussion.
Yeah, based on percussion, there will be a band of resonance. Okay. If this mass is not moving, does it mean it's a pancreatic mass or not moves with respiration? What do you see? What does it signify?
Sir, it can be a pancreatic mass or it can be a stomach mass which is infiltrating the pancreas.
Very good. Yes, if it is infiltrating into the pancreas, it will not move with respiration. If it is a pancreatic mass, it will not move with respiration.
Yes.
Is there a chance that pancreatic mass can be mobile? Any pancreatic mass can be mobile?
Any benign conditions?
Yeah.
If it is serous adenoma of pancreas.
Yes.
Any pedunculated
any cystic neoplasms which are more protruding, they can also sometimes move mobile.
Yes, sir.
So what is Bate test? Bate sign. Anybody? What is Bate sign? It's used in pseudocyst to differentiate pseudocyst from epigastric. In epigastric mass, they will definitely ask, old examiners will ask this Bate sign. Bate sign is, you put a Wright's tube in a very thin patient like this, we can roll the Wright's tube on palpation. In which condition? For whom we can roll the Wright's tube on palpation? If it is a pseudocyst. There's a differentiation between pseudocyst and other epigastric mass. Bate sign. So old design. People are not doing now, but it is for pseudocyst, we can roll the Wright's tube on the abdomen. Only for thin patients like this, we can do that. Yes, sir.
Just to add one more, you were mentioning about differentiating the left lobe of the liver and stomach. So just tell us the clinical findings, how we will differentiate left lobe of the liver and stomach.
Sir, we have to stratify the liver dullness. Then we have to continue towards the epigastrium. So with that, we have to check whether the dullness is continuous with that dullness of the mass which is felt there.
So any other clinical finding that will differentiate? So basically, if it is the left lobe of the liver, will you be able to get above the swelling?
No, sir. Getting above the swelling is not
possible. Most of the stomach swellings also you will not be able to get above if it is arising from the frontless body, etc. Just that the site where you have drawn itself, like that's why I question. But generally, stomach mass also you won't be able to get above the swelling because most of the stomach is under the rib cage. Okay, except probably like I'm talking about an undistended stomach. Okay, normal location will be under the rib cage. So here you have drawn much lower down. But the left lobe, upper body you won't be able to feel. Stomach also mostly upper body you won't be able to feel unless it's a pyloric. Okay. Second thing is, if it is in the epigastric region, then what other thing you will do to differentiate between the left lobe and the stomach? One is percussion you mentioned. Anything else? Anybody else? To differentiate between the left lobe of the liver and the stomach mass, an epigastric mass. He said percussion. Both, let's say you're not able to get above the swelling. Any other clinical finding to differentiate? Yeah, somebody's finger insinuation, correct? Is that what you said? So basically, you try to insinuate your hand between the costal margin and the swelling. So which one will you be able to insinuate?
If it is liver, sorry, if it is an epigastric mass, we can insinuate
The stomach mass, basically, the liver lies closer to the costal margin. Sorry, your costal margin on the skin compared to the stomach. So stomach is even more, posterior. So therefore, if it is a stomach mass, maybe you won't be able to sort of insinuate your entire hand, but at least the tip of your finger. In the left lobe of the liver, you won't be able to. So insinuation of your hand may not be possible between the costal margin and the mass. So that is again differentiating feature. And of course, percussion. So all these things to differentiate between the left lobe of the liver and stomach.
On examination, what findings, in addition to what I've told us, they will tell us that this disease is probably an advanced.
So first of all, palpation of a mass itself
on general examination will something tell you.
Lymphadenopathy, sir. Left supraocular lymphadenopathy.
Even before that, can you get a clue? Jaundice.
Jaundice.
Presence of interest. Then general lymphadenopathy. It's right. No, you should list rapidly. It's not a tough question.
I didn't know if the liver and system was nodules.
Okay, umbilical nodules, yes.
Deposits in rectal examination.
Okay. Then
and palpation of a mass tells that it is an advanced disease crossing the serosa.
Okay. Not so clear. Liver, can you palpate liver with secondaries?
Yes, sir. Nodular deposits in the liver can be palpated.
What else? Significant ascites.
Ascites, presence of free fluid.
And you also sometimes palpate peritoneal deposits. You have multiple masses felt in the abdomen, indicating over different entities.
Yes, sir.
Being a female, another important mass we should mention. What is, especially she is a premenopausal broken. Yeah, you should palpate for a pelvic mass. Sometimes premenopausal young lady, if it is a spreading tumor, first it will spread to ovary. What is the mode of spread to ovary?
Transcelomic spread.
It's a transcelomic spread. Why it is happening only in premenopausal women, not in postmenopausal?
Like the follicles are
and in premenopausal, the ovulation time, the follicles rupture in the dry area, the tumor deposits will happen. That is, therefore, it is bilateral, seen in premenopausal women. It will be definitely seen as the first spread in most of the cases.
Yeah.
We have another 12 minutes left. So basically, what is your clinical diagnosis based on your investigation?
Investigations.
No, what is your clinical diagnosis based on your findings?
Carcinoma in the distal stomach.
So basically,
probably secondary to malignant cause. The symptoms are class of white, class of pupillary. So
you think it's a gastric malignancy?
Yes, gastric malignancy.
Any other differential diagnosis?
Can be GIST also. Patient was complaining of intermittent episodes of melena. In this unpalatable mass in the epigastric can be GIST also.
Okay. Any other?
No, sir. That's it.
Okay. So basically, based on your finding, you're thinking you're narrowing it down to only gastric.
Yes, gastric
pathology.
Okay. And so she was not having any previous episodes of abdominal pain. I go towards malignancy.
So how will you proceed with this patient?
Sir, initially I wanted to do an ultrasound.
Before that, you should do some
routine investigations.
It's a basic MBBS question. Patient is admitted in your ward. Now, what should you do next? Not
the patient is having multiple episodes of vomiting. We have to decompress the stomach.
Then,
patient is dehydrated, so we have to give IV fluids. We have to stabilize the patient.
What fluid should you give?
Normal saline with potassium.
You should give only normal saline with potassium. That should be the first step. You have to look for electrolytes. Electrolyte in the patient for serum electrolytes, and you should first put a white bore rice tube and correct the electrolyte imbalance. Yes, sir. Patient may die of hypokalemia in the ward. Okay, we have to immediately correct the electrolyte imbalance. That is the first step. Then only you should go for. Then only you should tell I will do further investigations. Yes, sir. You can.
Since you mentioned that this dehydrated patient, what precautions will you take before you give IV hydration with potassium?
But mutual like they will not put it adequate and
Why? Can you explain why?
because like the renal like in kidney injury cases like it can affect potassium, it can cause hypertension. It's more dangerous.
So it's very important that you ensure that adequate urine output before you start correcting potassium. So the first thing to start off is normal saline, and then once you're sure that there is good renal perfusion, patient is putting out urine, then you start adding potassium.
Yes, sir.
So what would you do? What is your investigation for confirming your diagnosis? So you do your, so what was the hemoglobin?
So hemoglobin is 8.3.
Okay.
Other parameters are within normal terms, routine blood investigations. And we have done an upper G endoscopy. In endoscopy, circumferential growth was there in the antropolaric region, extending to lesser curvature. Scope was not able to pass beyond. And we have done a CT. So we'll just play the video. It is a contrast enhanced CT of thorax, abdomen, and pelvis. Arterial phase we are playing, sir. And here you can see a distended stomach with RT in situ. Mass can be seen in the antropolaric region extending to D1. Complete narrowing is there with some perigastric nodes, and free fluid is also there, sir, in CT.
So basically, there is an obvious mass in the stomach, in the
Yes,
part of the stomach with proximal dilatation.
Yes, sir.
So, what else do you want to comment on this CT scan? It's an arterial phase we mentioned.
Yes, sir.
What are the other things you want to know in this?
Sir,
So this is in the distal part of the stomach. You got a mass.
Yes, sir.
If you just show that mass again. But what are the things you want to look at? So you want to look at local extent. You want to look at whether there is any systemic.
Signs of inoperability.
Distance spread.
Yes,
so local extent. What do you comment? How will you say? What are you going to say?
Signs of inoperability. It is actually abutting the.
Yeah. So local spread.
Local spread. Signs of inoperability like involvement of pancreas, and in this patient, transverse colon is abutting in the CT.
So where is the pancreas? Is it?
We cannot see there is we cannot see any obvious pancreatic infiltrate in this patient, sir.
Yeah. Why do you say that?
Sir, it is a fat lines are there, main thing.
So you mean to say there is a fat plane between the pancreas? So that is to say there is no infiltration.
Yes, sir.
But in the head of the pancreas, is it still okay? If you are in doubt, okay, let's assume that this is okay. But if you are in doubt, what else can you do? If you have a mass in the distal stomach, and there is a doubt of whether it is infiltrating the pancreas, there is no clear claim.
Endoscopic ultrasound can be done.
No. CT scan. Okay, so you can go. So you just change the position of the patient and see whether the stomach falls forward. So if it doesn't fall forward, obviously there is infiltration, because in a very, very dilated stomach, it's hard to comment because the stomach will be compressed on the pancreas anyway. It's quite distended also. Okay. And of course, you also need to comment on perivascular nodes, peritumoral nodes, whether there is any nodes around the stomach and digestive areas.
Yes, sir.
Whether there is any omental spread, like whether there is stranding of the omentum, etc. Okay, so these are all things. And it's a female. You want to say anything about the
Normal, sir.
sorry, ovaries are
Normal.
Why is that important? Okay, and is that for all women or in any particular age group or premenopause? So she's premenopause, right? So it's important to comment on the.
Yes, sir.
And it's
The other thing also is to look at the vascular anatomy. See, if you're going to do the sectional surgery, more particularly you mentioned arterial phase, you can look at the arterial, whether there is any vascular arterial anomaly, aberrant left gastric, etc. So that will help with your surgery also. So all these things you need to tell in your CT scan. Okay.
And biopsy was suggested of adenocarcinoma, intestinal type, totally differentiated adenocarcinoma. And free fluid was there. Cytology was suggested of malignancy, so it is a metastatic carcinoma. My final diagnosis across the investigations will be metastatic biopsy, totally differentiated intestinal type adenocarcinoma of the distal stomach with stage of T4B, N3, and M1.
How was the ascitic fluid taken by ultrasound
Guided.
So why are you saying M1?
Sir, peritoneum is involved.
The ascitic fluid is.
Cytology is acids.
So you can actually get, but there is no obvious. Let's assume that there is no obvious spread, and a doubtful sort of. Let's say your ascitic fluid cytology is also sort of not very clear or doubtful. What, in other words, what other investigation, staging investigation can be performed to clarify that? Okay, it's called a staging laparoscopy.
We can
to look at whether there is, if it is still doubtful,
obvious.
you can do a staging laparoscopy because it can pick up small volume peritoneal disease, which may be missed on all these things. Okay. But if you, let's assume you do a staging laparoscopy, there is no other peritoneal disease. Okay, only your cytology is positive. Okay, so assume that this is adenocarcinoma, stomach, no peritoneal disease on staging laparoscopy, only cytology is positive. So what stage will it be? Will it still be a what? Okay, so it will, the answer is yes, it will still be M1. Even if the cytology is positive, it will be M1. Okay, because it definitely has got a poorer prognosis. Now, based on this staging, this is the clinical staging you have got. Okay, based on this clinical staging, how will you proceed?
Initially, currently patient is in gastric outlet obstruction. So dehydrated also. We have to optimize the patient. My plan will be, final plan will be palliative only. So initially we have to manage the patient according to the symptoms. So we can either try a nasogeminal insertion, nasogeminal tube insertion, or if the patient is getting optimized well, we can proceed for any palliative procedures like loop gastrojejunostomy to relieve us from obstruction. Stent also can be placed, sir, but in concern of the disadvantages of the stent and migration and other complications, GJ will be a better option for us, young women. So we can also try for since only peritoneum is involved, we can try for cytodetective surgery with hyper.
You're going into controversial areas. Okay, so I think you stick on to the basics for your exam. I think you should stick to the basics. I think what you said up to here probably acceptable. But I think when you have a diagnosis like this, where you have M1 disease, what other tests will you do? I think it is, see, you're saying what palliative? So her symptoms are vomiting and she's got obstruction. So one is you need to relieve her obstruction. Okay, that is palliation. And you said that I think stenting will be difficult in this patient because it's quite a bulky disease. So one option is to put an esophageal tube endoscopically, try to build up her nutrition and then give her some chemotherapy. The other option obviously is to do some sort of a bypass to this. Stenting may be difficult here. So in addition to this, what other tests will you do? Let's say if you've decided to give her some palliative chemotherapy.
Liver function.
So you will do HER2 testing. Okay, so HER2, because what is that? What is HER2? Okay, so basically you can give targeted chemotherapy using TRAS2, almost similar to breast cancer, because if they are HER2 positive, then you can give this targeted chemotherapy. They have got a worse prognosis, but you can at least give targeted chemotherapy. Okay, so any other testing you can do? So basically, the question is, what are some biomarkers? These are all biomarkers in carcinoma stomach. One is HER2. Any other biomarker that you can do so that you can give appropriate targeted therapy? That is the drug.
Any tumor markers?
So, what are the biomarkers that are available? So this is a straightforward question. So in carcinoma stomach, what are the one is HER2? Then have you heard of MSI?
Yes.
So you can look at MSI or microsatellite instability. It's done for both colonic and gastric cancer. The third one is it's called PDL1. Okay. So these are the three biomarkers that can be done in carcinoma stomach. So if you've got particularly advanced and metastatic carcinoma stomach, these are the three things, biomarkers you would do. If it is HER2 positive, you can give trastuzumab. MSI status, why? MSI and PDL for immunotherapy. So basically, if it is MSI high or if it is PDL1 positive, then you can give immunotherapy for these patients. So obviously, availability, all those things are. But I think for you, for your exam, you should be able to tell this because these are all things that have come up in the recent past. And it can make a difference because immunotherapy, although it is cost to the exorbitant, it is something that you should be aware of. Okay.
Hope you read Sabiston 21st edition. Sabiston 21st edition, what does it say regarding staging laparoscopy when there is a positive peritoneal wash? What will you do? Yes. And there is a positive peritoneal wash. What will you do? Anybody? We are doing diagnostic laparoscopy for an operable case like this. And when we are doing a staging laparoscopy, we are doing a positive wash. We will wash the fluid and send it for pathological examination. It is showing positive malignant cells. What is the next step? Is it operable or inoperable? It is a metastatic. Therefore, what we will do is we will give a neoadjuvant chemotherapy for one course. So three cycles of neoadjuvant chemotherapy is given. After that, we have to again do a staging laparoscopy. And during that time, if there is positive peritoneal cytology is negative, it's an operable tumor. This is from latest Sabiston. So just if you go through the book, you will understand. This is a new point from new Sabiston. Old edition was not mentioning it. New edition has mentioned this point. So you can try a neoadjuvant chemotherapy and you can plan for a staging laparoscopy after 1 or 2 months. Meanwhile, you can do a GJ also now presently. That is the one option, better option for this patient. Yes.
So basically, you have this situation. Suppose this patient had bleeding also. So you said melena, right? Did the patient have melena? Melena. So you have two problems now. You have gastric outlet obstruction. You have melena also. So if you do a GJ, it's not going to sort out the melena problem. So how will you address the melena problem? So the palliation, two things. In gastric malignancy, one is bleeding, the obstruction. So you've talked everything about obstruction, but you have not addressed about the bleeding problem. So say her hemoglobin was 8 to start with. You do it again, it's 6 now. So what will you do for her?
If from 8 to 6 means it is
Bleeding.
massive bleeding.
No, it's not on one day. So basically she's dropping her hemoglobin. She's bleeding somewhere. It's not like profuse bleeding where you need to do something straight away, but obviously she's dropping her hemoglobin. She's continuing to have, let's say,
Hemostatic RT. Hemostatic RT.
Good. So one option is to give hemostatic RT. What is the other option? We'll probably finish because we are running out of time. So surgery, how will you do? Because it's metastatic disease. Right? What is the other option that you can do to stop bleeding?
Vascular embolizations.
Embolization. So basically you can do TSA and embolization to stop address the problem of bleeding, because you can't do resectional surgery at least till because you have an M1 disease here. So to address the problem of obstruction, maybe a bypass, but more importantly, you need to address the problem of bleeding, because with bleeding you can't give any chemotherapy, you can't give any other treatment also. So for that, maybe you address it with radioembolization. Okay.
What is the chemotherapy regimen given?
ECF regimen for perioperative chemotherapy.
Morning, sir was teaching. This new regimen has changed. Sir only was taking the
Slot.
Yes.
Slot. 4 cycles of slot.
Okay. Thank you.
Thank you.
Very good.
Thank you. So basically, exam, you need to stick to your basics. Okay. So you need to be able to substantiate what you say in terms of your clinical findings. Suppose you say vomiting, gastric outlet obstruction. It needs to fit into that, thing. So whatever you say, you need to be able to substantiate it, with your answers. So that is number one. And I think the discussion, I think you did well. Need to know the recent advances, particularly immunotherapy, the biomarkers, all that. I think just refresh their exams.
Thank you.
Any other questions from the students from the audience? Okay, thank you.
Thank you.
Thank you, sirs, for that edifying session. I now request the examiners to award certificates of presentation to Dr. Kedar. And Dr. Manoj. Thank you, sirs. We shall now break for lunch. Lunch is being served in exam hall 1 in 3rd floor. Kindly reconvene in 45 minutes at 2:15 for the afternoon session. The afternoon session, we shall begin with the case presentation on obstructive jaundice. I also request the following e-poster participants to report at the registration desk. Dr. Dinesh, Dr. Mamta, Dr. Pachuri, Dr. Dharmik, Dr. Varsha, Dr. Deepika, Dr. Gopi Krishna, and Dr. Pranav. Dr. Avinash, Dr. Dinakar, Dr. Manoj, Dr. Rajalakshmi, Dr. Varsha, Dr. Kedar, Dr. Likita, Dr. Nandakumar, Dr. Jibitosh, at the registration desk, please. Thank you. by Dr. Pawan Kumar and Dr. Furkan on obstructive jaundice. I welcome Dr. Ananthakrishnan, Dr. Suresh Kumar, Dr. Raja Mahendran, and Dr. Anandi to be examiners for the presentation. I request all to be on the dais.
Good afternoon to all respected faculty on the dais and my colleagues. I'm Dr. Furkan and this is Dr. Pawan. Today we'll be presenting a case of obstructive jaundice. Our patient was a 52-year-old lady, recently diagnosed diabetic, resident of Kadalur, a housewife belonging to those with economic status by modified performance state. She presented to us with chief complaints of yellowish discoloration of eye since 2 months. The patient was apparently asymptomatic 2 months ago when her relatives had noticed yellowish discoloration of her eyes. Since then, the patient has noticed that the yellowish discoloration has been deepening. On probing, she gives us a history of high colored urine, pale stools, and itching. The patient has noticed that she has had a lot of weight, but it is not quantified. Though she does say that she has loosening of clothes. Patient has been complaining of generalized weakness and easy fatiguability since 1 month. The patient has no history of abdominal pain, no history of episodes of fever or chill, no history of nausea or vomiting. She is not having any altered bowel habits, and she is not giving any history of melena hematemesis. She is not giving any metastatic history, or she is not giving any history of previous dust transfusions. She has had no similar complaints in the past. There is no history of surgeries or endoscopies in the past, and there is no chronic drug intake other than the medication for diabetes mellitus. She was diagnosed as a diabetic 5 months ago at a local hospital when she had complained of increased frequency of urination and increased urination during the night time. Since then, she has been started on oral hypoglycemics and insulin, and she has had full control with both of these, which was informed to her by her doctor. Because of the increasing jaundice, she had gone to a local hospital where she had underwent an ultrasound scan, but the scan was not available with her, nor does she know the details of the scan. From there, she was referred to JIPMER. The patient consumes a mixed diet. There is no loss of appetite. There is no history of altered bowel bladder habit other than the pale colored stools and high colored urine. The patient has no addictions and there is no complaints of disturbance of sleep now. There is no significant family history. The patient attained menarche at 13 years of age. He had had northern menses, married 20 years of age, and had first childbirth at 22 years, second at 25 years. Not undergone any family planning surgery, and attained menopause at 50 years. Summarizing the case, this is the case of a 64-year-old postmenopausal uncontrolled diabetic, which was newly diagnosed with complaints of painless progressive jaundice, high colored urine, pale stools, and itching for 2 months, associated with loss of weight, generalized weakness, and easy fatigability. She has no other significant positive history, and she is not having any other systemic complaints.
It has pale stools, you said. Okay. So you should not say no history of melena. The two will not go together. If there is total obstruction, acolic stools, how will you have melena? Small things like this will raise the irritability quotient of the examiner. Were you there in our institute last time presenting a case? No.
In this case, I remember
what is that? Okay, so be careful about getting melena, right? So what are the salient features? Can you summarize?
So the patient, a 64-year-old lady, recently diagnosed diabetic and it is not controlled.
She has had progressive jaundice with more progressive jaundice, which looks like obstructive because she is having associated complaints of high colored urine, pale stools, and itching since 2 months. Along with this, she is having generalized weakness, irrefatigability, and loss of weight, which is not quantified, but she is having complaints of loosening of clothes. And other than this, she is not giving us any other qualification.
Even without any other information, what will be your conclusion with a history like this?
So with a history like this, first I would like to collect all the data that I have. In that, the patient is having
the data that you have.
Now, next thing I would like to connect the data.
Unless you are keeping some secrets from us.
I would like to connect the data to each other. So one way of connecting is this jaundice along with high colored urine and pale stools and itching. It's fitting a pattern of obstructive jaundice. So I will keep obstructive jaundice in mind. Whereas
that the patient will come and tell you. In fact, the husband will tell you. He is the fellow who first noticed it. What could be the cause? That's what I'm saying.
So classically, painless progressive jaundice, along with features of generalized weakness and constitutional symptoms, I would think of malignant cause. Mostly classical lesion phase painless progressive carcinoma of pancreas would be my initial diagnosis.
No, anatomical will not go. It's probably malignant obstructive, unless proved otherwise. But what is this painless? Because when you say painless, what is it that you mean?
Patient is having progressive.
They won't have pain at all? Zero pain? If you have a pain scale?
They are not having.
Because one of the ways carcinoma pancreas spreads is by perineural lymphatics infiltration. That's why they have significant pain. So what is this painless jaundice?
In head of pancreas, tumors initially they won't have the pain. Though they can present as pain, again, as I said, it's classical treatment is painless.
They will always have a dull ache. When you say painless, what you mean is biliary colic type of pain. Not that it is absolutely painless. Right? That's the nature of the disease. That's how it spreads. Whether it's head, body, or thing. Only thing, body will be much more likely to have significant pain compared to head or tail. Because of its proximity to the plexuses. Right? Okay. So be careful some of these terms. Painless doesn't mean no pain. It means no colic. Okay. Good. On probability is probably malignancy. Okay.
What are the causes of painful jaundice? So painful obstructive jaundice first would be stone disease, which is leading to cold local caries and cholangitis. Any other cause of cholangitis will lead to painful jaundice. And other than that, some malignancies which can lead to post-herpetic secondaries like gallbladder malignancy can also present with pain. Causes of painful jaundice are number one. Cholangitis. Cholangitis in any jaundice will cause pain. Number one, pain along with, but it will be associated with fever. There is no fever so far. So painful jaundice is due to cholangitis. In any type of jaundice, you get cholangitis. Stone disease, number one. Number two, sir told carcinoma of the pancreas will also have pain. Definitely, when a cancer pancreas is causing jaundice, it will definitely cause pain. I don't know where you have learned as painless progressive jaundice in cancer pancreas is very, very rare. But one important history which is favoring of cancer pancreas in this is called recent onset uncontrolled diabetes is one of the early symptom of cancer pancreas. That is more favoring of cancer pancreas. You might have asked the patient would have had dull aching pain. Definitely should have not told you. Yeah, should have had a dull aching pain. Number two. Number three, hilar cholangiocarcinomas also will cause pain. So the painless jaundice are more in favor of distal bile duct cancer and periampullary cancer. These are the two cancers which are painless. Distal bile duct cancer will have progressive painless jaundice. Bile duct periampullary cancer will have what type of jaundice? It will have painless intermittent jaundice. The only jaundice cause for melena in a case of jaundice patient will be probably the patient had a sloughing of the tumor. So melena with the clay stools, what do you call that stool as? This is called silvery stool. It's the Thomas sign. It is Thomas sign. It is a silvery stool. It is known as silver stool or Thomas sign. That is the reason for that. Yes.
See, in this progressive, there are three terms you must be aware of. Jaundice, progressive, intermittent, and remittent. Are you aware of the differences?
Yes.
What are the differences?
Remittent jaundice.
Just like fever, the same definition.
Yes. Remittent jaundice, the patient will touch baselines in between. That is, there will be.
No, that's intermittent. Intermittent. In between, bilirubin will be normal.
And
when does it happen?
Stone disease can happen.
Calculus disease. Mostly gets impacted, disimpacted, becomes normal, again gets impacted. So in between, it will be normal bilirubin. Remittent?
That will happen because of the sloughing off phenomenon. Whenever there is a sloughing off, that time there will be leaves of jaundice, but not completely.
Yeah.
And then
There is a fall in bilirubin, but it will never touch normal. And then progressive, of course, there is no, right?
You have asked about history of surgeries. What are the surgeries which are associated with jaundice?
Main surgery that I would ask for is laparoscopic cholecystectomy because iatrogenic injuries or strictures are very common.
Okay, so you are asking for a laparoscopic cholecystectomy. Okay. Is there any other surgery which can cause jaundice during some other surgery?
Any surgery?
Yeah, any surgery in the upper GI by accidentally they would have tied the, especially gastrectomy or any surgery when they are doing D2, accidental tying of the bile duct, something can also cause this thing. Okay. And important thing is we should ask about any procedures like ERCP previously done. Some patients will tell 3 years, 4 years back I have done a ERCP sphincterotomy was done. When you ask them, they will tell that. They will not think it as a surgery. It is a procedure. So they will not tell it is a surgery. Okay, that also you should ask.
Yeah, we had asked for endoscopy because like commonly
no procedure was done. Yeah.
Only
before going for the examination, in the history you told about there is no relevant family history. So I would like to know what relevant family history you asked and.
So firstly, I would ask for any history of cancer, mainly for pancreatic cancer, any other gastrointestinal cancer in the family. By this, I would try to rule out the syndromic associations that are present. Secondly, I would also ask for chronic pancreatitis history. Familial pancreatitis can also lead to carcinoma of pancreas, but in this case, again, it is not having pain, so that is not.
So how common it is? How many percentage of patients you are thinking that coming into the familial history? How common it is? Like how many percentage? Familial.
2 to 5%.
5 to 10% is familial. So in those familial also you have two category, right? What are they?
The familial,
whether it is familial or
hereditary. So
known genetic mutation, which is common.
80%
is familial. Proceed to the examination.
Coming to the examination, patient is examined in a natural light in presence of female chaperone. She is conscious oriented. She is moderately built and poorly nourished. Her BMI is 16.2 kilograms per meter square, and she is ECOG status 1. Her hydration is fair, and she is afebrile. Icterus is present. There is no pedal edema. There is no sinuses or clubbing. There is no generalized lymphadenopathy. There are no signs of liver cell failure. There are scratch marks all over the abdomen, thighs, and arms, and there are no other skin findings of peripheral malignancy. Coming to her vitals, 76 pulse rate is 76 per minute, good volume, which is regular, measured in right radial artery. BP is 110/80 millimeter per Hg, measured in left arm in sitting position. Respiratory is 14 per minute in abdominal thoracic type. Her RPS is 278 per deciliter. Coming to the abdominal examination, on inspection, abdomen is flat, umbilicus is central inverted, all quadrants move equally with respiration. Her flanks are free. There are stretch marks present over the abdomen. There are no sinuses, veins, or visible peristalsis. Hernial orifices show no cough impulse. There is no spinal deformity, no renal angle fullness, no supraclavicular fullness. Coming to palpation, there is no local rise of temperature or tenderness. Liver is palpable 3 cm below costal margin at mid-clavicular line as well as mid-axillary line, which is non-tender, which has rounded edges, and there is smooth surface, and it is of smooth surface and firming consistency. A soft globular, non-tender swelling palpable in the right hypochondrium along the mid-clavicular line with a smooth surface and well-defined margins. Superior margin was not made out, and the mass moves with respiration. There are no other masses palpable. There is no splenomegaly. There is no spinal or paraspinal tenderness. There is no renal angle tenderness or mass palpable. There are no supraclavicular lymph nodes palpable. On colorectal examination, there is normal tone, no mucosal irregularities, pale color stools are seen, and there are no rectal deposits. On percussion, there is no shifting dullness. Upper border of the liver dullness is present at the fifth intercostal space at mid-clavicular line. We have examined the liver at mid-axial line also. Liver span is 14 centimeter along mid-clavicular line, and along mid-axillary line it is showing around 16 centimeter. Drop space is resonant. On auscultation, normal bowel sounds are good. Other system examination, there is no CVS and RS is normal, and CNS shows no focal neurological deficit. Coming to the summary, she is a 64-year-old lady with a new onset uncontrolled diabetes, present with obstructive jaundice for 2 months, associated with loss of weight and easy fatigability. She has no other significant history, and examination revealed hepatomegaly with a palpable gallbladder and no other significant findings. And our provisional diagnosis want to give is obstructive jaundice probably due to a malignant cause, most likely to be head of pancreas or periampullary carcinoma.
Even in intracystic obstructions, when will the gallbladder not be palpable? Malignant obstruction.
It's a partial obstruction. It's a partial obstruction.
Okay.
And the gallbladder itself is involved.
Intracystic, below the junction of the cystic duct.
Yes.
Previous cholecystectomy, anything else?
Take the mic, it's not audience. Take the mic.
Because of stone disease, gallbladder is not palpable. Previous history of cholecystitis.
Yeah.
With the stone
Previous calculus disease. And anything else? Sometimes periampullary ulcerates, decompresses, gallbladder will collapse, then may not be palpable, and then occasionally the gallbladder is intrahepatic, doesn't protrude, so you won't be able to feel it under the liver. So there are lots of exceptions to the pulverization, one or two, many exceptions. You must remember that before you attach significance to a palpable gallbladder.
A common finding to have a palpable gallbladder, because here you are thinking about malignancy, right? What is the most common presentation of the periampullary carcinoma? Most common clinical presentation.
Jaundice.
Jaundice, 75%
is jaundice, 50% weight loss, and 39% pain.
So where is a dilated gallbladder, palpable gallbladder? How many percentage will have?
It will around 5 to 10%.
1/3 of the cases. Only 1/3 of the cases it will be palpable. Otherwise, it won't be palpable. It's not a very common finding.
Where all the places did you look for jaundice?
Sir, we have looked on sclera of the fingernails and mucosal surfaces, oral cavity.
Under surface.
Under surface.
That will be the jaundice first. According to suggestion, first one will be under surface of the tongue, and it will be in the under surface, and if you last will be in the skin. So skin pigmentation is a lot. Why there is itching, scratch marks. So itching, many theories are proposed for itching in obstructive jaundice. Initially, the theory that we learned as undergraduates was histamine gets there will be accumulation of bile salts or bile crystals, which will irritate the nerve ending. One thing. Second thing, it will lead to release of histamine, which can lead to again irritation of the nerves and itching. Then the next theory proposed was serotonin theory. Instead of histamine, they said that serotonin will be reduced and increased, and that's why they're itching. And now current theory, lysophosphatidic acid increase will lead to the itching, but no conclusive theory there. Okay, very good.
And this year you mentioned there's no other skin findings. I would like to know what you have.
So for malignant skin findings, in general, GA malignancies can present with acanthosis nigricans, or more commonly seen with stomach, but we can see sebaceous keratosis also in this. Now, adenocarcinoma of pancreas, the skin findings that we can see, one is I would like to see for the migratory thrombophlebitis. Second thing I would like to see is that migratory necrotizing erythema, which is seen in glucomas and
pressure relapse.
Just
Migrated bronchiolitis. What is that called sign?
Clausius.
Any other clause you know?
Clausia.
Possible. Which was not also.
Is it the same? Twice, same. Not twice, it's same choice use.
Clausius.
Anything to do with calcium?
So when we put a BP cuff and increase the pressure, they'll have the hand tetany, carpopidal spasms.
Is it same spelling or different spelling?
This one is the same spelling, but
Twice, yes.
is the different spelling. The supraclavicular movement.
Okay.
Carpopidal.
Just now you told, no? Same. That was asking what is the spelling?
Of that one.
Here OUSSEAUs.
Yes, we would expect a bradycardia in this case because we are taught that this biosolves can lead to a sinoatrial node inhibition, but in this case we had a normal positive.
One area of deposition, the other theory is increased vagotonia due to hypothalamic deposition in there, because this is soluble bilirubin transmitted into the CSF gets deposited.
Next. Here you have mentioned no supraclavicular lymph node palpable. Specifically, you have to mention whether you are mentioning what side, right? That will be better.
Yes, can proceed.
So for us, we have summarized with the projection diagnosis of obstructive jaundice due to malignant cause. And most likely we are thinking in terms of head of pancreas and periampullary carcinoma.
Why there is a head of pancreas in the first place? Any reason for that?
So most of non-malignancy are presented at the time of presentation. So
other than that, I would again like to
uncontrolled diabetes. Uncontrolled diabetes. So we're thinking more in terms of
diabetes or
recently diagnosed uncontrolled diabetes.
Recent uncontrolled diabetes. What is Wadsworth syndrome?
Sorry.
Wadsworth syndrome is a chronic pancreatitis causing obstructive jaundice. There will be narrowing of the bile duct due to pancreatitis causing a stricture in the distal CVT. It is there in Mango.
So we'd like to investigate further. So first I have to confirm obstructive jaundice with an LFT as well as an ultrasound. On LFT, we have seen that the total bilirubin is 13.9 with a direct component of 5.7. So total bilirubin of 30 with a direct component of 13.9. And ALB is elevated, which is 756. Her HB is 10.8 and her albumin is 3.2. And PTNR is in the normal range 1.2.
Here, I would like to add that we would also do a CA19.
Have you heard of something called an R value?
Area.
That the probability of obstructive jaundice is more from LFT based on SGPT and alkaline phosphatase levels.
So if the alkaline phosphatase levels are more than 1,000, it is diagnostic of obstructive jaundice.
But it won't happen all the time.
Yes,
that's very rare.
R value or not?
Shall I give it to you as a homework or shall we tell the answer now?
We'll find it.
Huh?
We'll find it.
Okay. Send me a mail tomorrow. Right after you find.
So in this investigation, again, if you're doing the blood workup, we can send a CA19 also initially.
And ultrasound imaging, we found mild intrahepatic biliary radical dilatation with a dilated CBD of 1.5 centimeter. Liver is 13 centimeter and the gallbladder is distended, measuring around 8 centimeters, but there are no calculate, no sludge. Pancreas shows a hypertrophy with internal vascularity. Pancreas shows a hypertrophic lesion with internal vascularity with a mass of 4.3 cross 7 centimeter noted in the head of the pancreas. And MPD is 5 millimeter
and body and tail of the pancreas is normal, and there is no prefluid abdomen present.
In ultrasound, you got this information.
Yes, sir. In this ultrasound,
They're able to measure MPD diameter. Because it's dilated. Any urine investigation, something you do? Urine examination? Anyway, it will be useful. You said high color urine, no? Okay. Also called achloric urine. So why achloric urine, high color urine?
Because of bile salts in the urine, biliary pigments in the urine, and urobilinosis.
So why it's called achloric urine then?
No, you just, what sir is asking is, what is normally present in the urine to give the color of the urine? First question.
Normally you have urobilinosis in the urine.
Right, that is going to be absent here.
Absent here.
Yeah, what is going to give the high color here? What will you be? Conjugated. That's what he's asking, so tell that.
So though it's called achloric urine because absence of urobilinogen, but it is looks high color because of the presence of urine. Okay. Usually in ultrasound, the precise information like this may not be available. So what we look into ultrasound?
So in ultrasound, first thing we can start with is we can see the level of obstruction. So first confirm the obstructive jaundice by seeing IHBRD and follow the IHBRD and find out what the level of obstruction is, where we are able to see the cutoff with the ultrasonographer is able to see this. Then second thing, we can confirm the palpable gallbladder. There will be a large gallbladder. Not in this case, but we'll always see for stone disease if present. Liver, if there is any obvious metastasis present or not, we'll see. Then coming to the periampullary region, if such obvious mass is present, we should be seeing that. Second thing is we should see both the ducts, MPD and CBD, and see if they are dilated or if they are normal. Then other obvious features of any metastasis like free fluid abdomen and all can also be present that we will be able to see in ultrasound.
You said the dilated duct you want to see, right? What it is called? You said
Double duct sign.
So if the double duct sign is a feature of ultrasound or any other imaging, are you aware of it?
It can be MRCP.
So in any image which you are seeing, that is called double duct sign. What is the importance of that? What if when you are seeing that, what is the importance of that?
We level of obstruction again, we know that it is near the ampulla.
Not only level, usually double duct sign, if it is positive, it is because of the periampullary malignancy is there, right? So next investigation, what do you want to do?
So now that we know that there is a mass and we have already done the blood parameters, I would like to go ahead with the CT to define the mass more clearly. So we have done a triple phase CT with a pancreatic protocol. This is the arterial phase.
So here we can see there is no prefluid abdomen. There are no lesions in the liver till now, and we are able to see ill-defined mass in the head of the pancreas, which will be measuring around 4 × 4 centimeter. And gallbladder is distended. There is no obvious infiltration in the gallbladder. So here we will be able to see the lesion, gallbladder, IVC, and blood vessels along with portovenous system. The tumor is in the head of the pancreas, which is measuring maybe around 5 × 5 centimeter. And we can see SMA in the arterial phase. We can see SMA. The tumor is away from the blood vessels. And I would like to comment on SMV and IMV on venous and portal phase. And there is no other obvious infiltration anywhere. I'd like to go to portovenous phase.
So what is borderline resectable tumor?
In borderline resectable tumor, we'll see in the head of the pancreas, we see if the tumor has a contact of more than 180 degree with SMV or IVC, and any contact SMV portal vein, and any contact with the celiac axis or SMA?
SMA for how many degrees?
Less than 180 degrees.
Less than 180 degrees. They are known as borderline.
Borderline resectable.
That is the purpose of doing CT scan actually. We are not going for a main reason for doing a CT in 3 phases is to know for whether it is resectable, borderline resectable, or unresectable. Borderline resectable is involvement of SMV and portal vein less than 180 degree, or involvement of celiac artery or SMA less than 180 degree. And about the common hepatic artery, what about common hepatic artery? One more is missing, no? Borderline resectable, so
the borderline resectability, we'll have arteries and veins. In the veins, we'll have a superior mesenteric vein and portal vein.
Yes.
Borderline resectable for superior mesenteric vein and a portal vein is if the contact is less than 180 degrees. If the contact is more than 180 degrees without any obvious infiltration or any irregularity or clot inside, or less than 180 degrees with irregularities or clot inside. And for the arteries, it should be less than 180 degrees contact. And for specifically for hepatic artery, it should not be going to celiac trunk. It should not be going to bifurcation.
Yes.
And
it should be a replaceable. It should be reconstructible hepatic artery should be available. It should not be going towards celiac artery, or it should not go to bifurcation. If it is involving in the common hepatic artery, we can resect and do a grafting there. That is the point of borderline resectable. So unresectable means
unresectable is for arteries greater than 180 degrees contact anywhere for the arteries with or without infiltration is unresectable, or it is a hepatic artery with the involvement of the trunks and either to the bifurcation or to the celiac artery. For the veins, it is greater than 180 degrees, which cannot be reconstructed, or greater than less than 180 degrees with the clot or any deformity, any clot or any irregularity inside, which cannot be reconstructed. Yes.
Yeah, very good.
What is the current position about arterial resection?
So again, in arteries, as far as resectable, less than 90 degrees.
Criteria I know.
Yes, sir.
But is it to be done as a matter of routine?
No. All these procedures are usually not a routine.
Is there any demonstrated advantage of arterial resection vis-a-vis the potential complications?
I have to look into it.
Is there evidence, strong evidence to suggest arterial section improves either the quality or the quantity of life?
We are not sure.
The current view is arterial dissections are to be done, if at all, only as part of a trial. Because there is no demonstrated benefit, mobility is very high. So it's not to be done routinely in every sector. The consequences of thrombosis, major. You're part of a trial, yes, because the evidence that we have so far does not indicate a very strong support for resection. Benefit, if at all, is marginal.
Then what is the purpose of branding them as borderline resectable? What is the reason?
Yes, so borderline resectable, nowadays we have option of giving them a neoadjuvant therapy and then later on going for a curative surgery.
So what is the latest neoadjuvant chemotherapy given for these people?
In our center, we are giving gemcitabine plus platinum therapy.
Okay. There is the latest drug which is added in 2018 onwards from Sabiston.
FOLFIRINOX.
Yes, FOLFIRINOX is a new regimen which is to be given as neoadjuvant, even for adjuvant also, after surgery also. The latest drug is FOLFIRINOX. What is the name of the trial? It's the latest trial, the last one the trial. What's starting? Rotage trial. Okay.
What is the drug? The drug which has been added. What are the drugs in the FOLFIRINOX trial?
Name the drugs.
5-fluorouracil.
L. What is L stand for?
Leucovorin, oxaliplatin, and irinotecan.
Irinotecan.
Yes. So CT seems to be
operable.
Operable. Okay. It is a resectable tumor. Okay.
This is the CT report that was given.
SMB they have mentioned as 200 years.
So we'll keep it borderline resectable, sir.
Okay.
So because this is borderline resectable, I would like to go ahead next with endoscopy.
And in endoscopy, I'd like to do a few things. First thing would be, if possible, to do an US FNAC, get a tissue diagnosis. Secondly, if possible, ERCP and stenting, because we are planning to give a neoadjuvant therapy.
Sir, in this city, would not mentioned, but there are very
Sir is asking what information is missing in this report.
nodal involvement is missing. Sir. We haven't. But we know that we were able to see around 1 + 1 centimeter node in arterial phase.
When you present in the exam, show this, you tell it yourself that we want information on nodal involvement. There's no involvement mention of the liver, no information of extrapancreatic, extrahepatic lesions. Excellent. Yes. What is given here is a very limited amount of information.
There's another thing where we just put the positive findings and which is normal. We take a space, that's why we're not.
Then you tell it that you are not put it on the slide, but what else is important? Liver is all right?
Liver is all right. So tumor is free from the liver, and we can see from the scan. Gallbladder is also distended, but it's free from the gallbladder.
Free fluid?
There's no free fluid abdomen present, and we can see lymph nodes around the perilesional lymph nodes are present, but there are no para-aortic or porta-hepatic lymph nodes.
Or aortic.
What are the local operability? What else you want to know from the CP?
We want to see metastasis.
You have mentioned.
Lung and everything other metastasis.
Apart from that,
Yeah,
anything else?
vascular, different type of vascular abnormalities or anomalies that can occur.
Very, very important, right? Next, what do you want to do? Next, you said that you want to do some biopsy. No, and ultrasound.
Upper J endoscopy, and upper J endoscopy, if from there, because we are planning to start neoadjuvant therapy, you would get a tissue diagnosis by doing US and FNA.
But why US? It's a very ample report, right?
If possible, side viewing scopy and biopsy.
Just have to say side viewing scopy and biopsy. It's very much because if it is a deeper inside and small lesion, then yeah, of course, endoscopic ultrasound will help. Otherwise,
only information which can be given on US, which is not given on side viewing scopy, can be on notes. Second thing, they say that less than 2 centimeter lesions in the parenchyma of the pancreas, which might be missed by all other investigations, can be picked up by US. So maybe if there's underbody lesion, I would not plan the same.
very limited indication for endoscopic ultrasound.
Right. What are other investigations?
For what purpose?
So this is only if we are planning the patient for a neoadjuvant chemotherapy before doing surgery to downsize the tumor.
Before you give adjuvant chemotherapy or adjuvant chemoradiotherapy, always have tissue. There you only have to do perhaps FNAC or through the endoscopy, not percutaneous at any point of time.
Yes.
Yes, sir.
Where percutaneous is allowed?
Gallbladder.
No, gallbladder means?
Yeah.
CAGB.
It's asking when you can do percutaneous. In okay, sorry. If you're thinking metastatic, metastatic. If you're thinking, then we can do percutaneous and then later on give the.
Yes, if there is a
If it is
metastatic.
already extrapancreatic, disseminated peritoneal masses, then you can do. What you're afraid of is
seeding of the tumor.
Yeah. It's already gone outside, you can do percutaneous.
Any other investigation? Very important investigation I have not mentioned that will change the entire life of the patient.
Tumor markers.
PET-CT. PET-CT is a must. This is an advanced borderline resectable cancer is based on CT scan. Only when you do PET-CT, you may know some more meds. There may be lung meds, there may be liver meds, which will make this patient an inoperable. And we are going to only do a palliative. At that time, you can do any type of biopsy. Okay? So that is very important, especially in locally advanced all the cancers, whether it is a cancer stomach or any cancer you are mentioning, you should always mention about PET-CT. So PET-CT is a very important, plays an important role in pancreatic cancers. Many cases we have found out lung meds and all. So therefore, please don't miss PET-CT. And before doing any procedure, you told you are going to plan for a ERCP biopsy. Before doing that, what you must have? Blood value. PTINR is very important. Why PTINR is elevated? Because of liver cell failure. There will be non-absorption of
fat soluble vitamins A, D, K. Vitamin K is important for the production of clotting factors.
Yes, very important for in obstructive jaundice patient. The major problem is they won't have bile salts in the lumen. When bile salts are entering the terminal ileum, they will be reabsorbed into the liver. That is very important for absorption of fat and fat soluble vitamins. So when bile salts are absent, there will be K deficiency and there will be elevation of prothrombin time INR. In such case, if you are going to do any procedure, it will cause severe bleeding. We have seen so many patients admitted with so much of severe bleeding following a biopsy itself. In a ERCP stenting itself, they will get severe bleeding. Unless PTINR is normal, we should never touch the patient with any knife or any procedure should not be done. In such case, I want to do emergency. If patient is having severe cholangitis, I have to do emergency ERCP, but PTINR is elevated. What will I do?
Give transfusions of fresh frozen plasma.
Yes. Fresh frozen plasma should be transfused at least 4 units before doing any procedure if I could not correct the PTINR. So the moment you see an obstructive jaundice patient in your ward, what will you advise your oxygen?
To send injection along with the PTINR with class.
Before that, obstructive jaundice patient admit பண்ண உடனே கேஸ் ஷீட்ல என்ன எழுதுவீங்க? Injection vitamin K. The moment you admit a patient, you should write vitamin K. That is the most important. That will automatically correct PTINR in 3-4 days. That is why vitamin K is first given for those patients. Okay. So please don't forget, PET-CT is a must for obstructive jaundice patient, especially this type of patient. He might become an inoperable case. When you do a PET-CT, if there is a meds, there is no discussion at all for that. Yeah.
Since this vitamin K is brought for discussion, you know, what are the fat soluble vitamins we have?
A, D, K.
But why only vitamin K is becoming deficient? What about other?
We don't have stores of vitamin K in the body. And short half-life.
Yeah, high turnover and less storage. That is why only vitamin K is deficient mostly.
So if this is an operable, let us assume this case is an operable cancer. If we are going to plan SMV contact is less than 90 degree, let us hope it. Let us assume it is less than 90 degree. What are you going to do now? Is there any more slide for you for discussion, or is it the last slide? That's the last slide. Then what are you going to do for an operable cancer?
We will start optimizing for a surgery, sir. Yes. So for first, we admitted that the BMI was low. Start giving a high protein diet nutrition, corrected sugar, second thing, and start doing a workup which then anesthetists might ask for a surgery.
How the patient will take high protein diet with the bilirubin 30? How the appetite will be there? The patient will be having nausea, sometimes vomiting.
From our side, we can try and give supplementation. And in this case, doesn't have those features of nausea, vomiting yet, so maybe still they'll be able to take.
What is the role of preoperative biliary drainage?
Previously, it was educated saying that if bilirubin levels are high, there will be more complications. There might be more intraoperative bleed. There might be wound-related complications. But now the studies have shown that preoperative stenting or preoperative reduction of bilirubin is not always required in when you're planning for when it's readily operable cancer.
Yes, number one. And what are the complications of doing a preoperative biliary drainage?
Post-operative infection rates are very high.
Preoperative itself, we will unwantedly do cholangitis. The patient your patient is not having any cholangitis. We will infuse the bacteria and you will cause cholangitis, and that will cause post-operative increased rate of infections. So unless there is an essential need for preoperative biliary drainage, nowadays it is not done for most of the cancers. We are directly planning for surgery. Okay. Only when you are going for a neoadjuvant chemotherapy, we should do a preoperative stenting. Otherwise, not needed. If you are going to do a preoperative biliary drainage, how will you do for this patient?
We'll do ERCP and stenting, and we'll prefer a short metallic stent.
Okay. If it is hilar cholangiocarcinoma,
even in hyaluronic we'll try, sir, based on the endoscopic expert, we'll try to do an ERCP stenting. But if ERCP is not possible or it's failed, we'll try for a PTBD, preferably internalized.
Okay, you plan for a percutaneous. Actually, most easiest is percutaneous biliary drainage only. When you are going to plan for surgery, always go for a temporary procedure. ERCP and stenting through a hilar cholangiocarcinoma is more complicated, and it is done only when it is going to be a permanent permanently for a chemotherapy or post-operative. Okay, otherwise not done. What is the surgery done?
She is not operated, sir, but we will like to plan for pancreatic duodenectomy with reconstruction.
So with the reconstruction, okay. So when you are doing pancreatic duodenectomy, what important thing we should do before ligating GDA? One question, last question. Before ligating gastric artery, you should do one step.
We should see the flow in the GDA, which direction it is, because if there is a celiac axis stenosis, then the flow of the whole trunk will be through the GDA.
So if you ligate it, then everything will be very important. Before ligating, gastroduodenal artery ligation is a very important step in Whipple's operation. Before ligating GDA, we should put a soft clamp and we should look for pulsations at the hepatic artery level. This is because if the hepatic artery is receiving blood supply from celiac artery, it will be patterned. In many old age patients like 65, 70 years, what will happen? There will be retrograde flow from SMA. SMA it will go to inferior pancreatic duodenal artery, then through superior pancreatic duodenal artery, through GDA it goes to the liver. So far the patient was living from a blood supply from SMA. That might be the reason. Therefore, in such case, if you ligate a GDA, the patient's liver will go for damage. So we have to be very sure. Before ligating GDA, what will you do will be a viva question.
You said routinely not required the preoperative biliary drainage. So what are the indications for biliary drainage in case? Some few indications. When will you consider doing?
Cholangitis. If the patient is presented with cholangitis, we should have to relieve the obstruction. Second, what I've seen in the words is greater than 20 bilirubin. We use it as an arbitrary cutoff to extend the biliary discharge.
Patients having hepatic encephalopathy, they have to relieve the obstruction. Then optimize the bilirubin levels and then go to the
Any patient who's not fit for surgery at the moment, like uncontrolled comorbidity, is not medically fit for surgery. So there is some delay in surgery to those patients. So okay, consider these patients inoperable, like PET-CT are doing, that's a metastasis. So how do you proceed? What do you want to do for this cases then?
So again, now it becomes a palliative care, and any decision of palliation should include the patient. So we'll ask her what her main complaint is, what is the thing that is bothering her the most. And in this, she's not having too many complaints. Mostly the itching will be the one which will be bothering her. There's no pain, there's no other signs. So for itching, I would like to start with medical management, see if that works. Starting chlorpheniramine maleate. If that doesn't work, then some sedatives have also shown to help in reducing the itching. If that is also not working, then again, I would like to suggest a comfortable procedure like ERCP and stenting rather than PTBD for relieving her obstruction and reducing the jaundice. So again, this is all patient's decision. If the patient understands and is agreeing for any procedure, then that's what we do.
When you're asked, what will you do? Whipple's operation is not the answer. Because classical Whipple doesn't include vein resection.
No,
We had given pancreatic.
Even that, you have to add what else will you do? And the other thing is, it's always good policy before you plan for a pancreatic resection to do a diagnostic laparoscopy. You didn't say that. Is it not important? If you put a thing and you find 2 millimeter nodules all over the place, will you proceed with the
No, sir.
Tell. So when you are asked what to do, tell exactly what you will do, not the name of the operation. What is the indication for very rarely doing a total pancreatectomy instead of just a head resection? Pancreatic duodenal. Any indication at all or no indication?
Mighty focality.
Very rare that you will find it if you don't find it on imaging.
Is the rest of the pancreas is atrophic? Some cases where they're presenting with chronic pancreatitis and then it is progressing to a malignancy.
Perhaps, and also sometimes the quality of pancreas is so poor, very friable, does not hold sutures, high chance of leakage with a anastomosis. There, the lesser even maybe to know the pancreas was preserving the spleen.
Thank you, Dr. Thank you, Dr. for presentation.
Thank you, sir. The next presentation.
Thank you, sirs, for that extremely inquisitive session. I now request the examiners to award the certificate of presentation to Dr. Furkan. And Dr. Pawan Kumar. I now kindly request Professor Dr. Vikram Kate to felicitate Dr. Anand.
അടുത്തത് presentation ഇതിലെ ഡെസ്ക്ടോപ്പിൽ presentation desktop மட்டும் இங்கதான் இருக்கிறதுல இந்த செக்ஷன் லெக்சர் கன்வெர்ட்டிங் இருக்கு அது கடையில் அது இதெல்லாம் சார்
Kindly request Dr. Suresh Kumar to remain on the dais. Now we have the next session by Professor Dr. Anand Krishnan on converting dissertation into scientific manuscript. I request Professor Dr. Vikram Kate to join Dr. Suresh Kumar.
Clicker. Okay. Next is the next. Okay.
Good afternoon, everybody, and now we have a very important lecture presentation by Professor Anand Krishnan, who does not need an introduction. In the previous case presentation, you have seen that he was the examiner, and you also seen his brief, which was projected on the screen, and he has been my mentor. I'm associated with him since I joined JIPMER in December 1988, and even though everybody here is very much familiar with Professor Anand Krishnan, I request Dr. Suresh to briefly just enumerate sir's. As I said, it's very brief, otherwise it will take a very long time, 30-40 minutes for the achievements itself. So Dr. Suresh, please.
Thank you, sir. As sir said, sir doesn't require an introduction. Sir is a well-known figure all over India and outside India. Sir is teacher of my teacher. My teacher is sitting in front with me, and sir is teacher of my teacher. Sir has 15 national orations and 367 papers in conferences and 480 publications, 8 books, co-recipient of Shushruta Award in Association of Surgeons of India 1981. As sir said, sir's CV, if I start reading it, will run into pages. Sir has received a Lifetime Achievement Award in recognition of academic excellence, commitment, dedication, and contribution to the cause of surgical gastroenterology in India from the Indian Association of Surgical Gastroenterology during the 25th Silver Jubilee IAGCon 2015, October 2015. Sir's area of interest includes biliary lithogenesis, carcinoma penis, Helicobacter pylori, lymphatic filariasis, peptic ulcer, and corrosive strictures. Thank you, sir. Thank you for accepting an invitation. Over to you, sir.
Just a second. I'd like to just briefly tell one line that there are many postgraduates sitting here, and it's extremely important that if you have written papers during your post-graduation, it is well and good, but if you're not written, the best way to have a very good paper of a work which you'll be doing for 1.5 to 2 years will be how to convert your thesis or your dissertation into a paper. So now we listen from the doyen of research in India, how to do that. Professor Anand Krishnan, please.
While they are getting the slides ready, thank you, sir, and thank you, Suresh, for asking me to talk on the subject. Now, these slides are not meant for those very, very motivated residents who are experts in writing paper. Why I am saying this is, I have had the good fortune of collaborating with Vikram and writing papers with some residents like Mosina and Guru Shankari and all that. I have learned from them rather than they learn from me. So they are congenital writers. So it's meant for all the others, the rest of the world, who are not like Mosina and Guru Shankari. You may ask me why I put 10+2 steps. Just to make the title look interesting. It doesn't have any particular significance. Now, how does one start converting a dissertation? It's better to use the term dissertation rather than a thesis, although a lot of people use the term thesis. Thesis involves defense. Thesis involves original work. And therefore, it is properly applied to doctoral work. Whereas dissertation is a writer on any subject for purpose of learning how to do research. It doesn't have to have originality. It doesn't necessarily have to have defense. Therefore, the proper correct term is to use dissertation, not thesis. So when you start converting that, because I have many students, one of whom I still remember, Aditya Agarwal, we did a very small study when I was here. We have, as you know, a lot of patients with carcinoma penis. Most of them advanced, where we cannot save the organ. Some of them not so advanced. And we wanted to see how we can save the organ, because what the books say, clearance should be 2 centimeters. And if the corpora are involved, then the whole penis. So we wanted to answer 2 questions. Why is this 2 centimeter spread? Is it arbitrary or is it group? And does the pleura get involved, which requires whole organ removal? Just 2 simple questions. So I told them he was doing a presentation with me. Let's do a whole organ section. You know, in those days, in the old laryngectomies were being done, the whole larynx will be preserved, and they'll do 3-dimensional serial sections to see the spread. So after amputation of the penis, we did preservation of the whole organ and serial sections at every millimeter proximal to the tumor. And the proximal limit of the tumor was marked by ultrasound of the excised penis. And what we found was completely opposite what was given in books. The maximum spread in a well-differentiated carcinoma penis was 5 millimeters. There was no discontinuous spread, and pleural involvement was 0%. And the maximum spread in poorly differentiated tumors was 1.5 centimeters. So all that nonsense about total pedectomy was rubbish. So many patients could be salvaged. This simple dissertation was converted by Aditya Agarwal, published in the British Journal of Urology. Today it has got 220 citations, and it is in all the textbooks of urology as the standard of care for management of carcinoma penis. Simple thing like that. So don't take dissertations very lightly, because many of them can lead to discovery of data which is very, very useful. The first thing you have to do when you sit with a dissertation and want to convert is, why I told Aditya Agarwal is, that was the paper which got him the job that he went for in the UK, and he was selected over 43 other people because of that publication. First question you have to ask is the dissertation worth being published? Because we know how dissertations are done. Now, I don't know, with 70 residents in the department, whether you have enough topics for dissertation. You have? Every year? Worth being published? I don't know. You have to ask yourself.
It becomes a difficult task.
We have difficulty. We have only 18. But we have probably 5% of your patient load. So it's terribly difficult. Our head of department is sitting here, Dr. Rajan. He knows the difficulty we have. So the first question is, if it's not worth being published, don't push the borders too much. Send it anywhere you want. If you own a journal, publish it there or send it to any predatory journal, and in 15 days it will come out. The next decision you have to make is, should I publish it as a whole or should I publish it in parts? Because sometimes when you combine everything in a dissertation, it becomes too long. Nobody will publish such a long paper. But at the same time, the data should not be overlapping. If you do that, then it's called salami size. That you deliberately divide one work into many and publish. I did my dissertation when I was a PhD at All India Institute on multimodality methods of analyzing gallstones. To have a theory about biliary lithogenesis, what is the sequence? When you do it with crystallography, histochemical staining, microchemical methods, and so on and so forth. The data was all different. And we were able to publish it as 4 papers in Indian Journal of Medical Research and consecutive issues because there was no overlap. But if your data is overlapping, then better to publish it as one, otherwise you will be accused of salami slicing. The third question you have to ask is, which journal will be suitable? You send it to the wrong journal, you will come back even before you come back from the post office. And therefore, you have to choose the journal very, very carefully. And then you must know nowadays how not to send it to predatory journals. Because you send it there, it's as good as throwing it in the waste paper basket, it has no value. So let's go to the next topic of how to choose a journal. When you look at journals, you have various types of journals. You have general journals like the Lancet or the BMJ or the New England Journal of Medicine or the National Medical Journal of India, which covers topics across the discipline of health. There are subject-specific journals, like you have the Indian Journal of Surgery. Then you have the higher specialty or the super specialty journal of urology, like I told you about Aditya Agarwal, Indian Journal of Urology. Then you have organ-based journals, thorax. And then now, of course, you have organism-based journals, because Vikram and I worked for many years on Helicobacter. There is a journal called Helicobacter pylori, devoted only to publication. Now, when you don't match your dissertation with the journal requirements, it will come back. If you have a topic of interest to more than one specialty, then you choose a journal which is multidisciplinary, like the National Medical Journal of India. But if it is highly specific PhD work, like Vikram did, on some aspects of Helicobacter, then you can even send it to Helicobacter. But what will happen is, the readership will be limited to a very small group of people, and therefore, your citation will not be very many if you send it to a highly specific journal. So match your article with the journal, otherwise it's likely to come back. The question is, what are predatory journals and how to identify them? And now, I think 70% of journals in the market are predatory. There was a man called Beale, who was a librarian in the United States, who first brought this idea of predatory journals to the idea of researchers. Then a lot of people threatened him, and Beale no longer publishes the list. It is now published by ResearchGate every year, listing all the predatory publishers and predatory journals. If you look at it, you'll know what's a predatory journal. If you see the journal, they'll say we are indexed in Scopus, we are indexed in PubMed, we are indexed in Web of Science, and every possible index. But when you go to PubMed and see, you will not find it. So if you want to know whether the journal is predatory, compare what they say in their page, editorial page, and compare it with the database. They'll give you wrong data about impact factor. You will not sometimes have even an editorial address, and sometimes they run 5 or 6 or 7 journals. The editorial board will be the same for all the journals, irrespective of the subject. That itself shows you that the journal is predatory. One man cannot be expert on 10 different subjects. So if you don't know, ask somebody, this is predatory, and they will tell you. Don't waste your time sending there. It doesn't fetch anything. It's not counted for promotion. It's not counted for any career advancement. Then, of course, you must focus on getting started. And I only put this slide to tell you that such an ambience may not be the best type of ambience to write a nice scientific paper. And therefore, you choose a proper ambience in which you can focus and write a good article. The first thing that you have to decide is, very often you'll find dissertations have titles which run into 4 or 5 lines. I remember when Vikram did his PhD under me, the title ran to about 4 lines. Huh? Such a title, if you put on a journal article, nobody will publish it. The title in a journal article must be attractive. You should remember, that's the first thing a potential reader will see. And if the title is not attractive, they will just not go forward. What is the next thing that they'll see after the title? Anyone? The abstract. So if you fail with the title of the abstract, you're lost readership. Titles should be unique for journals. Do not copy titles of dissertations. They'll not match. A journal, a dissertation title is what we call a descriptive title. It tells everything that you have done so that somebody looks at the title, it looks as if a lot of work has been done. Although you know and I know that very little as work has actually gone into it. Like the first example, prospective cohort study of clean and clean contaminated surgical procedures to determine the value of chronological change in platelet indices in predicting occurrence of surgical site infection. It will take a translator to understand what this actually means. Such a title will not get any readership. The same thing you can write in affirmative rather than descriptive. Platelet indices can predict surgical site infection. So somebody sees that and they're not been doing platelet indices, they feel like they. Or sometimes interrogative. My wife did her PhD. Why does the girl child not go to school? That will attract leadership just by putting that lot of patients are losing their organ because of the recommended clearance margin for amputation of the penis. Therefore, we wanted to see whether that clearance was required. A lot of patients were having total amputation when the crura were involved because of belief that once inside the buccal fascia is breached, it will spread to the whole organ. Was it really true or not? So that is what you write in the first paragraph. Everybody in the world knows what is the importance of the paper. Why you have done it. The second paragraph are what are the lacunae and controversy. What is missing in the information? If everything is known, why write another paper? Unless, like we have several senior referents in our department who have got material. Rajan knows, but they will not write the article. So we asked them, why you don't write the article? You have got so much material. No, I'll wait to be assistant professor. Then I will write two so that I can become associate professor. Because the National Medical Council requires 2 papers as assistant professor in order to become associate professor. So, what are the existing lacunae and controversies? The third paragraph is the aims and objectives. Therefore, what are you doing? So, what is the issue? What is the lacunae? And therefore, what are you doing? That is sufficient to complete the introduction part. Then the next step is methodology. What do you write in the methods? You start by giving the setting, where the study was done, what type of study it was. Was it a prospective randomized controlled trial, or it is a descriptive study, or is it an interventional study, is it a blinded study or not? All that should be there in the first line of the methods. It should also be preferably an adjunct title after the first title. The second line of the title. What are the parameters you have studied? What is your outcome definition? What are the primary outcomes? What's the end point? What is the most important thing that you're looking for? That's the primary outcome. What other things you find out on the way on the secondary outcome? What are the exclusion and inclusion criteria? Remember, these are not to be overlapping. When you write inclusion criteria, the exclusion should be something new. If you say inclusion criteria, males, exclusion criteria cannot be females. It's understood. So they should be different. What is the sample size? How it was calculated? What is the reference base on which you have calculated the sample size? And if you have randomized, what type of randomization? Is it block randomization or computer generated randomization? All that should come in methodology. So the aim of writing methodology is, if somebody wants to repeat that study, or he can have enough information to repeat the study, improve you right or wrong. So that much detail must be there in methodology. What is well known, you don't have to write. If measurement of glucose is part of the study, you can say we did estimated glucose. You don't have to write the glucose oxidation method or how glucose is estimated from blood. Then the study protocol, preferably in algorithmic format, so that it's easy to grasp. Follow up, how long, and then the statistical test for each outcome. There should be a table, always should be a table. What are the outcomes and what is the appropriate statistics you are used for that? Qualitative variables, you may say chi-square. Quantitative variable. If you are comparing mean, you may say student feature. Whatever is the appropriate statistic, you must. It should always end with a statement of ethical approval by the concerned committee. Without that, no journal will accept it. And if they ask you to produce, you have to produce them. And if it's a clinical trial, you should have the registration number, because clinical trial must be mandatorily registered. Otherwise, nobody will publish. Then the results should be condensed. In a dissertation, often you will find there's a table followed by a pie chart and a bar diagram, all for the same data. You can't do that in a paper. If you think it's a complex data, then use a table. If it's proportion, Out of 100%, then you use a pi. If you are longitudinally comparing, you use a line curve. So you choose the appropriate visual method and not a repetition of what is in the dissertation. The results, Bradford Hill said, what did you find? Often 10-15 pages are there in results in the dissertation. Whereas in a published paper, you'll get probably 1 page. Everything has to be summarized. 4 or 5 tables, or 3 and 4 figures. Preferably, use color only when required for a photomicrograph, for instance. Otherwise, color is not accepted by many journals, or even if they accept, they'll ask you charges for the color. Avoid unnecessary tables and see that each table is properly numbered so that when you read the heading, you know what it contains. If you are talking about significance, have a column which shows the significance for each parameter. Or if it's together for the whole table, put an asterisk and put it at the bottom of the table. Wherever possible, if you can put it in figures, it will be better for the visual impact. And if there are significant findings, like statistical significance, or you want to draw attention, make that part bold so that anybody who looks at the table will know that they have to read that line. Now we come to the most difficult part of the paper, the dissertation section. Start your dissertation with a brief para of the problem and the aims of the study, so that you are now reminding them of what you wrote in the introduction before they start reading the discussion. You are just in 3 or 4 lines, what you wrote in 3 paragraphs in the introduction, you are writing in 3 or 4 lines as the first paragraph of discussion. Then write the next paragraph, what is already known. The lacunae where you mentioned only 1 or 2 in the introduction, now bring out more lacunae in the discussion, so that the justification will be clear. And as a matter of policy, we are not writing history. So any reference which is more than 10 years, unless there has been no work in the middle, need not come in your paper. There is no point, because those data are very often outdated. Focus in the discussion on one issue where your study agrees with other published studies. If it agrees, there's no need to give reason, because all other fellows have written about it or already given the reason. But if it disagrees, draw attention to the disagreement and give the reasons why you feel your findings are different from published data. That's very important, because that is going to set the standard for the next study. At the end of discussion, give your principal conclusions, how they have added to knowledge. Our conclusion in that carcinoma penis paper was, based on the study, it appears we cannot say that we have conquered the world, because another study may prove us wrong. It appears that 1 centimeter clearance is sufficient for well-differentiated tumors. Total amputation is very rarely required, because discontinuous spread is very, very unusual. And now you have ultrasound to find out discontinuous. And if it's poorly differentiated, only then you require 2 centimeter clearance. That's all you say. Don't claim that you have invented the world or you're Einstein, because then people get annoyed. And 10 fellows will write letters to editor condemning your study and finding fault. Do not claim what you have not personally found in it. The conclusions must have only your study. Limitations are mandatory. No study is perfect. The limitation may be you had a sample size but could not achieve it for various reasons. Or you had a dropout because some people did not come for follow-up. Admit it before it is pointed out. And if you have something, nowadays all these published papers come, everybody sends to each other. The conclusion is always, they say this, that, all that. And then the last line will be, a larger study is required with a longer follow-up to confirm these findings, so that they are protecting themselves from the public. Everything that comes out of China or any of these things, hundreds of reviews, hundreds of studies. The last line is always here. The larger study is required, or it is a longer follow to confirm what we have just found. If you feel that's fashionable, then put it down in your study also. The abstract is, I tell you, next to the title is the most important. And structured abstracts are the rule. First paragraph of introduction, 3 or 4 lines, 3 or 4 lines of methods, principal outcomes should be there, the type of study should be there, and results, principal results should be there, not all the results, but the results section should be the largest part of abstract, so that it gives more details. 2 or 3 lines about conclusions. Some journals will say, I want to know the setting also. So in the background, you put the setting. In a tertiary care hospital, you put the setting. The word count in abstract is very important. Most of them are about 250 words, 300 words. You can't send 1,000 words. The editor is very happy when you send 1,000 words, because he doesn't have to send it to any peer reviewer. He just has to put it in another envelope, put your name there and return it. So, references are very important. I am a reviewer for many journals, and I get terribly annoyed when the references are not in proper format. Because that's basic courtesy to the reviewer to use. You will find number 4, then you search something there, there will be something else in number 4. So take Vancouver is the standard style. There are still journals which use Harvard or modified Harvard. Therefore, fit it in with the journal style. Ensure, and this is very common in dissertation, at the end you will find 300 references, but when you read through, only 25 would have been cited. All the others are just put there to look, make it look as if it's a very heavy study. Ensure that all cited references are in the list and only cited references. Self-citations as a policy is not good. If you have 20 references at the end, 10 of your own papers, then obviously nobody would like them. That you are not such an important man in the world, that 50% of the data and world literature you have contributed. That's what it means when 10 out of 20 are your own papers. Of course, the COPE guidelines are there, Committee on Publication Ethics, follow them strictly. They tell you what is the authorship, who's the host author, gift author, and everything is there. Easy to read. Sequence of authorship, I'll rather not go into it in public. Ideally, in the ideal world, the person who does the study must be the first author. And the senior most person should be the last author. But we know forces are at work. They cannot be admitted in public where the sequence is disturbed. But ideally, this is the sequence. In a dissertation, the postgraduate's name should be first. If you have used tables and figures, copyright permission should be there. Just because it's available in the net does not mean that anybody can use it. Some of the things in the net are also have copyrights. Certainly, tables from other articles, tables from books cannot be used without permission. Do a plagiarism check. You have an excellent software here, done it in. Done it in is very costly. There are other software equally good, like Google. And the accepted similarity, I won't say plagiarism, that is not a good word. The accepted similarity rate is 10%. Anything more than that requires to be rewritten. Most journals will not accept. And of course, declare your conflict of interest and funding. Language is very important. So if you are not strong, give it to somebody to read and make sure that it flows. You may ask in what format you write. Ideally, the first person singular or the first person plural is best for a study of that. Don't write in passive voice, that's it. They, and all that. It's nice to say we did this and we found this. That takes ownership for the material. Conform to the word count if there is any. Give it to somebody else, leave it aside for some time. Look at it again, then you will find many mistakes. Whenever I get, in fact, I published so many papers. I don't remember more than 2 or 3 which were accepted without first being returned for review. All of them will come back. And they'll come back with good comments. Read every line of the comment so that you attend to it. And by attending to it, your paper will always become better. Don't say this fellow has written 2 pages or review, I'll send it somewhere else. You send it somewhere else, but first attend to those 2 pages, make the change and then send it somewhere. And then come to the last part. A lot of them will come back with a very polite note saying that's excellent paper. However, we don't have place because we get too many articles. That means in one word, your paper is rubbish. But they are too polite to tell that. But when it comes back, what to do? This is the plagiarism part, and that is the man on the left whose paper has been rejected. Read every comment and respond to every comment. If they say send it back after review, highlight the changes so that they know what changes you have made in response to the questions. I always do that. I put it aside so that I can develop a little hyperkeratosis before I look at the paper again, and then I don't feel so sensitive when they say nasty things about something which we think is creative. Give it to somebody else. And if they say send it back to the same, or select another journal, go through the whole sequence. Did I send it to the wrong journal in the first instance? That is very important. And my last slide, there will still be papers which come back. The way to avoid that is to write a good paper first, so that it doesn't come back. The second thing to think is respond to the reviewer's comments. And the third is, of course, start a journal of your own and publish it. Nobody can stop you. You can have 1,000 publications or pay money and publish. You can have 2,000 publications. In 15 days, you'll see your name in print. Thank you all very much. I don't know whether there's any time to answer questions. If it is allowed, and if there are questions.
Thank you, sir, for a wonderful lecture, and I'm sure it has generated a lot of interest with the audience involved. And any of you, if you have any clarifications, any questions, you're free to ask.
In the afternoon,
Yes,
just trying to present a paper.
Yeah, you can.
It's not related to publishing, but once we look at a paper, how do we assess its quality? Like some few steps or like some cheat.
There are a whole lot of criteria for assessing the quality of a paper, starting from the journal in which it is published, the impact factor, citations index, and so on and so forth. There are many methods of doing it. Now today I can't talk about it, maybe some other forum will tell you how to judge whether a paper is good or not. At least 2 of the audience are awake.
Good afternoon, sir. So, you had told us about how to write different kinds of how to publish a thesis. When we are reporting a case, like a rare case which you're going to report, a lot of these don't hold good. Like, can you give us a bunch of points which will help us report a case? The discussion part mainly.
See, many reputed journals are now starting new journals called case reports, like Lancet case reports, BNJ case reports, because they know there's a market for case reports. A lot of people want to publish. And also remember, case reports have no citation value in them. So it will not add value to your CV. When do we publish a case report? When you have something new to say about it. Just because only 20 are reported in world literature does not make the 21st worth publishing. After 20 people have stopped reporting because there's nothing new to tell. So either a method of diagnosis or an unusual finding or a new method of management, some message has to be there in a case report to make it worthy of reading for other people. So sit with the case report, look at what has been published, what is known, and answer only one question. What am I adding to what is already known? If you can answer that I am adding something new by way of clinical features, therefore diagnosis, new by way of investigation, new by way of management, or the same old management I am getting a better result, then publish. Otherwise, case reports by themselves have very little value. It's a good way of learning how to write a paper, but not a good way of developing career. Have I answered your question?
Thanks.
If no further questions are there, then
Thank you all very, very much.
Thank you very much for your
Thank you, sir. Now request Professor Dr. Vipin Bharti to LCD, Professor Dr. Antarish. Thank you, sir.
For the attention of the audience is an important announcement to make. The following e-posters have been selected for oral paper presentation. Dr. Varsha Raja, Dr. Likita Subhash, Dr. Rajlakshmi MR, Dr. Vidya Shetty, Dr. Veda Prakash, and Dr. Savi Prakash. Participants are requested to kindly submit their PPTs at the technical desk. Next, we have an interesting online guest lecture on managing hyalocholangiocarcinoma by Dr. Ravi Marudanayagam. Sir will be joining us from UK online. I welcome Dr. Vishnu Prasad, Dr. Indian Samarasan, Dr. Rajan KV. Okay, I welcome Dr. Vishnu Prasad, Dr. Rajan KV, and Dr. Asayas Bosco to the dais to chair the session.
You can ask only, sir. The right records. Okay.
It's actually afternoon here. Must be morning there, Ravi. Good morning.
Hello to them.
Yeah. Professor Ramakrishnan wants to say hi to you.
Hello.
Hello, sir. Good afternoon. Nice to see you. I wish I was there physically, but unfortunately, I couldn't make it this time on time.
Can you see Professor Ramakrishnan, Ravi?
I can. I'm not sure if you can hear me.
You are not audible. Can you? Ravi, you are not audible.
Okay. I'm unmuted actually.
Let me introduce Ravi Marudanayagam. He was our is an aluminium department. She is currently the consultant hepatobiliary and pancreatic surgeon at Queen Elizabeth Hospital, University Hospitals of Birmingham, NHS Plus.
He is not unmuted.
His area of research and interest is advanced laparoscopic hepatobiliary and pancreatic surgery, as well as education and training. He is currently the program director, higher surgical training, West Midlands in the UK. In the UK, led for the European minimally invasive pancreatic surgery registry, training and education led for minimally invasive liver and pancreatic surgery association, co-led for the UK European minimally invasive liver surgery, and founder member of the International Laparoscopic Liver Society. He is also a principal investigator for a number of European clinical trials, and he has got publication in 85 peer-reviewed journals. Over to you, Ravi. He is speaking on management of cholangiocarcinoma, use experience of the Birmingham
Thank you, Dr. Vishnu, for the introduction, and thank you for the organizing committee for the kind invitation. As I mentioned, I wish I was there physically, but unfortunately couldn't make it this time. Let me share my presentation.
You can hear us, Ravi?
Yes, I can hear you. Can you hear me?
Yeah, we can hear you. I just want to say your tie looks nice.
Let me see how I. Can you see the presentation yet, or? So I'm trying to. I think there's some issue with my presentation is not coming up for some reason. Can I log in from a different device? I'm just trying to figure out. I'm just trying to log in from a different device.
Recording in progress.
I'll log out of this one and then join to the other one. Can you see my screen now? Sorry about this confusion. So thank you again for the invitation to talk on managing hyalocholangiocarcinoma. I'm going to be focusing purely on the resection, as currently hyalocholangio is still not an indication for liver transplantation in the UK, but it will soon be. My focus will predominantly be on how to diagnose and whether it's resectable or not, and how to optimize once you have made the decision to resect, and what type of surgery you would be performing. The key in hyalocholangiocarcinoma is getting a tissue diagnosis. So it's not easy to get a tissue diagnosis preoperatively all the time. If you can't get it, the only way to confirm the diagnosis is based on radiology and to rule out a differential diagnosis. The commonly encountered differential diagnoses are Merit-G syndrome, which can be diagnosed based on ultrasound and MRCP, and a dominant stricture of a PSC. So 20% of the PSCs present for the first time with a dominant stricture, and it can be very confusing. And in the Far East, hepatolithiasis and recurrent pyogenic cholangitis is one of the differential diagnoses. And IgG4 cholangiopathy is becoming more and more frequent now. And there is a strong association between IgG cholangiopathy and IgG4 pancreatitis. So 90% of them will have associated pancreatitis, and that would help with the diagnosis. And ischemic cholangiopathy, again, it's a frequently diagnosed condition of late. So the diagnosis, I will divide that into two portions. One is radiology, and the second one is tissue diagnosis. So the first presentation is usually jaundice, and these patients all tend to have an ultrasound before they come to you. So it helps to identify, to an extent, the level of your obstruction, but more importantly, it helps to rule out any stones. But presence of stones does not necessarily indicate gallstones or the Merit-G is one of the causes of this, but it could be secondary to a chronic obstruction. But absence of stones does help to rule out the diagnosis. CT is a pretty important investigation, even better than the rest of the ones I mentioned here, because it gives you an idea of the level of obstruction. It gives you an idea whether there is a mass lesion or just a stricturing lesion, and about vascular involvement, and about any intrahepatic or extrahepatic metastasis. MRCP is useful to an extent in the sense it gives you an idea of the level of obstruction, but more importantly, it gives you an idea whether there is a background PSC. MRI liver sequences do help to differentiate intrahepatic metastasis. It can be extremely challenging sometimes with smaller lesions. So coming to tissue diagnosis, so 15 years ago, we rarely aimed for a tissue diagnosis preoperatively, but now we make every effort to try and get a tissue diagnosis. And I would say in our experience, probably 90 to 95% of the time, we are able to get a tissue diagnosis pre-op. Again, ERCP traditionally was used long time ago. And still, I think some of the centers in the Far East, if you see the publications, they mention about ERCP and brushings. We tend to avoid ERCP for a number of reasons. One, a high level obstruction is extremely challenging to get there, and brushings are not always diagnostic. And there is a risk of introducing cholangitis and pancreatitis. So we always go for a PTC and endobiliary biopsy. And with time, we have gained more experience, and our biopsy results are becoming more productive. An advantage, we can also do a background liver biopsy to rule out any chronic liver disease. So what we have changed in our practice is to get the PTC beyond the obstruction, but keep it above the ampulla. That reduces the risk of cholangitis. Because as you would see later in the presentation, cholangitis is one of the biggest problems facing in the management of hyalocholangiosis. And if there's a mass lesion, it's sometimes good to do an USN biopsy if repeated endobiliary biopsies fail. And again, off late, we started doing spyglass through PTC rather than via ERCP. So we got a short, thin scope where we can do through the PTC scopes and get a better yield because you can visualize and then biopsy the appropriate areas. Just briefly about role of tumor markers. CA19-9, like any other tumor marker, is not diagnostic, and only 50% of the hyalocholangiomas do secrete tumor markers. But it's good in prognosticating in secretors. So if the level goes up following resection, you know they're getting recurrence. and very high values, like in terms of thousands, you know that there is likely occult metastasis somewhere. So that's why the role of CT PET may be useful. Again, CT PET is very difficult to interpret in settings of recurrent cholangitis, especially to diagnose intrahepatic metastasis. Microabscesses can be more challenging to diagnose on CT PET because it will highlight as what the metastasis. So an MRI liver is far more protective. But for extrahepatic metastasis, CT PET does have a role. But in our center, we don't routinely do CT PET in these patients. So once you have diagnosed, the next step is to see whether it's resectable or not. So for the postgraduates, it's very, very important to know the biliary anatomy because it's in hyalocholangio, it's very crucial. And each and every patient is different from one another. So interpretation of CT is very, very important. So the basic general anatomy description of biliary tree is division of the right into anterior, posterior. Left gives of 4, and then 2 and 3. Traditionally, we always followed bismuth correlate classification. So as you can see on the right, it's got 4 different types. So type 1, where the confluence is intact. Type 2 is where the confluence is separated with the division of the right and left duct. And 3 is basically separation, extension into the second order ducts. 3A into right side with separation of right anterior and right posterior. And 3B is extension into the left with separation of segment 4B from 2 and 3. Then we have type 4, where it's extension into both second order ducts. But the pitfalls of bismuth classification is it doesn't mention anything about the radial extension. It's always on the longitudinal extension. So you don't know what the arterial involvement or the venous involvement is. It does not give you an idea of nodal involvement. It does not tell anything about the metastasis. But what it does give is it tells you the number of drainages required in each individual. So the type corresponds to the number of drains required. So if we say type 1, you need 1 drain. It can drain the whole biliary tree. And if you say type 3A, for example, you need 3 drains, 1 for anterior, 1 for right posterior, and 1 for left. And it also tells you about what type of surgery you would need to do. So I'll come back to that in a few minutes' time. So again, this is very, very important to decide on what type of resection you'll be doing. So the essential bottom line is you have to resect the bile duct because it's the bile duct cancer. But because the vessels are so close to them, you have to take those vessels down. Especially if you see the anatomy here, the right artery goes behind the bile duct. So even if it's a type 3B, you would see that your right artery is first involved before your left. So it's very rare to do a left hemihepatectomy for hyalocholangio purely for this reason, because your right artery tends to get involved earlier on. So if you're going to take an artery or part of the vein, so you have to take that part of the liver along with that. And that's what adds to the complexity of this problem. So you are going to need to resect the extrahepatic bile duct, resect the blood vessel involved, and also resect the portion of the liver involved by the blood vessels. So when would you not resect? So like any other cancer, if there is distant metastasis, or if there's evidence of intrahepatic metastasis, or iotrocable lymph nodes. So that's an extremely controversial topic of late. Some people still say if they respond to chemo, you just go ahead and resect. But as of now, we still don't resect para-aortic or iotrocable lymph nodes. And then contralateral artery involvement. So again, we have not, I'll show you our data towards the end. There are only a few cases, if you remember, I think 3 cases where we did an arterial resection, but it was not planned. It was intra-op decision. It's not the best thing to do. So contralateral artery involvement is still a contraindication if diagnosed pre-op. Contralateral vein involvement is not a problem as long as it's very short segment. If it's a long segment going into the rects, then we wouldn't resect when I'm talking about right-sided cholangio. So contralateral short segment portal vein involvement is not a contraindication because you can resect. Again, I'll tell you the reasons why later. Okay, we've made the decision to operate. But the biggest problem these patients face are 1, recurrent cholangitis, and second is inadequate liver volume. So these both criteria need to be satisfied before you proceed with resection. So I'll focus on the function first. So they all need biliary drainage. And when you plan for biliary drainage, always do for the future liver remnant. So if it's a type 3A, so most of my discussion is on the assumption that it's going to be type 3A, because that's the most common one. So you do the left side internal external drain. You very rarely need to do an ipsilateral drainage, only if the patient has got recurrent cholangitis. So otherwise you wouldn't need to do that. And next question is what type of stent? So as I mentioned, we use a plastic stent, but try and keep it below the obstruction, but above the ampulla. There are some positives because it reduces the risk of cholangitis. You don't push the duodenal contents through the ampulla into the static biliary tree. But the downside is it keeps slipping out. So you may need recurrent, repeated drainages. So next is if it's straightforward operable, plastic stents are fine. But if you think that the patient is going to need neoadjuvant chemotherapy, or if the patient is going to need, let's say, dual vein embolization or portal vein embolization for FLR hypertrophy, then some of your oncologists won't like leaving a plastic drain hanging out because it increases the risk of cholangitis. So in those cases, you can do a short metal stent, but we would prefer a covered metal stent because covered metal stents are quite easy to remove at the time of surgery, while uncovered metal stents are extremely challenging to pull it out. But the downside of the covered metal stent is it's going to block the other side. So you would need a bilateral covered metal stent if the patient is going down the route of chemotherapy, neoadjuvant chemotherapy. If it's inoperable, then just put bilateral uncovered metal stents. Then the next question is how low you want the bilirubin to be. It's almost impossible to get it back to normal. We probably get it in 10-15% of the times completely back to normal. So there is no clear-cut evidence in the published data to say this is the safe limit. But in our experience, we have found something similar to 3 milligrams per deciliter. So ours is around 60, so which corresponds to roughly around 3 milligrams per deciliter. And then be prepared or be aware of that these patients will need multiple drainages, prolonged hospital stay pre-op, and recurrent cholangitis is not an issue, it's not uncommon, and then they may need repeated drainages. So sepsis control is a key, because otherwise it's going to compromise on your FLR. And second optimization is the volume. So there are two types of volumes, anatomical volume and a functional volume. So your anatomical volume is what you just measure on your CT or MR. And even though I put as 30 here, that's usually for colorectal mets. But in terms of hyalocholangio, definitely you would say minimum 40%. And the functional volume, so the 40% is the anatomical volume, but that's based on the assumption that every cell in that FLR is functioning, but that's not necessarily the case with hyalocholangio. So you need to do a functional volume. So we do something called a mebrafenate SPECT CT routinely for these patients. And the cutoff we use is 2.69. But again, this specifically measures the functional volume of the FLR. But 2.69 is good for standard colorectal mets. But in these cases, we may even push for 3. And obviously, if the volume is inadequate based on both anatomical and functional, you will have to do a vein embolization. Again, we have changed our practice recently to dual vein embolization rather than just portal vein. So we always embolize the portal vein and the hepatic vein on the disease side. Just briefly about the mebrafenate scan. So this is based on the ROC curve. We just come up with 2.69. And this is how we do it. So if you can see in this patient, it's written as functional volume, but that's anatomical volume. It's 25.9. So you would think it's low. But if you see the function of the FLR, it's 2.79, which is good enough to go. So this one, again, it says the anatomical volume is 30. You would think that's adequate. But if you measure the functional volume, it's 1.87, which is inadequate. So it shows that there is probably occult background liver disease, which if it's not diagnosed, and these are the patients who struggle post-op. Just a quick algorithm on how to manage these patients. So if a patient is referred to you with the suspected hyalocholangiocarcinoma, and if you think it's resectable, do a PTC of the FLR side, along with endobiliary biopsy to confirm the lesion diagnosis, and plus or minus background liver biopsy. This helps to know if there's any background liver disease. We don't do it as routine, but if there is any suspicion based on the cross-sectional imaging, or if the patient has got background PSC, then we would do that. If the FLR is adequate, go for surgery. Inadequate, dual vein embolization. And if it improves, for surgery. If it doesn't improve, for palliative chemo. And if you think straight away it's unresectable, go for a PTC, because they all would need a biopsy for chemotherapy, and put bilateral metal biliary stents. Uncovered metal stents are perfectly fine on this occasion. Coming briefly to type of surgery, I'm not going to go in depth, but as I said, type 3A is the most common. So the planned surgery would be an extended right hepatectomy, When I say extended, you don't need to take 4. We routinely used to take 4 before, but that has serious consequences on your future liver remnant and small for size syndrome. So, and you don't need to do unless segment 4 is involved. So we now do only extended right hepatectomy and maybe extended to segment 4B, but caudate needs to come out always because of the way the biliary ductal drainage is. They all need extrahepatic bile duct resection, complete lymphadenectomy, and a hepatic jejunostomy. The hep-JEJ can be sometimes just 1, sometimes 2, sometimes 3. And type 3P, exactly you do same on the left side. So the main issue in these patients are they will have extensive fibrosis and inflammation due to a number of reasons, because of the stents, because of recurrent cholangitis, because you have done a DBE or a PE. So it's important to do frozen section regularly in these patients when there's a doubt. Just a picture to show how it look at the end of it. So without going in depth to the details of surgery, just a few technical tips I would like to say here. So aim for a negative microscopic margin, because this is one of the single most important independent predictor of long-term survival. So when you divide the distal bile duct and we divide the left duct, send frozen section margin and see how far you can keep going. Then if you're doing an extended right hepatectomy, if the left portal vein resection is needed because of tumor involvement, don't do it till the end, because then you're going to divide all the collaterals. And then by the time you do the transaction and finish, your liver doesn't look healthy. So you do your left portal vein resection up front before you even start transecting the liver. So get a stump above, stump below, do end-to-end or a graft, and then you go for the resection. And the third line is very important. Even if your left portal vein is not involved, so what we have found in our experience is once you take the right lobe out, right portal vein out, and do a complete lymphadenectomy, your portal vein is just flapping in midair. And there's an acute angulation of the left side when it comes off the main portal vein. They're very prone for kinking. So we have a very low threshold nowadays. Even if it's not involved, at the end of it, we resect and do an end-to-end so that you avoid that acute angulation. I still remember one 80-year-old patient I did operate on, and I was not convinced at the time to resect the portal vein. I left it like that. Post-op, she developed ascites, which was not getting better. You have to go back and stent the portal vein. So I think have a low threshold to resect the portal vein, even if it's not involved at the end of the surgery. If in doubt, just measure the pressure above and below the kink. Then complete mobilization of the caudate is very key. And Pringle, routinely, again, I tend to use Pringle, but hilar cholangio, it's preferable not to use Pringles because the volume is always an issue. So if you have to use Pringle, just use on the portal vein, just leave the artery, and so that the liver continues to get its blood supply through the artery. And the key thing with the PTC, don't take the PTC out, leave the PTC stent across the hep-JEJ or above the hep-JEJ. Because if this patient leaks, there is no way to access the bile duct again, because you won't have a dilated biliary system because of the leak, and you can't access because of the hep-JEJ. So always leave the PTC stent, above the hep-JEJ, and leave it till you're 100% sure there is no bile leak and the patient is completely recovered with no intra-abdominal collection of sepsis. Then you can pull it out. Then, as I mentioned, measured, again, I made it a routine practice to measure the portal vein pressure at the end. And if the pressure is above 18, because the reason we come up with the 18 is because above 20, you get small for size. So if the pressure is above 18, I tend to ligate the splenic artery to reduce the splenic venous return and thereby help with the post-op liver regeneration. Because you have mobilized the liver completely even off the caudate, make sure you fix the liver to the anterior abdominal wall, the remnant, because it can twist and obstruct your outflow. These are the tips based on my experience. So just quickly run through, I won't go through detail. This is one patient's journey. So as you can see, dilated biliary tree, and then you can see this patient ended up with bilateral PTC because I had recurrent cholangitis of the ipsilateral side. And then we did the FLR, and it was quite low. So he had to go for a dual vein embolization. So you can see the right anterior and right posterior portal vein being embolized. And the blue arrows, I don't know if you can see very clearly, there are coils on the hepatic vein. So that's the hepatic vein embolization. And this is post-embolization picture, CT. So if you measure the volume here, it's 2.12. It's quite low because here we are trying to do only one, say segment 2 and 3. But if you preserve part of 4, then it's adequate. Went ahead with the resection, and this is post-op CT scan. As you can see, the liver has hypertrophy. This is 3 months post-op. But this patient took 4 months from the diagnosis to go to the resection. Because of repeated PTCs, DVE, you have to wait for 4 to 6 weeks for the liver to hypertrophy. So this is the trend with cholangio. So you'd be patient. You have to make sure that the patient is patient because they do get fed up staying in the hospital or coming for recurrent admissions. Again, very brief about our experience. So 10, 11 years data, the numbers have gone up significantly off late. The last 5 years, it's a lot more than this. It's 85 in total. As you can see, the range is from very young, 27, that's somebody with PSC, and the oldest one is 80, which I just mentioned to you about. And 50% of them need more than 1 biliary drainage. And 8%, but again, this number is significantly higher off if I just include the last 2-3 years data. The DVE rates are much higher. And the number reading right side, as you can see, it's much, much more than the left-sided ones. Half of them need portal vein resection, but again, I would say this number is probably much higher now. So 3 patients had to have artery resection, but that was not pre-planned. It was at the time of surgery. And 1 patient, I think now we have done 1 more since, a combined pancreatic duodenectomy because the distal margin kept coming positive. So we have to combine epipulse with the right hepatectomy as well. And morbidity, you can see the percentage is extremely high, 63%. So 2/3 of your patient will have some amount of morbidity. And major morbidity is almost half. When I say major, it's bile leak, intra-abdominal collection, sepsis, recurrent cholangitis, small first size syndrome. So they have a significant morbidity. The mortality is 15%. So when we see a patient in the outpatients clinic, you have to quote a mortality of 15 to 20%. They need to be realistic of their expectations. The length of stay is extremely variable, based depending on number of PTCs they need pre-op. And so again, readmission, 1/5 of them will come back with recurrent admissions. Again, R0. So despite repeated attempts to do frozen section, it's only 68%. So some of them, you don't want to do a combined pancreatic duodenectomy along with a right hemipectomy. So it's distal margin is positive, you just have to give up. Or when you're doing the left frozen section, you keep going, but you can't go beyond certain extent. So just to summarize, hilar cholangio is extremely challenging to diagnose, but of late things have improved with spyglass and with PTCs. Preoperative optimization is very, very important to have a better outcome. So optimization both in terms of function and in terms of volume. Then surgery is extremely complex and carries a significant morbidity and mortality. So this should be ideally performed in a high volume center with expertise, both surgically and with radiologists, because most of these patients will need intervention at some stage or other, and good endoscopists. Thank you. Happy to take any questions.
The other best centers appears like?
Sorry, I didn't get your question actually.
Mortality rate of your data, which you have shown, appears little higher compared to other best centers. What do you say?
I think it does, because most of our experiences over the last 5-6 years, I would say, with hilar cholangio, because the way of the referral system works here. So one before that is almost like, I would say, a learning experience for us. And now the referral pattern has changed because people don't tend to do hilar cholangios even in designated HPV centers if the volume is low. So we have formed a local consortium here where the regional hospitals, even the regional HPV centers, refer to us so that the volume experience gets better. So we know based on our pancreatic experience that the volume outcome relationship is very, very important. So with that, our outcome has improved in the last 5 years, but this is a 11-year data. So
data with the next lead center, which is close by, is it better or less?
I don't know, to be honest, because lead surgeons have changed off late. So there was a surgeon who was retired just now, but he used to do the bulk of the hilar cholangios there. But now there is not a focused experience in Leeds, and it has moved to Liverpool. So there's a dedicated center in Liverpool for hilar cholangio. And for us, we get all the referrals from Wales, including Oxford, and from the Midlands. So the regional HPV centers don't do that anymore. So I think that has made a difference to build up the volume, because these cancers are not common to the stage where they go to resection. So I would say if you're probably getting around 10 to 15 of late every year, that's still low numbers. But what we are doing before is probably 3 to 5.
You show the data is total vein resection 40 plus something. Is it done as a part of the curative resection or just to prevent the kinking of the total vein on the left side?
It's just to prevent the kinking. So, because you don't see that with a colorectal or a HCC resection because you got the hilum intact. But in this one, you're doing a complete lymphadenectomy. So essentially, your hilum has got only portal vein and the artery, and you mobilize the liver completely. So there's nothing for it to stay stable in one position. And the way the anatomy is, your right vein is straight and the left vein comes almost at a right angle. So when you take the right vein off, you see that suddenly the left vein is just coming at an acute angle from the main vein. And with experience, we realize I think it's safer to resect at the end of it. And then just, it's a very tiny resection. You just have to take the angle off and just make it straight with the end to end.
How often you get type 4 ILR angioplasty?
I think in our experience, probably these ones are, by the time come to us, they're inoperable. So I don't remember resecting one recently. So they probably the way they extend, they involve bilateral arteries or bilateral veins. So I can't remember one where we've done a type 4.
If you look at the data of Nagino from the Nagoya University, they get the more often the type 4 ILR angioplasty rather than type 3. So it nearly close to 40 to 50%. But
Possibly, I guess again, I would probably thinking of the reason, I would say probably they don't even get referred to us maybe. When there is a bilateral one and it's involving the blood vessels, the local MDT might say it's inoperable, probably they're not coming to us. That could be one of the reasons. So, but I still don't know the denominator because what I've collected is all what have been operated upon. So what I don't know is the number who have not been operated on.
They have got a 30% resection of the arteries. I probably your data has started. Okay. Let me ask you the other question regarding the biopsy. When you do the biopsy through the percutaneous transhepatic approach or the spyglass microscopic approach, what percentage come positive?
So I didn't get that percutaneous approach, or what is the second one?
The spyglass microscopic approach.
So spyglass, we don't do it as a routine. So always the PTC to start with first because they need drainage anyway. So we go with the PTC biopsy at the same time. So it has significantly improved of late. So I would say, I can't remember the exact percent, but based on just the experience I've had, probably I would say 80 to 85% we are able to get through PTC. So the spyglass, we were initially doing via ERCP route to get the spyglass, but now we've got a new scope called Spy Discover, which we can do through PTC, so which is much better. One, it reduces the risk of cholangitis, and second, you get much better visualization from above, and getting to the lesion is much easier. So with that, our pre-op diagnosis is probably out of around 90 to 95% now. Still, out of this 85, the final histology came back as negative for malignancy in one patient, but rest all were positive. So, but still we didn't have maybe 3 or 4 confirmation of diagnosis pre-op.
Put up this R0 resection rate. And I just wondering if there are any routes for neoadjuvant therapy to improve outcome. Or intrabiliary therapy, as all experimental or any practice or any experience here. They put intrabiliary stent with radiotherapy.
So definitely we don't give radiotherapy here because our oncologists are not convinced. I know the Mayo protocol does involve radiotherapy, but we don't routinely or we don't give at all neoadjuvant radiotherapy. But yes, neoadjuvant chemotherapy is, we have done it. But the problem with chemotherapy for cholangiocarcinomas is the response rate is pretty poor. So only 1/3 of your cholangios respond to chemo with the current chemotherapy regimes available. So if you think it's upfront resectable, you should go for surgery. But the reasons we give neoadjuvant chemotherapy is one, there is a contact with the contralateral artery. Let's say it's not involved, but it's touching the left hepatic artery. Then we would go for neoadjuvant chemo. But otherwise, if it's upfront resectable, just go straight for surgery purely because we don't have a good neoadjuvant chemotherapy at the moment. The response rate is only 1/3.
Question from the audience.
Sharma, Saurabhi, would you like to? Sir. Okay, there are no more questions, Ravi. Thank you very much. That was a good presentation.
Thank you. Thank you very much.
Thank you, Ravi, for the excellent talk.
Thank you.
Thank you, sir. That was a very insightful session on the management of hyalocholangiocarcinoma. We shall now break for tea. Kindly reconvene in the hall for the evening session in 15 minutes at 4:45 p.m. Thank you. Welcome back. Moving on, we now have a case presentation by our postgraduate students, Dr. Likita and Dr. Vijay Raghavan on liver mass. I request Dr. Vishnu Prasad, Dr. Rajan KV, Dr. Shanmugam and Dr. Debashish Naik to go on to the stage for chairing the session.
Good evening, sir. Here myself, Dr. Vijay Raghavan and Dr. Likita. Here we are going to present a case about right hypochondriacism. Our patient is a 60-year-old gentleman, farmer by occupation, belonging to upper lower class, according to modified economic socio-economic scale, hailing from Vilupuram, in Tamil Nadu, presented with complaints of upper abdominal pain for past 1 month. History of presenting illness: the patient was asymptomatic until 1 month back when he developed upper abdominal pain, which was insidious in onset, dull aching, and continuous. The pain was localized to the right side of the abdomen and it was non-radiating. There was no specific aggravating factors, and the pain was relieved by analgesics. The pain had no relation to food intake and was not associated with nausea or vomiting. The patient had no history of loss of appetite, but had significant history of weight loss. He also had complaints of difficulty in initiating menstruation, straining, and an increased frequency of voiding at night. He also gave history of loose stools for 1 week, 1 month back, which was subsided by the.
For the pain, it just got 1 foot of weight, the chief complaint, I think. Continuous pain. Yeah,
the patient also gave history of loose stools for 1 week, 1 month back, which was subsided on medical management at local GH. The patient had no history of fever, vomiting, constipation, bleeding fever, or passing black tarry stools. He had no history of hematuria or burning ulceration. The patient had no history of yellow distillation of high colored urine and pale colored stools. The patient had no history of ball rolling movements, abdomen distension, early satiety, and postprandial fullness. The patient had no history of breathlessness, chest pain, easy fatiguability, and bone pains. The patient had any history of no chronic drug intake, no history of any IV abuse, no history of any blood transfusion in the past. He had no history suggestive of any anaphylaxis or allergic reaction in the past. Going to past history, the patient had no history of similar complaints of abdominal pain in the past. They have no known comorbidities like diabetes mellitus, hypertension, asthma, tuberculosis, epilepsy, or coronary artery disease. The patient had history of surgery for right inguinal hernia 5 years back, but the records are not available. He has recently found to be hepatitis B positive in outside hospital, and he was not started on any medication for that. The patient had no history of any similar abdominal complaints or cancer in the family members. Personal history: he consumes mixed diet. The patient has normal appetite and bowel habits, but has disturbed sleep pattern due to the increased frequency of micturition and nocturia. He doesn't consume alcohol and is a non-smoker. He has no known drug allergies. With the available history, I would like to summarize. A 60-year-old gentleman recently diagnosed with hepatitis B with the complaints of dull aching right upper abdomen pain for past 1 month with significant weight loss and a complaint of low urinary tract symptoms. He also had history of loose stools 1 month back, but with no significant history of bleeding manifestations are grounded.
So what is this pain? Dull aching, right upper abdominal pain. But that usually replaces the fetus, replaces the right hypochondriacism. The pain abdomen. It localized ABS chamber, umbilicus, or hypogastric in the midline. You have written right hypochondriacism.
Patient mainly complains of pain on the right upper abdomen.
What is it? Pain due to as per your history.
In the right hypochondrium, mostly the patient, considering the patient old age and the history of loose stools also patient is having. I would like to think of patient is formed by occupation. I would like to think of any amoeba abscess causing loose stools and amoeba liver abscess as one of my diagnosis. And
fever. Without fever, pain, I mean, sorry.
He had no history of fever. Maybe the late presentation, maybe liver abscess, like patient initially he had loose stools. Now he is having only the pain he has developed.
Why not this pain in the stomach? First, you need to, whenever a symptom is like that, you need to distinguish whether the pain is arising from a solid visual viscera or the luminal abscess. How to distinguish that?
Like nature of the
pain. right?
If the pain is associated with any food intake or any, what is the type of pain, whether it's dull aching or colicky, whether the pain is relieved by any vomiting or with analgesic, mode of the aggravation and relief factors based on that.
So you have ruled out all that. You have taken the history.
Yes, sir. Patient doesn't have any history of retching or any history of changing pain with the food intake.
Does the pain radiate to the back?
No, sir. No history of variation of pain.
You have told them?
Yes, sir.
Okay. So it's not a pancreatic pain.
It's not a pancreatic pain, sir. Patient mainly pain of the right upper abdomen and it's not radiating to back.
It's there is no any. You have written lower urinary tract symptoms.
Yes.
What are the symptoms?
He had an increased frequency of micturition in the night and difficulty in initiating micturition and the straining also is complaining.
There's no pain along the radiating along the.
No, there no line to groin pain, no radiation.
No hematuria.
No hematuria. No.
Less likely to be originating from the kidney.
Like less likely to be a pain originating from the kidneys, like, because the patient doesn't have any complaint of like colicky pain and the only that initial patient is old age complaints with the history of the venoplastic hyperplasia like initiating infiltration and increased frequency in vomiting in nights. Doesn't have any colicky pain relating to obstructive urinary symptoms.
Colicky pain in the right upper quadrant due to renal problem. Colicky pain may be irritated slightly lower abdomen. Right upper abdomen pain, don't say colicky pain. So can't be renal colic. Renal colic is a misnomer. Doesn't produce any stone sitting in the pelvic system. You don't produce that kind of. That's been the tube, no tubeless structure. They get it. Show the negative history. Taking so many negative history because the chief complaint only abdominal pain. You ask for history of ball rolling movement. Why is that?
Sir,
right upper quadrant pain, why ball rolling?
We want to rule out that any gastric pathology like gastric obstruction due to the phase of any mixture of vertical disease causing gastric obstruction or any malignant outlet obstruction to the stomach.
There is no pain localized to the right upper quadrant. Yeah, like pain arising from the stomach going to the right upper quadrant.
Any pain arising from pylorus or D1.
Yeah, typically no, it confines to the epigastric disc. You don't get pain on the right side. Gastric or obstruction, pain in the right upper quadrant. Quite rare. Go to the characteristics of the distinct pain. The initial stages. Yeah. Pain which was insidious, dull aching and continuous.
Yes.
Is it severe?
No, sir, that pain was less severe, but it is the dull aching continuous pain. So the patient's pain is getting relieved by the over-the-counter anesthetic. The pain was continuous and low grade for the past 1 month, so it helps the patient to relieve the aid-seeking medical nursing.
So you were diagnosed, you said amoebic abscess, you get more severe pain. And sometimes there will be pain. So, but if it is pyloric abscess, definitely there will be pain. Right? So based on this history, what any possible provision diagnosis can be made?
No, like pain is over the right upper abdomen, and the patient is the oldest patient. So the local is the organ. I want to rule out any malignant cause causing the pain, like any hepatic fluxure malignancy or any malignant mass arising from liver or gallbladder.
Hepatic fluxure malignancy, you get other symptoms. There may be history of either anemia or obstructive symptoms. Right? What other thing is it?
Any malignant mass arising from liver.
Liver mass is possible because sometimes they do not be much symptoms. They are very mild pain and conflict-related pains. Right?
And malignancy of gallbladder also, I have put it on a differential diagnosis.
Mass usually presents differently. In what we see in our OPDs, the most often they present pain abdomen or jaundice, right? And a mass and palpation. But if you go towards the north, they present early. They may instead of 60 years, and usually it's more common in females. Okay? And if you go to the northeastern states, they come early. They come at the age of 45, so I've seen many times. But they coming with pain abdomen, mass of and jaundice. Right? More common in the northeast to the Gangetic type. Here usually they come, but we get reference nowadays people starting kinds of the West Bengal because there's a direct line. We also get sometimes. Right?
And then one of my last differential diagnosis, I want to consider the carcinoma prostate. Also, my one of my differential diagnosis with the patient is having the lower urinary tract symptoms and with the upper abdomen pain. It also cannot be ruled out.
No, they don't present like this. They usually carcinoma prostates many times it is detected incidentally. So not a very common thing, but you're right. So urologists may be able to get it better. My experience with that is yes, but I don't think they're present like this.
One of the last possible.
I need, no, I don't think amoebic liver abscess has to be first. Instead of that, you can consider any space occupying lesion in the liver, right? So probably malignant liver tumor. CGB less common. You can have carcinoma, you have to delete all this carcinoma, prostate, amoebic liver abscess, hepatic fracture, malignancy. These are to be
diagnosis, think of that based on history alone. Giving the diagnosis based on history or examination. You have to be diagnosed. You are able to diagnose
Patient is having the right upper abdomen, so possible causes I want to know.
You can only say the liver mass, probably malignant liver mass, right? Or a mass arising from the liver producing symptoms. You cannot give the differentiate. That is our given based on CD. Right? More common is HCC or secondaries. Right? The commonest tumor is secondaries in the liver. The next may be HCC. Right? So then other tumors. So you cannot give this way of giving differentiate. I will not satisfy the exam. I can say liver mass, probably malignant theology, and what is the most common means secondary to the liver, next to HCC. That are. And the patient is younger males, you may consider connected. So different depending on. So you have to delete all that. This doesn't look good. Don't write like this. The paper you give to the exam.
This differential diagnosis looks like you have Googled and got the differentials. How you can make a differential after taking all these histories? You should come out with a meaningful diagnosis or the differential diagnosis. How you could put random all combinations just because pain in the right abdomen. Why you suspect malignancy in this patient? On what basis? What points you got to make a diagnosis of malignant lesion? And how you made that organ is more of a liver.
Patient is having significant extra weight loss.
Have you quantified the weight loss?
Not quantified. He's saying that by loosening of the cloth.
How long he has been able to say that he has lost weight?
Past 3 months.
So his presently complaints is 1 month duration. But weight loss he has got for last 3 weeks. Then how do you say it is significant loss?
Patient himself was noticing that there is a loosening of cloths.
And he has got some history of some HVSAG which was detected recently. Does it have anything in implication in the diagnosis? How you connect that here? Have you got any other further details on that? When he was diagnosed first of all?
Patient was diagnosed with hepatitis B and he went to outside hospital for the management of loose tooth here. So that time he had not started on any medications and further investigation also not taken. And the patient was
So this was some recent 10 days.
Recent diagnosis.
And that surgery, what he has undergone in the past?
Right ignorant for that he has undergone mastoplasty before 5 years, for the records are not available. Patient is saying he has undergone surgery on it.
So any complications he had or any time he had subsequently any history of jaundice or anything he has had?
No history of jaundice and uneventful recovery following surgery.
Okay, 60-year-old man, person presenting with pain abdomen and loss of weight. So considering probably 71 marks. Okay, example.
Good morning, sirs and dear friends. I am Dr. Likita, final year JR. I will be continuing with examination. He was examined after taking verbal content in a well-lit room. General examination revealed he was conscious, cooperative, and well-oriented to time, place, and person. He was afebrile, normally built, moderately nourished, and adequately hydrated. His BMI was 20.54 and ECOG status of 1. He had no pallor, icterus, cyanosis, clubbing, fetal edema, generalized or supraclavicular lymphadenopathy. He had no stigmata of chronic liver disease. His pulse rate was 90 beats per minute, regular rhythm, good volume, measured in the right radial artery. And blood pressure was 130/70 mm of Hg in right arm in sitting position. Respiratory rate was 15 breaths per minute, abdominal thoracic type. This is an inspection. After adequate exposure from nipple to the pubic symphysis, patient was examined in supine position with arms by his side. The abdomen was flat with fullness in right hypochondrium and right lumbar region. Flanks are free. Umbilicus is normal in position, centrally placed and inverted. Skin over the abdomen is normal. Scar was noted in the right inguinal region. No dilated veins or visible gastric or intestinal peristalsis. All quadrants move proportionately with respiration. No visible cough impulse or swelling was noted over the hernial orifices. No fullness noted in over the right renal angle. External genitalia appears to be normal. Coming to the palpation, his abdomen was soft and non-tender. Liver was palpable 6 cm below the right costal margin in the mid-clavicular line. It was non-tender and had no local rise of temperature. Has a smooth surface over the medial half, and a 10/6 cm mass was with an irregular surface was palpable over the lateral half, which was firm in consistency and was extending from the right hypochondrial.
You mentioned no local rise of temperature. Which abdominal mass it produce raised temperature?
Because initially after resting, we were thinking in terms
Any
of
abdominal mass, you can feel the temperature through the abdominal wall, through all the layers of abdominal wall. You think the heat will be conducted through so that you can make it. Can you feel it?
It is less likely, sir. It doesn't
Normally, if you get parietal dorsal, there maybe it's relevant. You only said liver is palpable. You only confirm that the mass you feel is liver. You said no local. When will the liver be hot? Before any hot liver? Even kind of big abscess inside the liver, you may not feel the temperature outside. You feel it through the layers of the abdomen. This feeling other places is important. You always start off with that. You find it, you not take there, not just there, not the ingrout also. You continue.
The upper margin of the mass was not felt and was extending to the right subcostal region, as it was not possible to insinuate fingers below the right costal margin. The mass was moving with respiration but had no intrinsic mobility and became less prominent on head raising test. In the inferior border of the liver was rounded and regular in the medial half and was rounded and irregular in the lateral half. Spleen was not palpable. Renal angle was normal. No lump or tenderness on palpation. Hernial orifices were free and external genitalia was normal on palpation. On percussion, upper border of the liver dullness was in the fifth intercostal space in right mid-clavicular line, with the liver span being 18 centimeters. Dull note was focused over the liver, over the mass in the right hypochondriac region and right lumbar region, which was continuous with the liver dullness. Rest of the abdomen had a resonant note. No free fluid or shifting dullness was noted. Top space was tympanic on percussion. On auscultation, there was no bruit or hum or rub over the mass. Bowel sounds were normal. And on digital rectal examination, normal anal probe was noted with the empty rectum, no mucosal irregularities, and grade 2 prostatomegaly was noted. No pelvic deposits and normal smooth staining of the gloved fingertip was observed. Other systemic examination, cardiovascular system, normal heart sounds were present and there were no murmurs. Respiratory system, normal vesicular breath sounds were heard equally on both sides and had no added sounds. Skeletal examination, no abnormalities of the skull or spine were noted, and there was no spine tenderness. Summarizing the case, a 60-year-old gentleman recently diagnosed with hepatitis B and had no other medical comorbidities, presented with complaints of dull aching upper abdominal pain on the right side, for 1 month with significant loss of weight and complaints of lower urinary tract symptoms. He also had history of loose stools 1 month back, but had no significant history of bleeding manifestations or jaundice. On examination, he had a performance status of ECOG 1. Abdominal examination revealed hepatomegaly with the rounded inferior quarter of the liver, 6 centimeters below the right posterior margin, and a mass and right hypochondrium extending to the right lumbar region, having irregular surface on the lateral half of the liver, which was firm in consistency and non-tender. He also had grade 2 prostatomegaly on PRI.
You got on liver, so it's like previous level. You got a hepatomegaly of so many centimeters. Next one, the summary.
Yes, sir.
6 centimeters. There's one more mass. One mass in the RHC extending to the right lumbar. So 2 different masses.
No, sir, it is the same mass, sir. Initially, I explained it as a hepatomegaly, and on the lateral half of the enlarged liver, there was a mass which was around 10 to 6 centimeters, and it had an irregular surface.
That's separate from the liver.
It is not separate from the liver. It was the damage was continuous with the liver, and it seemed to have been arising from the liver. But because of the surface irregularities which were noted on the lateral half,
We describe surface normally we use these terms, whether it's smooth or nodular. So we describe any cellular surface. It's like basic things. Say it was smooth or nodular. Was it nodular or smooth? But make up your mind. That's a irregular surface.
it was smooth, sir. Just because
You said the border is rounded, no rounded border.
Yes.
Next, the other important hint is the the surface of the. It's going to give you the underlying pathology. Rounded border, what does it tell you? When you find a liver rounded border compared to sharp border, does it make any difference?
Yes, yes, sir. Round borders are usually seen when there is.
What does it indicate? Rounded borders of the liver. The underlying pathology doesn't indicate the nature of the pathology.
It could be due to architectural reorganization.
Infiltrative, no, there's some infiltrative lesion within the liver. That's when you get the rounded border. You get congestive cardiac failure, you get a sharp border. Liver. Because in last but you get a sharp border, then basically it's congestive liver. But when you get infiltrative liver lesion, then you sort of find the border getting rounded. Next clue is your surface, whether it is smooth surface or nodular surface. So nodular surface indicate what?
It indicates cirrhosis, or any other
Elderly man who comes with weight loss and you got a large liver with nodular liver surface, what is the indicate? It is more likely to indicate.
It indicates
Only on based on clinical, all based on clinical findings, we're trying to find out what is the likely diagnosis.
irregular surface will go in favor of any malignant lesion, case occupying lesion of the liver, considering the stage group as well. And with the background of hepatitis B, there is no likelihood of malignancy.
When you find such a big mass outside, the answer is become vacillated surface. On the occupying one side, 6 centimeter, 6 centimeter.
That was, yes, it was 10 plus 6 centimeters.
It's not much of the lateral side.
Yes, it's only on the lateral side.
Is the
It
mass
was like, it was non-tender. And there was,
there is tenderness?
it could be due to viral hepatitis.
Get such a big liver. When you get such a huge liver, which is so big, more than 5 centimeters, usually you consider with a irregular or a vacillated or a surface.
I would consider liver abscess.
No, not tender. This hemorrhage is good. Any hemorrhage has happened in the underlying malignancy. No. There are the tenderness like that. Without tenderness, you get a liver which is so much enlarged, you have to consider a space occupying lesion. In a patient with abstention, you must have noticed liver enlarge is just a 2-3 centimeter. When you get a bigger liver, consider a space occupying lesion. If it is not tender,
So you have to consider like a malignant patient is close to elderly, 60-year-old. You have to consider space occupied lesion, either secondaries or a primary liver tumor. So bigger liver, secondaries or primary liver. So such big tumors you don't get in a obstetric diabetes. You get smaller, but when they get metastasis, it may become big. Right? That's a clue. When the liver, you get in a surgical ward, you get a patient with a big liver mass, probably a liver tumor. And the secondaries are primary. Right?
Just show the outline of the liver. So you got a groove like this. So that is the little part is the mass which is feeling a separate mass.
Yes, sir.
Projection from the liver.
Yes.
How do you describe hepatomegaly on examination?
Hepatomegaly, sir, this, first we calculate the entire abdomen and look if the liver body is pathogenic. And we start the examination from the right idea further, moving upwards with each breath. And then if the liver, and it is measured at the point where the liver body fits if the comma surface of the hand. And if it is continuous, if it is continuous not and the border is well palpable, then it is
All palpable liver is hepatomegaly.
will depend on the stages of the patient and the
Yeah. So in this patient, which liver, right liver, left liver, or both are enlarged? Right, look, so you have to describe the liver span in the on the midline, mid-cleft, and also the mid axillary line. To say that it's a uniform and diffuse hepatomegaly, or it's a tumor alone that you are describing. And did you see any other mass per abdomen? What you look for?
Because of its location in the lumbar region, I would look for renal angle and also any intestinal pathologies or if there was no palpable lump per se. To indicate a malignancy of colon or
Any other organomegaly?
spleen. Spleen was also not palpable, sir, because the liver was enlarged. I wanted to rule out portal hypertension and it is a chronic liver.
How did you look for a splenomegaly?
Splenomegaly, we start examination in the right idea and go diagonally to the opposite side and look for enlargement of the.
So that rules out splenomegaly?
It should be enlarged by at least twice its size to be palpable.
So if you're not palpate, that means there is no splenomegaly.
We also checked for the top space. If there is splenomegaly, that would have been done, but it was resonant in this case.
What is the boundary for it?
Trough space is the semilunar space, which has upper border is the sixth costal sixth spirit, and the lower border is the costal margin, and lateral is the mid axillary margin.
There is a problem in this slide. Not the problem. There's written Carnet's test. You always did the mass and with the respiration. So where is the question of doing this Carnet's test? There's no meaning to that. You should apply whatever you know, whatever test you're supposed to do, you should apply everything in a particular question. Once you find a mass moving to inspiration, it becomes meaningless.
So you also how did you find out the extent of the liver? What is the upper extent of liver dullness?
Upper extent of liver dullness was in the fifth intercostal space.
How do you surface mark the liver?
We started percussion in the mid axillary.
Have that idea so that you can mark the liver border and see whether liver is really enlarged or it is pushed down.
And if you take a point between the mid-axillary line, the subclass will take that is 10 and another point in the fifth intercostal space, mid-axillary line. So join these two lines, that will be the right lateral border. And then take another point in the left mid-clavicular line, fifth intercostal space. Join this line. Right? You got the idea. So that is the upper border. And from below you join these two lines. Mid-axillary line, fifth intercostal space to the subclavicular space on the right side. That will be the border. Right? So that will be the liver outline. Right? So that is a normal position. Normal outline. Right? So if you draw that, then you can very easily see that liver is enlarged. Right? And then you also should give during dullness various upper border of liver dullness. And when you give this, when you say that the liver mass is enlarged, you should give the measurement in the anterior axillary line, mid-clavicular line, and from the exhibit star. That will be better for the examiner if you want to score better.
In that examination, you mentioned that lesion is seen in the right type of organ extending into right lumbar. Is it the same? Or from the picture, I don't see. Like
It's almost extending to the level of umbilical.
So how you divide that abdomen into regions?
By two vertical lines from the mid clavicular lines of the transfer, and then a transpyloric plane, which is at the tip of the costal margin of the joint, that is the first horizontal plane, and the next horizontal plane would be the transtubercular line, which is from the highest point of the iliac crest.
So if you draw that line, does it fall within the right hypochondrium and the right lumbar region? So you also have to be little clear that that line doesn't clearly puts everything that below the costal, right costal is as the right hypochondrium. So it is into the epigastric region also.
Because the mass was the irregular surface noted was only on the lateral aspect. So that I have considered as hepatomegaly, which is extending into the epigastric region and not the mass related. After the examination, I would keep my provisional diagnosis as space occupying lesion of the liver, probably of malignant etiology, hepatocellular carcinoma as first, and maybe liver secondaries with unknown primary.
This list is not accepted. First, why not consider liver secondaries first?
Because it was liver secondaries of 10 plus 6 centimeters.
We have seen many patients with secondaries, entire liver occupied by liver secondaries. They can present with huge liver mass. Nothing like that. But why you are not considering liver secondaries in this patient? First.
We are not able to get any significant history of primary, and the surface of the liver is not nodular, like significantly telling to secondary like nodular surface complication that we are not able to.
You may not feel application in that. It's not possible.
That we are not able to appreciate.
But you got important clue, the HPSAG positive.
Right? That is also pointing to primary liver.
Whenever there is HPSAG, you have to keep that in mind, because most of the liver carcinoma appears in the background of inflammation. Right? 80 to 85 or 90% of the patients, they are already, sometimes we don't know what is the type of inflammation going on. It may be HPSAG or CV or some other types of inflammation. That's a result of other toxins. Many times you're not able to do it. Right? So it always appears as a type of. So we are not considering liver secondary. Probably you have to give an answer that we are unable to find any primary symptoms like a gastric carcinoma. Right? But in this case, the examiner may ask you got a lower tract infection. So is there any genitourinary malignancy likely to metastasis to liver and particularly the diffuse secondaries? So we have to answer that question. Right? So any genitourinary producing setting liver? There are areas where you can get primary without any symptoms. Any areas, they can present liver secondary. JIT. All occult, you will have carcinoma in those areas, but they will not have any symptoms. They present in secondary school. I have to give this answer first and then defend that answer. So you have taken a pretty different history and examination. But when it comes to the diagnosis, you can't just put and fill as many possible differentials as possible without any points to justify. Why you have put a gallbladder, hepatic picture, and all those things in this differential? What points you have got to keep this as a differential in this patient? So what points you have got specifically you are suspecting this to be a gallbladder or a carcinoma hepatic picture?
Because I had a history of loose tooth, there was some altered bowel habits history. But it was very short history and it was only 3 weeks back that he had for 1 week. So we thought it could not be ruled out. So in that case, we have kept that.
Is that sufficient to make the diagnosis of hepatic fracture? Or that is how the patient usually will present? Just because he gives a symptom of loose stools, do we make a conclusion that it's malignant based on that?
Considering his age and history of loss of weight.
Why you mentioned locally advanced? Clinical diagnosis locally advanced. How did you make out locally advanced? Not a simple gallbladder. Why you are locally advanced? How did you find out it's locally advanced? Both your colon and gallbladder are locally advanced.
Because the mass was not separately palpable from the liver. So
in the lateral situation, you are saying that is the gallbladder. What you feel in the lateral aspect of the liver? That is not the place you find carcinoma gallbladder. GB mass you won't find that lateral. You're thinking carcinoma gallbladder, then you have to say it's a secondary, it's a prominent secondary, it's a lateral aspect. Probably you're not able to feel the gallbladder mass. You will not have to from this, not on the fundus. Because the neck or the body. So that's why you're not able to feel the GB mass. How you differentiated it's a small bowel diarrhea or large bowel diarrhea and how you are suspecting colon as a cause for the loose stools?
If it is a left colonic malignancy, then the patient might have spurious diarrhea, which will be more mucoid inconsistent. But in case of right-sided colonic malignancies and to differentiate it from small bowel, I'm not sure about it.
Make a diagnosis, you should have points. What is strongly suggesting you to put that as a differential. So without any valid points, just to put it will put in a complicated situation. Order should be different, must be excessive because you say that hepatitis B positive, plus then next comes the secondary with hormone factor. Then comes all your other conditions which are don't have any answers or things to explain. Okay, because of lack of time, we proceed. So, how would you like to come from your diagnosis?
Yes, next I would like to do baseline investigations with CBC field analysis to look for any change in derangement in the liver parameters. And followed by serology, as you were already suggested in HbA positive, and further do HbV DNA titers. And for diagnosis and staging, I would like to do tumor markers and an ultrasound to localize the lesion and also the extension of clinical examination.
This will increase the cost if you do tumor markers like this, AFPC. I think I don't put the determine you cannot do like. So the examiner asked, how do you confirm your diagnosis? What did you say? I would like to run this tumor markers.
I would prefer to do AFP and prostate specific antigen corporates.
No, first to do a screening ultrasound. See. So in this way,
so ultrasound
Ultrasound showed a Liver was 12.8 centimeter, creating a caudally with normal echoes under smooth contour. There is evidence of 9.8 plus 1.7 centimeter size in heterogeneously hyperopic lesion in segment 5 and 6 of the right lobe of liver. The lesion shows a poorly defined capsule. There are no cystic areas and calcifications. There is the evidence of another similar lesion measuring 2.9 plus 2.9 centimeter abutting in the right lobe of liver. Hepatic vein, portal vein, and intrahepatic and extrahepatic common bilates appear normal. And gallbladder, pancreas, spleen appear normal. So no free bleed occurring. Ultrasound KUB, right kidney measure 10.5 centimeter in size with normal echoes and CMD maintained and no calculus, HN hydroelectronephrosis present and TPD was 1.2 centimeter, P of 6 mm and meteorator obscured distal ureter 6 mm. A 7 mm cal noted in the right vesicular junction and left kidney was 10.3 centimeter in size and normal echoes, CMD maintained, no calculus or no hydroelectronephrosis. Urinary bladder distended with wall thickening present with measure 5.3 mm. Prostate measure 67 cc. Our impression from ultrasound is there is a space occupying lesion in the right lobe of the liver with the right VUJ calculate with mild upstream HIM and grade to prostate.
So what is pain? Is it due to the mass lesion or is it because of the right vesicular junction calculate?
Patient's pain characteristics was not correlating the pain due to the VUJ calculus. It is a dilating and dilating.
Okay. How would you like to? This is enough to make a diagnosis. You would like to do further imaging. Based on this, what's your impression? SOL in the right lower liver.
With the no circular and on the background of hepatitis B positive, I consider the hepatitis carcinoma diagnosis before going to further investigation.
What further investigation?
I want to confirm the diagnosis of taking with tumor marker AFP and CECT, contact and CT I will like to. Out of it, more than 54,000, sir. It has a markedly elevated.
Right, viral marker, low, less
than that.
What additional investigation we want to further confirm the diagnosis? Ultrasound sufficient?
I'd like to go ahead with CCT. Look for the confirm the diagnosis and look for the extent of the lesion.
CCT means what?
Like CCT liver protocol with the arterial, portal, and venous spaces.
Yeah.
Yes.
Why you want to do that CT? What do you call that? Triple phase liver CT. So what is it? Why you want to do? What are the phases it will be taken?
First, we take the non-contract CT, followed by an arterial phase, which is taken 20 seconds after the injection of contract, after the giving the contract. And the next is the portal phase, which is taken with 60 to 90 seconds. And after that will be the delayed phase, which is taken at 5 to 10 minutes. So different lesions in the liver have different characteristics in these phases. So it will it's now like in case of HCG, there will be an arterial hyperenhancement and portal phase hyperenhancement and venous washout. In case of metastasis, because it is supplied by the this characteristic of HCG due to the because it derives the arterial supply from the hepatic artery. And in case of metastasis, it has a different thing. So,
it's our patient who we.
This is the first image of the coronary section, and the next is the cross section of the liver. And this is an arterial phase. We can see hyperenhancement of the hyperenhancement within the lesion and the few areas of necrosis. And next is portal phase, where we can see isoenhancement of the lesion with the rest of the liver, and there is a capsule which would be read out. And in the delayed venous phase, the liver was enhancing more than the lesion, so it suggests the washout, and with the capsule becoming more prominent. So, findings of CT, liver measures 17.4 centimeters, 20/40, well-defined, heterogeneous, partly exophytic lesion, measuring 10 × 12 × 11 centimeters, noted in segment 5, 6, and 7. And there was arterial hyperenhancement, portal isoenhancement, and washout and delayed phase with few non-enhancing areas with them. And the lesion was so closely abutting the posterior segmental branch of the right portal vein. Other findings, there was no significant peak fluid in the abdomen or extrahepatic spread, which was noted. Though there was it was abutting the anterior surface of the right kidney, but fat planes were in it was not infiltrating.
Okay, what is the impression of the radiologist?
Impression, they have.
What's your impression?
There was phase occupying lesion of the liver, with the characteristics in the three phases. I would like to think there's hepatocellular carcinoma.
Your secondary analysis in which phase?
It enhances in the portal phase.
Usually it will be multiple, but sometimes there can be single solitary lesion also can be as big as LCC, but analysis in the whole business. That's a good. What about the intrahepatic chlorine? Because he had one of the different. Can it be this? Why? What will be the CT feature?
In intrahepatic cholangiocarcinoma, there should be.
It doesn't have to enhance completely. Actually, be a synchronously enhanced, but there will be one prominent feature of capsular contraction. It's typical feature of the intrahepatic cholangiocarcinoma. You see that you can increase the synchronously enhancing in the arterial base with capsular contraction. Right? So that is usually the list of intrahepatic cholangiocarcinoma. We have operated with the intrahepatic cholangiocarcinoma.
So you described about the lesion in detail, but is it sufficient information you get from the CT, or anything more you need to see?
I would
So
like
what specifically?
any vascular engagement with it and any anatomical gradient.
Okay, then.
Extra hepatic.
We just see any whether is it not, you know, this the case because I have operated on this patient. Time is up. I think we have to speed up another 1 minute only.
There was
You have to
180-degree contact with the portal IV Caesar, but
possible to that.
it's just
It doesn't matter. What will you do? It is a big mass in the right way. You suggest you HCC. What else? Any additional investigation would you like to do?
I would like to look for the rest of the liver parenchymosis. I would do a RP scan to look for any fibrosis. And yes, sir. It has a mean shear velocity of 8.5 kp with suggestive of active fibrosis.
Okay.
Some mild changes of fibrosis. Going by the blood investigation, we had calculated the child score to be class A, and then MELD score was 7 points. And looking here because the investigation with multinodular.
Any other investigation?
We would like to do an upper GI to look for any hepatic decompensation.
It means very. Any other investigation?
The lesion is non-mental study. I would like to offer a curative treatment. Before going into research, I would like to do microfinance scan to look for the future liver.
Future liver remnant. What is microfinance scan usually says? What will be the normal, abnormal?
That is a lidocaine-based technician scan. That I will take on with a normal liver parenchyma. And the abnormal tumors that will not take on the dye. Based on that, we have to calculate the future liver.
No. That is what is the value which tells the normal function of the liver? 2.65 percentage.
2.7. 2.7.
Percent. What is the value? Full value. There is given then. Per minute to minute square. Where is it given? Yeah, there. 4.76% per minute per 1.73 meters square. 2.65 per minute. Normally it should be above that. 2.65 per minute per meter square. If it is above that level only, we will consider for liver. If it is below that, we will not consider. Right? So another way is doing it through the ICG, which we don't have currently this, but we have the development scan. ICG retention at 50 minutes, giving the ICG and C, less than 10% should be retained. More than that means the not should have major repetition. So this one, what will you do? There is some HbA positive, F2 fibrosis. Want to do resection or want to do transplant?
I'd like to downstage the tumor by case first. And the lesion is large and the tumor load is also high. Future liver amount is also like 25%. And on the background of competitive also like to downstage the tumor by doing case first.
Yeah, same thing we did. We initially did a case for this patient and then so waited for 2 weeks. Right? Yeah. Actually, I was not aware that you have prepared this. It's good that you have taken the real case from our view. After that,
I would like to take a repeat CT to assess the test post test tumor load. It is increased and
so since we don't have the transplant facilities, we cannot offer. And so whenever a major vessel is involved, there may be contraindication. In this case, the right hepatic vein is involved, alpha protein is very high, right? So major vessel involvement is maybe a contraindication. So you have to downstage, bring it to the normal. So that's what the Taiwan is doing. When I was there for a year, right? So they bring it to the criteria because there's the strict criteria and then that the insurance doesn't approve unless it falls within the UCSF criteria. But in the Vedanta Institute, they have got a different set of criteria where they downstage using the cyberknife or the chemo, this thing, radio, this thing, atrium sphere, bring down, stay downstage. If there is no major involvement, vein, portal vein, major trunk, or the hepatic vein, not important. We'll discuss that in a later because it's difficult to understand that part of the transplant criteria. We just stick it to that because of lack of time. So after this, we went ahead with the resection in this patient, right? So we did a right hepatectomy. The picture is there. Yeah. Okay. Okay, thank you for the opportunity.
thank you.
Thank you, sir, for this informative session. I now request the examiners to award certificates of presentation to Dr. Likhita. Dr. Vijay Raghavan. Thank you, sirs.
Now, we have the final case presentation for the day on right iliac fossa mass by Dr. Vikyat and Dr. Veda Prakash. I request the examiners, Professor Dr. Vikram Kate, Dr. Asias Bosco, and Dr. Rajkumar N to kindly come to the desk.
RAF mass.
If you are ready, we can start. Good evening, everybody. Dr. Vikas and myself, Dr. Vikas, and this is Dr. Venu. And you hold the mic little closer. Yes, let's see, closer because somewhere, whatever we want to do. Voice has to be heard clearly and loud. Yes, yes. Yeah, finally, a junior residents from Department of Surgery in JIPMER. We're presenting a case of RIF mass. Presenting a 68-year-old male, a manual laborer by occupation, belonging to lower socioeconomic status as per modified Kuppuswamy scale, known case of chronic kidney disorder on medical management, and a known case of hypertension for the last 6 years, but on irregular medication. Presented to us with complaints of pain in the right lower abdomen for the last 3 months, passing black tarry stools for last 15 days, and blue stools for the last 1 week. History of presenting illness. Patient was apparently asymptomatic 3 months ago when he developed pain abdomen, predominantly in the right lower quadrant, which was dull aching in nature, insidious in onset, gradually progressive in nature, but had no relation to food intake. There are no symptoms suggestive of radiation of pain. Patient gives history of consuming over-the-counter antacids and analgesics for the above complaints, but with minimum relief. He, however, developed complaints of black tarry stools with increased frequency of stools for about 15 days. Stools were predominantly small in quantity and were intermittently black tarry in nature for the last 15 days. It was painless and was not associated with hematochezia. He also gives history of weight loss, that is 8 kg over the last 3 months with the loss of appetite. He has no history of evening rise of temperature, mass per abdomen or obstipation constipation. No history of abdominal distension, jaundice or hematemesis. He had no history of reduced urine output, burning micturition. No history of cough with expectoration, restlessness, palpitation, syncope or altered sensorium. He has no history of similar complaints in the past. Not a known case of type 2 diabetes, thyroid, cardiac disorder, epilepsy or TB in the past. No history of surgeries in the past. He was diagnosed with generalized body swelling and was told to have a chronic kidney disease in 2015 and was started on tab enalapril. However, patient has taken the same tablet for around 2 months after that and has defaulted the same for the last 7 years. Patient consumes predominantly mixed diet, has no addictions, is a non-alcoholic and a non-smoker, has regular bowel and bladder habits before the symptom onset, and also has adequate sleep, which is unaffected by his present complaints. Family history, there is no history of GI or genitourinary malignancies in the family as per the pedigree chart, which is drawn for 3 generations. For the above complaints, he has not received any sort of treatment or has undergone any imaging at outside center. So summary of the history, 65-year-old male is a ECOG 1 manual laborer and a known case of CKD and hypertension on regular medication with no significant family or personal history. Presented with complaints of pain in right lower abdomen for 3 months, melena for 15 days and loose stools for 1 week. With previous history of anasarca present treated at an outside hospital. Stop here, okay, because you have to analyze and interpret the history. So it will be better because people might not register all the points when you move the slides then faster. You are given a summary of the history. So can you go slide by slide and we'll discuss and analyze why you asked this question and what was the interpretation. Okay, so just go to the second slide. So slide by slide you go and tell why you asked that and what was your thought process. Firstly, pain, patient, he's a 68-year-old male, known case of hypertension, complaints of repeat everything because you already told this. So, complaining of pain in the right lower quadrant. So, for any complaints of pain, we have to ask the site, onset, character of pain, radiation, or any referral of pain, any associated symptoms, intensity of pain, any exacerbating and relieving factors have to be asked. So that's why it's like this. Okay. So no symptoms of radiation of pain. So if radiation is present, then what? If radiation is absent, then what in the present situation? That is what I wanted to ask. Like, that is what we'd like to do. So if it is not there, it's fine. But suppose if it was there, any complaints of that, what will you interpret in this type of patient?
So because patient was complaining of a right lower quadrant pain, we wanted to know like any point of time he had periumbilical pain, which has now come to right.
Usually we use the term migration of. Okay.
Yes.
Suppose if it was there, what is the age of the patient?
68.
68-year-old patient, 3 months history, 3 months back, he says there was some history suggestive of migration. It was in the umbilical region. Now he shifted there on the right side. And he's having this persistent symptoms of dull aching pain. Okay. It was there, the intensity was moderate that time. Then over a period of time it subsided. And right now he's continuing to have this problem, this symptom for this last 3 weeks. So if you have something like that, how will you analyze it? Any of you can answer. Because you asked a question, is it not?
I'd also like to know whether the pain radiates to the groin or the genitals.
That's a separate picture. He is mentioning a pain which is suggestive of appendicitis typhotis. That is what he particularly do. So let us stick to that first.
I wanted to ask the radiation to rule out appendicitis. So,
a 68-year-old man, now it is 3 months history. If the history suggests appendicitis in the past 3 months back, and presently patient is complaining what you already mentioned there, what will you suspect? That's not asking. That's the question.
Initially only there will be a suspicion of like it will not be a classical appendix because age is not correlating.
No, that's not the answer. Can you answer? You'll go quick and fast so that we can move forward. Don't have much time.
Not sure.
See, the answer should be when you have a 60 plus or 50, 55 plus and the symptoms are persisting. It may not be a case of primary appendicitis. It may be a case of secondary appendicitis. What do you mean by that secondary appendicitis?
So some other sort of lesion which is causing obstruction.
Very clear. So what can be the other lesion in this patient?
So it could be a carcinomas like malignancy of cecum.
Very clear. That's what I'm asking. So the thought process has to be like that. So in the exam, if you mention like this, immediately if you are countered, you can't remain blank. Okay. So whenever you are taking the history, it is important. And if it was present, what it will be. If it is not present, I move. That is how it should be. That's why I asked you. You understood the point? Yes. Secondary appendicitis, because that is what it can happen. It's a rare thing, but once in a while it can happen. If it is present, then the thought process has to go there. Unlikely appendicitis will be there for 3 months. Okay, but there is a possibility 68-year-old man can have a malignancy in the right colon of cecum, particularly cecum, which can lead to that sort of situation. Okay, yeah.
This is for the all postgraduates. The purpose of history of presenting complaint is you have to somehow identify the organ involved or the system involved, and also to find out what's the pathology there. And if possible, you could find a etiology and in what stage of disease this person has presented to you. That you keep in mind, then these questions will be automatically answered. Okay, initially you thought 3 months ago, a single episode, you can still take it appendicitis, but it's a recurrent, as Sir said, we need to think beyond that. That means your organ is not that organ. Okay, so just move on to that.
Any other secondary cause you have in mind? Apart from CSC?
It could be a stricture secondary to ileocecal tuberculosis, which is deformed the appendiceal opening and caused secondary appendicitis.
That's very rare. Okay. Is it mentioned in books anywhere? Something like that? If you're telling something, it has to have some, I've not much read about it.
Cecal diverticulus. Yes, the diverticular.
Fine. Go to the next slide. Now here in this particularly, patient has got black tarry stools, with increased frequency of stools over 15 days. So black tarry stools means what? And increased frequency of stool means what?
Black tarry stools would mean bleeds, ongoing bleed in the GI tract.
Yes. Tarry means what?
The
TARRY means black. Everybody knows.
The consistency of the stool is
no. Tarry means it's like coal tar.
if you see in the liquid coal tar, the stool will exactly look like that. That means what? It is jet black in color, it is liquid, and it is sticky. These are the three properties of the coal tar. That is what the stool will be when a patient has got a bleed, which is significant in amount. Significant means at least 50 ml. Yeah, 50, 60 ml. Usually it will not be 50, 60, it will be 200, 300, 500, that sort of thing. And that is why it is producing two symptoms. One is the bleeding is producing these starry stools. And because the patient has got a bleed, ongoing or continuing or whatever the thing is there, that is actually increasing the frequency of the stool. Because liquid stool, it will be hastened to the GI tract. Because the transit time is faster, that is what actually leads to the increased frequency of stool. It's not exactly diarrhea. Because of bleed, it might be happening. Okay, that is what we have to presume. We had small quantity liquid stools which are interpreted black. That is what correlates with the first line what you have told. Painless, not associated with hematochezia, that's fine. So you are not expecting. So where do you think in a patient with right leg fossa pain, that's what he said, right lower quadrant pain and a bleed, what will you suspect? You can't go to right leg fossa mass straight away. Okay, because right now we are in the history. So we have these two positive findings in the patient, correlate and tell 1, 2, 3, at least 3 pathologies which can lead to this.
One is malignancy of right colon can present as melena.
Malignancy of the right colon classically does not present like this. What is the classical presentation as far as bleeding of right colon is present? What is described in books? It presents with what?
Weight loss.
No, we are talking of bleeding. Listen to the questions very carefully in the examination. Okay. I'm not asking you to enumerate the symptoms of right leg fossa mass. The question is, when it comes to bleeding and a patient has got a suspected right leg fossa mass due to right colon malignancy, what sort of bleeding it commonly presents with according to the textbooks? I'm not talking of journals also. Many of you can answer it. Occult bleeding. Occult bleeding leading to anemia. So occult bleeding is actually manifestation. The symptom is anemia. Anemia means the patient will have that breathlessness and all the easy fatigability and all that thing. It's not common finding, but once in a while, if it's a proliferative type of mass, it can produce bleeding, and it may produce hematochezia plus melena, sometimes melena. Why I said sometimes melena?
Because large bowel bleed usually doesn't cause melena.
Not exactly. So only you said it causes, and now you're saying it doesn't cause. You're giving contradictory statements. You only gave the cause, no? The first cause you mentioned is a tumor in the right colon, and now you're saying it is not. I'm asking, I said commonly only melena is little rare. Why? You know the reason, no? Reason is the transit time. Okay, from the colon to reach the anal canal, okay, it is not much. So there is a biochemical reaction involved with black tarry stool. So that might not happen. That is why usually small bowel bleeds will present with melena. Here you might have melena plus hematochezia. But still it can happen. Only tarry stools can also present. The bleeding is it stays there and it is occurring not as brisk as it should be, something like that. As I told, as such it is uncommon, but this is a little uncommon finding which is happening. And so you have to tell me where it can happen more often. No? Angiodysplasia. Angiodysplasia producing pain is not much of it. Usually painless bleeding.
Diverticulitis.
Diverticulitis is common in the sigmoid coils. Okay, again, right, why it will produce bleeding? It will produce hematochezia. Think of small bowel. Again, as I said, you are fixed. This is right leg fossa mass is printed in the schedule. You are only thinking of colon. I said patient has got a right lower quadrant pain and bleeding. Only these two symptoms I have given you. With that, you have to think. If melena is there, you have to think of small bowel. Tell me at least 1 or 2 conditions small bowel which can lead to bleeding. Huh?
Inflammatory bowel disease.
Inflammatory bowel disease, common ulcerative colitis happens in colon. Actually, broad thinking is the key when you are presenting into a case presentation.
Bleeding from Meckel's.
Okay.
Diverticular.
All right. Meckel's can produce off and on pain, is it not? And it can produce bleeding also. Okay, accepted. Anything else? It can present with the right leg fossa mass also.
IOC tuberculosis.
Physical hyperplastic tuberculosis. The intermediate word you have missed out. It's a plastic type of tuberculosis. Plastic means you understand desmoplastic reaction. How it will produce bleeding? The ulcerative type can. That is not hyperplastic. That will not produce a mass. Just I gave you a can produce a mass. Just nowadays we are seeing patients of this kind, is it not? So think of that. That can produce bleeding. That can produce off and on pain. There are some more conditions. Okay, I have just listed two. There will be so many others. Small bowel tumor cannot have. What are the common small bowel tumors, you know? Which can produce bleeding and which can produce this pain. Lymphoma. Is it? Small bowel tumors. Four common types of small bowel tumors are there. One is adenocarcinoma. Number two, lymphoma. Number three is GIST. Number four is carcinoid. Okay, these are the four. Carcinoid might not produce large masses, but at least adenocarcinoma can produce, the lymphoma can produce. Lymphoma has a tendency for bleed. Can happen, GIST has a tendency for bleed. So the thought process, keep it like. The last point what you mentioned, loss of weight. How does it help you? It points towards a malignant deterrence, weight loss. Possibility, is it not? 3 months, 8 kgs is a reasonable loss of weight. So there's a possibility that 68-year-old man has come to you and it is complaining of right leg, slight lower quadrant pain. We don't use the word right leg fossa in the history. Okay. Patient can test the quadrant and the patient has got this sort of pain and loss of weight. So there is a possibility of a malignancy which cannot do that. It's a very important pointer towards malignancy. And your earlier statements are pointed towards the malignancy is there, which is also producing bleeding. Okay, so that is how you zero down from step by step, from slide by slide. Next slide. Yes. Next slide. There any other history you are missing here? Is there anything which can get complicated? Right iliac column. Iliac fossa mass. History vomiting, abdominal distension. Right iliac fossa mass can get affected. There was other history here of the patient. Anything which is missing here? What were many symptoms? Why do you ask about reduced urine outcome administration? The known case of chronic kidney disease, so suspecting urosepsis. Okay. Are you missing anything there with regard to urinary symptoms? There is a right iliac fossa mass, a complication which can cause. So it can cause ureteric obstruction and actually you can have colicky pain also relating to the groin and recurrent UTIs can be there because of the obstruction causing achievement. And anything else? What other structures can compress in the retrofit? Then compression of the veins and of the lower limb, right lower limb, and can cause edema of the unilateral edema, lower limb swelling. So symptoms are just for DVT. Unilateral leg swelling. Point number 2, I want to ask. The bulleted point number 2. No history of abdominal distension for obstruction. Obstructions. Obstruction. Okay. Anything else? Ascites. Reflected in the abdomen. Okay, so if it is reflected in the abdomen, again, if you are thinking in terms of malignancy, because the previous slide you have shown, the patient has got a significant loss of weight. So that's a very strong pointer, I agree. If it is documented properly by the patient, it's a strong indicator for malignancy. Age is in favor of malignancy, and if there is abdominal distension without any symptoms of obstruction, then you have to think in terms of refluid. That means a dissemination of the disease. So it's an important point in history if the patient tells. Jaundice is also the same. Hematomesis, I did not understand. If melena was there, so you wanted to rule out if there has been any history of upper GI bleeds. Okay, but the pain is a little bit on the lower side of it. Understood. You have to ask because patient has got melena. What is the dictum that is used for Melina? Melina, as far as JIB is concerned.
Suggest a site of bleed proximal to ligament of treats.
No, whenever a patient has melena and patient comes to the hospital, there is a book dictum. Dictum is, you understand, DICTUS.
Yes.
That is the rule of thumb.
Place right tube.
No.
Most common cause of lower GI is
In the upper GI. The most common cause of the lower GI bleed, it's a contradictory statement, lies in the upper GI. So even if the patient comes with melena, never fail to do an upper GI scope. Whatever the other symptoms, irrespective of that, unless and until on palpation you find a hard tumorous mass and you feel that's the cause of bleed, but otherwise safer to do a 5-minute upper GI scopy to rule out conditions rather than subject the patient to extensive investigations for lower GI. Okay, so that is why it is understandable for you to ask whether the patient has got a hematomesis. Okay, fine. So other questions were asked by Dr. Rajkumar to you about the reduced urine output and cough and all those things. Why all these things, syncopal attacks and sensorium and all that?
Syncopal palpitation, we wanted to rule out any symptomatic anemias. Because patient has been having melena.
Okay, understood. Fine. That's a good point what you have raised and should be asked. Yes, patient has got melena for last 15 days. So there's a possibility patient must be having it. There's a high possibility of low hemoglobin. Proceed. You have to ask. Continue. Fine. Next.
Is he on aspirin?
No, sir, it's not on any medication.
It's a CKD, CAD.
Actually, a patient did not know, sir. Like he just told us that he had generalized body swelling. They gave him some tablet, told him to take it till the swelling comes down. And that's exactly what he has done. Like 2 months, swelling came down. So he stopped the medication.
So he stopped. You are not sure what he has taken.
No, enalapril, they had this
Just another
strips they had.
In 2015, he's just taking single drop.
Yes, sir. Only for 2 months he has taken. After that, he has not taken.
Continue. So what is the impression on this?
Based on history, my first differential would be a malignant right colonic mass.
Why? See, patient has got 2 predominant symptoms. That's what you said. 3 we can say. That third one is a little subjective. As far as the pain is concerned, dull aching pain, we don't know exactly right lower quadrant or not. Patient is telling them. But definitely you said loss of weight is there and patient has melena. Isn't it? Those things are fixed. So based on that, how you are saying right fossa, right tumor colon. We said no, it's very rare to have a melena sort of presentation. Weight loss is an indicator of any type of malignancy. So why you are targeting that based on the history?
Patient has luminal symptoms like melena with loose stools. Small quantity loose stools, so suggests a large bowel pathology.
I'm not very sure. Again, as I said, if you give an indication that probably you know the diagnosis. Never ever try to zero down on two specific diagnosis when the history is not suggestive. I told you these 2 symptoms are there. You have to correlate and 3-4 conditions at least. If you say only one becomes a problem. If the patient would have said there is a mass in the right lower quadrant, then there's a high possibility, then I agree. But there's no mass, according to the patient.
Pain,
patient is not complaining.
Because of the pain, we localized it to right animals.
But again, chronic okay, any other conditions?
Second differential was
no, there's nothing like second differential. One is a diagnosis, then you have a diagnosis of the differential of the diagnosis. That's why it's called differential diagnosis.
differential was ileocecal tuberculosis.
Because now we said it is plastic type of tuberculosis very early. It's all, you have to be a little bit, you are presenting a case which is prepared. No? So how you can now think of conditions? After history, they'll always give a break to ask you questions. You have a pre-planned this thing, 1, 2, 3, 4, 5, I'd like to think of. See, after history, we'll have more number of possibilities in mind. With examination, they'll narrow down further. With investigation, they'll narrow down further to maybe one or two possibilities. And then you treat. But you have the chronology in there. Any of you can answer.
A malignancy from the small bowel also, like GIST or adenocarcinoma, but I'd like to put cecal malignancy, especially because it is more common. And the small bowel malignancy is much, much rare.
No, but in cecal malignancy, melena is not very common.
Yes.
And you have one symptom which is common. Weight loss can be there with anything. Nothing very particular. So I think you should keep it little broad. I think what is my suggestion, or my colleagues are like to find something.
Any other difference? Benign also curative? Any benign?
Tiger colitis.
Keep your open mind. That's what sir is saying. Don't get fixed on the already what you know. At this point, what information you have, you try to have a give a diagnosis.
Bone infestation. What is the commonest cause of, since you're taken right leg fossa mass case, what is the commonest cause of RIF mass? What you said, RIF restored? In a hospital itself, commonest cause. Any hospital does the commonest cause, appendicular mass. Appendicular mass. So why not that as the first diagnosis? 3 months history. 3 months history. Then not the history of mass in this patient. Yes. So why not that? History-wise, there's no mass. So it must have become very less. Sometimes it will take longer for the mass to disappear. Could be secondary appendicitis causing mass. My question is, when I say appendicular mass means it is primary. Unlikely to be persistent for 3 months. Unlikely to be persistent for 3 months. The symptoms are unlikely. And weight loss. 8 kgs weight loss. That is significant. With that, you should counter. Unlikely to be there. Go to examination.
Coming to the physical examination, patient was examined in well-lit after adequate exposure, after taking the adequate verbal consent. He was comfortable at rest, conscious, oriented to time, place, and person. He had a weight of 48 kgs, height 160 centimeter with a body mass index of 18.6 kg per meter square. Hydration was adequate. His performance status was ECOG1. Blood pressure was 130 by 80 millimeter of mercury measured in the right arm in supine position. Pulse rate was 88 per minute with normal rhythm, normal volume and character, regular rhythm. Respiratory rate was 20 per minute. Saturation was 98% in room air. Temperature was 98.3 degree Fahrenheit. Pallor was present. There is no icterus, cyanosis, clubbing, generalized lymphadenopathy or edema. On coming to the abdominal examination, abdomen appears flat, corresponding quadrants moved equally with respiration. There was mild fullness noted in the right iliac fossa. Umbilicus was central and inverted. No nodules or dilated veins or scars or sinuses over the abdomen. Bilateral flanks appeared free. Bilateral renal angles were free. External genitalia and hernial orifices were normal. No left supraclavicular fossa fullness was seen. This is a clinical image showing the abdomen. On palpation, abdomen is soft, non-tender, corresponding quadrants moved equally with respiration. There was a 5 into 8 centimeter well-defined globular mass palpable in the right iliac fossa with borders well made out. The medial border was around 10 centimeters from the midline, lateral border 15 centimeters from the midline. Superior border was 8 centimeters inferior to the costal margin in the midclavicular line. The inferior border was 16 centimeters inferior to the costal margin at the midclavicular line. It had a nodular surface. It was hard in consistency. However, it was not tender and it was unyielding to the palpating fingers. It was intraperitoneal
on straight leg raises, the mass was less prominent. There was side to side intrinsic mobility noted, although it was restricted. The umbilicus position was normal equidistant from the default process and pubic symphysis. There is no palpable organomegaly, no hepatosplenomegaly was noted. External genitalia and bilateral hernial orifices were normal. No palpable left supraclavicular nodes are present. On percussion, dull node was noted over the mass. Rest of the abdomen was tympanic on percussion. No free fluid noted. Liver span was 12.5 centimeter, extending from fifth intercostal space up to the costal margin. On auscultation, normal vowel sounds are heard. No audible blowing over the mass. Spine was normal, no deformity or no tenderness. On the right lower limb examination, there is no limitation of movements, no swelling. Peripheral pulses are normal. Rest of the systemic examination was unremarkable. Coming to digital rectal examination, perianal area was normal. The sphincter tone was normal. No blemish of nodules. No mucosal irregularities noted. And there is a normal store staining of the gloved fingers.
No need for that. Okay, now you go back. The most important slide on your examination is the palpation. Okay. So with this now, tell the most probable diagnosis and what points you have picked up from this slide, which will give you a clue of the diagnosis, and what are the points which you, one or 2 points I thought were a little vague and odd, which you should not mention. Just answer those 3 questions.
Since it is a hard mass with a nodular surface, I would consider malignant mass.
No. Oh, so you should not use the word globular. Globular mass, okay, it's like we use it for gallbladder mass when you have a distended palpable gallbladder. So it is contradictory, a hard nodular mass which is globular. You understand? So that's why we don't use that. And while reading out, you said no splenomegaly. Although it is written very clearly there, no palpable liver or spleen. That is how it should be read. Yes, but I don't know how you imaginary you read. Why that is wrong to say that there is no splenomegaly?
Because for clinically appreciate the splenomegaly.
You don't know answer. Then why you said it? Okay, you only told no hepatosplenomegaly. Better not to use that word. You should always say the liver and spleen is not palpable. Okay, that is what you can do on clinical examination. So from this, what you have mentioned, this is your important slide. What do you think is the possibility? A little short of time.
I think of malignancy of the cecum or the
based on
the location of the mass, as well as the surface
consistency. Okay. What is the other point which is little bit not very much fitting into this particular thing is the mobility. Okay, I expect that when you have 5, 6, you have written 8 centimeters, is it not one of the dimensions? It is still mobile in one of the directions, I saw. Is it not transferring the mobile direction?
Side to side mobility.
Yeah, side to side, it was there you mentioned. So there is a possibility. There is a possibility that it could be a trait of mobility rather than actual mobility. Okay. Yes. So the thing is, and I don't think anywhere you have written it moves with respiration. I hope you have not written that.
No, not.
Why you should not write that?
It's a lower abdominal.
Yeah, your lower abdominal, and it is you can reach all. You have said no, it is all the borders are well made out.
Yes.
So you can reach the superior border, and there must be a gap between that and the costal margin. So you should never make that mistake of mentioning that. Have you mentioned that it is whether it's palpable bimanually or not?
So palatability.
Palatability is not used when you have a mass palpable through the anterabdominal wall. It is only used when the mass is palpable through the renal angle. This is palpable through the anterabdominal wall. So that is out. So by manual palpation means the one hand will go into the renal angle and the other hand on the top. When you have a mass which is large in size, it is better to add that finding. Okay, it's not there because it must be extending into the right lumbar region. 8 centimeter mass has to extend there. So you should do that test additionally. It will not contribute much to diagnosis, but just as a finding, some of the examiners might want it and need it. Okay. So with this, there is a possibility that it could be carcinoma of the right colon. Okay. Any other possibility?
Could be a
Malignancy
from
of
the
the
appendix.
colon. Okay, malignancy of the colon.
Could be a malignancy arising
That
from the
is
appendix.
very rare. That's all. Any other thing?
Could be a gastrointestinal stromal tumor from the terminal ileum.
Yeah, possibility is there. You cannot absolutely rule out. But as you said, now here the frequency of thing happens. Okay, small bowel tumors are rare. So compared to that, large bowel tumors are more often. So we like to put large bowel tumor, what you said. But a rare possibility of small bowel cannot be ruled out. It cannot be ruled out. Is it not? And you have certain mobilities there. Can it be some lymph nodal mass or something like that in the right leg person? Lymph nodal mass. Counter to my question immediately. This question you can do it.
Doesn't explain the melena.
Very good. So with the melena, high possibility of luminal mass. You should say that. Luminal means arising from the GI tract lumen. So GI tract lumen, one is malignancy. Okay. It can be GIST, it can be this. This has a propensity for bleeding. Okay. So GIST can occur in the colon also. Okay. So that is what is the possibility. But hard nodular typical thing, you have to consider carcinoma of colon as the first diagnosis. This might be the second, third might be the lymphoma. Lymphoma cannot be ruled out. Absolutely. Small, large bowel first, remote possibility of small bowel. That is how we will proceed. Okay. Investigations.
First, I'd like to do a ultrasound of the abdomen as an extension of my clinical examination.
To see what?
One is to see free fluid abdomen, to see the lymph nodes.
No, always investigation targeting the diagnosis first.
To see the
extent of the disease.
To see the mass,
Origin of the mass,
Origin
if it
of
is
the
possible.
mass.
Okay.
Then the regional lymph nodes.
Okay.
If you can visualize whether it has lost
Lymph nodes are not very clearly seen on ultrasound. So you should talk about the things which are clearly seen on ultrasound. One is the origin.
To look for any
Liver secondaries. Then
liver secondaries. Then free fluid abdomen.
Then go to lymph nodes. And what is the fifth thing you'll see? Intraperitoneal deposits. These are 5 things we look for any GI malignancy in the abdomen for. This. You have the report?
Actually, ultrasound has not been done, sir.
Not been. Okay. Fine. So let's say that ultrasound shows that there is a mass lesion arising from what you're expecting from the colon region. Okay, that area it is there. And liver is fine and no free fluid and the nodes, I mean some nodes, small nodes are visible. No intraperitoneal deposits. Next.
Then I'd like to do a hemogram to look for the hemoglobin levels since patient was having a.
First, you have to confirm.
Confirm the diagnosis with a CG.
Yeah, it can be argued both ways. You can say that I am using the hemogram in this patient for the diagnosis because the patient is bleeding. But ideally, what Dr. Rajkumar is saying that investigations will give you a direct the possibility of a diagnosis. Hemogram might not give you even if it is anemia. Is it not?
Just since the patient had melena, to look for the hemoglobin levels and also RFT before the contrast injections because in known case of CKD,
it's all right. What you said is correct. Absolutely, in this further patient, it's important. RFT you had not mentioned. You would have agreed for that. So you are asking for hemoglobin. Do you have the reports?
Yes. Hemoglobin was 9.9 in this patient.
Was the patient transfused?
No, not transfused.
What does it indicate? Melena is also there. Hemoglobin is 9, 10, close to 10.
On examination, patient didn't have melena, so he was giving only history of melena. When we examine patient normal stool, so maybe it's just intermittent melena rather than continuous bleed. So
fine. The free of hemoglobin, I mean, bleed hemoglobin also might be higher in this patient. It is also possible. It might be 14, 13, 14, never know. Fine. Then rest of things are all right. You're not shown the other investigation.
Yes.
No, this urea creatinine.
Urea is
creatinine is 2.5.
Creatinine is 2.5, indicating.
So what will you do next?
Then I would like to take a contrast enhanced CT of.
Will they do that?
Like we have to calculate creatinine clearance and
creatinine clearance. How much will it be? 2.5 creatinine. It will be less than 15. 1.5.
Yes.
GFR. eGFR. Is it not?
Yes.
Then
Are you doing with that?
Should be pre-hydration and post-hydration here being done.
It is done.
It is done.
But the risk is there, you have to explain to the patient, is it not?
Yes.
Because the creatinine is significantly higher. 2.5 is quite high. What is the weight of the patient?
48 kgs.
Why did I ask that?
The contrast injection is based on the weight of the patient.
No, the eGFR is calculated based on the weight and height. 48-year-old man, 2.5 creatinine is very high. It is 100 kgs and if it is 2.5, relatively it is less. The time is up, then 2 minutes to finish.
Yeah, this is the contrast in CT, sir. This is the arterial phase showing a large heterogeneously enhancing mass with the central non-enhancing area suggestive of necrosis in the right iliac fossa region. The terminal ileum cecum could not be made out separately. We can see here it is having large fragments with the right psoas muscle. Also, it is abutting the right external iliac as well as internal iliac vessels. Then anteriorly, it has large fragments with some of the small bowel loops.
Fine. What next?
There are no liver metastasis and no free fluid was noted in the CT. And then there are few subcentimetric lymph nodes are noted in the adjacent mesentery. Other than that, no other significant findings are there.
Okay.
Next, I would like, since based on CT, we are suspecting a malignancy of the cecum. I would like to do a full-length colonoscopy.
Done.
Report. Is it looking like cecum on the terminal area?
Terminal ileum and cecum both are like involved, sir, in the CT. Colonoscopy has been done, sir. It is showing an
rated one line, the diagnosis.
It's an ulceral proliferative lesion in the cecum.
The right colon. The right colon.
Yes, sir.
The large mass. Is it not? Yes. Biopsy?
Biopsy has come as mucinous adenocarcinoma.
Mucin secreting adenocarcinoma. What next?
Only this much investigations has been done.
No, what you'd like to do?
Next, I would like to pre-op, since it is malignancy from the cecum, I would like to prepare him for upfront surgery.
You're not mentioned, you mentioned CA, so
CA has been done. CA is 900 and
so all favor
75.
It's fine.
Yes.
So you like, do you think that based on CT is operable?
Based on CT, it's like locally advanced.
Patient is not obstructed. Any role for neoadjuvant?
Patient having CKD comorbidities are there, so you cannot tolerate the neoadjuvant.
And bleeding also is there.
Bleeding also.
But it has to be balanced and see. The patient is good, compliant, and you feel that the nephrologist says can be given, thought of, borderline, can be considered. Large mass, no? Is it not? So when such a large mass is there to have a good, I don't know whether R0 will be possible, but if to have a good R0, if it is possible, that is a role. You have to discuss a tumor load. MDT it has to discuss and then plan further. So you have two options. Either go that route, if it is possible, otherwise go for upfront. Upfront, what will you do? Before upfront, anything else will you do based on the CT finding? You said the ureter and all was close by.
Yes, sir. It was the abutting, but it is not infiltrating the.
So anything else you like to do? First of all, you should see the kidney function opposite side, and then you can put a stent. Is it not? You feel it is very close, and there will be a possibility of difficulty in identifying. Controversial. Some people feel that with the stent there could be difficulty, but that is one of the options. Surgery.
So there will be right hemicolectomy.
Radical you should use.
Radical
I think the mass is too large, and colonoscopically, if it is coming very close to ascending colon, you might have to do a right extended radical hemicolectomy. Okay, and role of post-op therapy.
Based on the post-op histopathology, already CT wise it is looking like T4, so definitely the patient will need post-op adjuvant chemotherapy.
Last question.
prognosis for this patient? And how do you decide? What is the most important point deciding the prognosis in whatever you have to, what we have to?
I think R0 resection.
No, the question is, what is the prognosis and what is the most important risk factor for that prognosis in this patient? I'll answer that before I'll ask my colleagues to ask question. It is a mucin secreting adenocarcinoma. That is why it is so large in size. That is why 3 months it has become, you're saying 8 centimeters, it could be 10 centimeters. Okay, CT size is there.
CT wise, it is 7 cross 12 cross.
Say 7 cross 12, no, is it not?
So 7 cross 10 cross 6 centimeters.
Okay, the largest diameter is 10 centimeters. Very large mass, 3 months duration. Patient relatively asymptomatic except for bleeding. So that is because of mucin secreting adenocarcinoma. The bad prognostic factor, when you talk to the patient, to counsel the patient. Okay. You people want to ask us any question before you want to leave? We're short of time. That you have any questions? Will you close? No. You asked you so many. You have a right to ask. Okay, fine. Otherwise, good presentation. Overall, you have covered it well. With some final points which you have missed out, you should read from it. Okay.
Thank you, sirs, for that enlightening session. I now kindly request the examiners to present certificates of presentation to Dr. Vikhyat. And Dr. Veda Prakash. I now request Professor Dr. Vikram Kade to felicitate our examiner, Dr. Asayas Bosco. Thank you, sirs. Next on, we have paper presentation by the selected candidates from the poster presentation conducted in the afternoon. All the presenters kindly note that the presentation shall be for 7 minutes, followed by 3 minutes for discussion. I now request the judges for the session, Dr. Rajan KV, Dr. Uday Shamrao Kumar, Dr. Nandkishore Maroju, and Dr. Suresh Kumar S. to move on to the dais to be examiners for this session.
Let's start. Please call the candidate.
First up on stage, we have Dr. Likita Subhash, postgraduate resident in JIPMER, Puducherry, in Department of General Surgery. Good morning, everyone. I'm Dr. Nikita, Junior Resident, final year from Department of General Surgery in JIPMER. I'm presenting a paper on comparison of adapted enhanced recovery after surgery pathway versus standard care in patients undergoing emergency abdominal surgery, a randomized control trial. Emergency abdominal surgeries comprise the lion's share of emergency. There are limited studies demonstrating the role of ERAS in emergencies. Most of the trials are retrospective observational studies, of which only one trial was compared overall emergency abdominal surgery. ERAS protocols are well established in elective surgeries, but when it comes to emergencies, because of the higher morbidity and mortality associated with emergencies, we don't tend to use newer protocols. So we have used ERAS in an adaptive form. It has a preoperative components such as patient education and counseling, non-opioid multimodal analgesia, NG decompression, IV antibiotics, and PPI is given. And in intraoperative phase, non-opioid multimodal analgesia was given, along with the lumbar epidural catheter whenever there were no contraindications for epidural. And goal-directed fluid therapy was used. IV dexamethasone 4 milligrams start was given prior to the start of surgery, and short-acting opioids or anesthetic agents were used. Intra-normal hernia was maintained using warmers. And in post-operative phase, IV antibiotics and PPIs were converted to oral as soon as the start of enteral disease. And IV metoclopramide was given on post-op day 0 and 1. Non-opioid multimodal analgesia, lumbar epidural with bupivacaine infusion was continued for 1 day and then it was converted to NSAIDs and acetaminophen. And brain removal, NG tube was removed when the output was less than 100 ml over 24 hours. And abdominal drain when it was less than 300 ml over 24 hours. And urinary catheter was removed once the urine output was adequate for 24 hours. Early ambulation was practiced, and resumption of orals was done after resolution of ideas. Here, resolution of ideas was considered as passage of first platus. This study was started with an aim to determine the safety, feasibility, and efficacy of adapted ERAS protocol in patients undergoing emergency abdominal surgery, with the primary objective to compare the length of hospitalization between the two groups. And secondary objective was to compare the functional recovery parameters, such as the time to drain removal, time to start of first liquid diet and solid diet, and time to first ambulation and removal of urinary catheter. 30-day morbidity in terms of post-operative complications such as post-operative nausea and vomiting, pulmonary complications, urinary tract infections were compared, and any need for reoperation was also compared between the two groups. 30-day mortality and readmissions were also compared. Coming to the study design, it was a single-centered open-label parallel arm superiority randomized control trial conducted from June 2021 to December 2022 after obtaining approval from the PRI. And the inclusion criteria was all consecutive patients undergoing emergency abdominal surgery. And exclusion criteria was refractory shock, coagulopathy, or patients already on vasopressors or ventilator support, age less than 18 years, ASA class 4E, and polytrauma, and pregnant patients. The sample size was calculated using the previous study, which is given as reference below, with length of hospitalization as a minimum of difference of 2 days, and level of significance 5%, and power being 90% with error of 10%. The sample size was calculated to be 50 in each group, and the total sample size was 100. Eligible patients were randomized in 1:1 ratio. And allocation concealment was done using the SMOOTH technique. Statistical analysis was done with Stata V version 17 software. And here's the consort flow diagram of my study. It is 130 patients were assessed for eligibility, of which 30 patients were excluded. 5 patients had declined to participate and then with the consent. And of the 25 patients, rest 25 patients, they were excluded based on the exclusion criteria. Age less than 18 years, there were 2 patients, and ASA class 40 and septic shock were 17 patients, and there were 6 patients who had a polytrauma. And the remaining 100 patients were randomized into two groups. There is the standard care group and the adapted ERAS group. A sequence was generated prior to the start of study with random log software, and using the snooze technique, they were allotted at the just before the surgery into standard care group and adapted ERAS group. In the standard care group, 47 patients had received the intervention, and 3 patients did not receive complete intervention because 2 patients had one AMA and there was one mortality within 48 hours of inclusion after surgery. And adapted ERAS group, there were a total of 50 patients, and of which 49 patients had received intervention. And only 1 patient did not receive intervention because of post-op mortality within 48 hours. And there was no loss to follow in either of the groups. And the total of 47 patients were analyzed in standard care group, and 49 patients in the adapted ERAS group. Coming to the results, the first pie chart here shows the distribution of cases between the standard care group and the adapted ERAS group. We found that there were majority of the cases were gastric, small bowel, as indicated by the blue color gastric cases, followed by the small bowel pathologies, which is shown by the orange color, and the gray color shows large bowel pathology. They constituted the majority of the cases. And coming to my primary objective, the length of hospitalization in the adapted ERAS group was shorter by 6 days. As it can be seen in the table on the right-hand side, the median ICUR length of hospitalization was 15 days in the standard care group and 10 days in the adapted ERAS group. The difference was statistically significant. The p-value is less than 0.001. And the other functional parameters such as removal of nasogastric tube, time to first stool, first liquid diet, solid diet, time to removal of urinary catheter, and removal of brain were all significant, and they were 1 day earlier in the adapted ERAS group when compared to the standard care group.
Dr. Likita, time is up. Go to the conclusion, please.
So, conclusion, adapted ERAS pathways are, I would like to conclude saying that adapted ERAS pathways are feasible, efficacious, and can be safely applied in any emergency abdominal surgery with a significantly reduced length of hospitalization, early functional recovery, and better functional outcomes with reduced post-operative pulmonary complications and no associated increase in rates of other post-operative complications or 30-day mortality and morbidity. Hence, adapted ERAS pathways might be a way forward in achieving better patient outcomes, even in the emergency setting.
What are the difficulties you found during this cases?
Firstly, sir, in preoperative period, there is very less time to recruit the patient and as well as for optimization. So we had kept very limited in preoperative phase. We have just done counseling for the patient and then avoided opioid analgesics. And
My question is, what are the difficulties other than the standard care of treatment? Providing this ERAS, what were the difficulties you encountered when conducting these studies? My question.
Then one more difficulty was convincing the anesthesia department to place the epidural, as they were hesitant to place epidurals in emergent setting, and because it increases the risk of complications and they might have coagulopathies. But as we had become, initially it was difficult to convince, but later on I had a good number of patients for whom epidural was also being.
Yeah, so good presentation. I just want you to highlight to me the differences between the two groups. If you show the same and adapted ERAS pathway, and what is it that is different in this group and the standard treatment apart from lumbar epidural?
Apart from lumbar epidural, sir, in intraoperative period, to alleviate the stress response, we are giving dexamethasone.
So the other group did not get dexa.
No, sir.
Okay, yes, then.
And next, we had made sure that everyone had a warmer during surgery.
So did you deny a warmer? Did you deny a warmer to the standard treatment group? Kind of. But that is again standard treatment, no?
Yes.
Because if you have a patient coming in shop, you have a warmer available, you should use it for both the groups. That is standard treatment. Anything else is different?
And other than that, we are given IV metoclopramide on post of day 0 and 1. That is
For all the patients.
for adaptive egress pathway. To shorten the duration of post-operative IVs.
Because if you see patient education counseling, that's again standard for every patient undergoing surgery, isn't it? So you avoided opioids and you gave lumbar epidural, you gave DEXA and you gave metoclopramide. With this, you found that there is a difference in outcomes, especially in terms of passage of calculations. Yeah.
Yes, sir. And we also encouraged early ambulation that
So my question is, because you didn't come to the aspect of limitations, is it that you are looking at them with a little bit of a special care? You think that would have influenced your results? Okay, you don't have to answer that. Yeah, okay, thank you.
Thank you, Dr. Likita. For the next presentation, we have Dr. Rajalakshmi MR, Junior Resident, Department of Surgery, JIPMER.
Good evening, everyone. I am Dr. Rajalakshmi, Secretary Junior Resident from the Department of Surgery, JIPMER, and I am here to present my paper titled Diagnostic Utility of Neutrophil to Lymphocyte Ratio, Platelet to Lymphocyte Ratio, and Monocyte to Lymphocyte Ratio in the early diagnosis of gastric cancer. It's an analytical cross-sectional study. So, as we all know, gastric cancer is one of the most common malignancies globally as well as in India, affecting around 1 million patients per year, and 1 out of 13 patients succumb to the disease. Globally, it's the 5th most common malignancy and the 4th most aggressive cancer, and in India, it's the 2nd most common cause of cancer-related death. So let's have a quick look into the pathophysiology. There's steady evidence which says that chronic local inflammation precedes gastric cancer. This could be chronic atrophic gastritis, gastric polyps, intestinal metaplasia, or dysplasia. This, in turn, triggers systemic inflammatory response and causes the release of T cells, chemokines, and prostaglandins. This, in turn, further causes the proliferation of leukocytes, predominantly neutrophils and monocytes, and also platelets. So let's keep this in mind and move ahead. So now comes the question, what is the need for new tests? We already have an upper GI endoscopy, which is a gold standard, and it also has a very high sensitivity and specificity. But the issue with upper GI endoscopy is that it's expensive, it's invasive, it requires a lot of technical expertise, and it's not readily available in all parts of the country. So in a low resource setting like India, blood investigations could come handy. These are inexpensive, these are quantitative, it's technically easy, and it's less invasive compared to upper GI endoscopy. And most importantly, this is already a part of routine clinical evaluation, not just for malignancy patients, but in general for all patients. So aim of the study was to investigate the individual as well as combined diagnostic ability of NLR, PLR, and MLR among patients with gastric cancer. This was an analytical prospective cross-sectional study conducted at JIPMER over a period of 2 years. Participants were patients who were referred from OPD to endoscopy with symptoms suggestive of gastritis or gastric cancer. Participants with known gastric cancer for whom treatment has been initiated, participants with other malignancies, acute GI infections, and acute peptic ulcer disease, active peptic ulcer disease on PPH for the past 2 weeks were excluded from the study. So for the participants, a predetermined proforma was given to record the socio-demographic variables and history risk factors. For them, a 5 ml peripheral venous blood sample was taken and complete blood count was sent from the sample. Based on their endoscopy and histopathologic reports later, they were classified into 3 groups: gastric cancer, precancerous, and control groups. These are 3 arms of the study. Variables were divided into 2, whichever you have collected. Independent variables were socio-demographic variables, lifestyle parameters, BMI, family history of gastric cancer, and presence and stage of the disease, and outcome variables were the ratios in consideration. Primary outcome of the study was to find out the diagnostic accuracy of these markers in patients with gastric cancer and to compare it with that of precancerous and control groups. Secondary outcome was to find out correlation of markers with the burden of the disease, that is stage of the disease, nodal involvement, and metastasis. Sample size based on previous studies was calculated to be 228, that is 76 in each arm, keeping a confidence limit of 95%, a precision of 20%, and a dropout rate, non-response rate of 20%. Variables which are found to be significant in univariate analysis were further taken up for multivariate regression. I'll explain this later. As I've already said, confidence interval is kept to be 95% and a p-value of less than 0.05 is kept to be significant. Variables are divided into two types, continuous and categorical. Continuous variables were further divided into two, normal and non-normal. The normal variables, mean with standard deviation of the non-normal, median with inequality range was calculated, and for categorical variables, frequencies and proportion is calculated. So the primary outcome, that is diagnostic accuracy of these markers, were calculated using the receiver operated characteristic curve, and an area under the curve of more than 70%, this is arbitrary, was kept as significant, and those were taken for further analysis. So demographic parameters, coming to the results, mean age was found to be around 55%. Gender, as already proven, male patients were found to have the disease, found to be affected with the disease more than females. Rest of the parameters were not found to be significant. This is the ROC curve which we use to find out the cutoff value as well as to find out the area under the curve. Keeping the highest possible sensitivity and specificity, the cutoff values for the markers were found to be 2.23, 147, and 0.26 respectively. So primary outcome, which is to find out the association of markers with the disease. P1 compares gastric cancer and pre-cancer group, and P2 compares gastric cancer and control groups. As you can see, the markers are found to be significantly associated, and they could differentiate patients with gastric cancer not just from the control groups but also from the pre-cancer groups, and an overall p-value was also found to be significant. So since the markers were found to be significant individually, we proceeded with making models. Model 1 is a scenario where 1 out of 3 markers were positive. Model 2 is where 2 out of the 3 markers were positive, and model 3 is where all the 3 markers were found to be positive. So we found that in both the two cases, that is gastric cancer versus controls, as well as in gastric cancer and pre-malignant groups, area under the curve was found to be significant, that is around 65 to 70. But in a scenario where 2 out of the 3 were positive, gave us the highest area under the curve. That is, if at all we are considering these markers for diagnosis, we could keep a combination of 2 out of 3 as a benchmark. Secondary outcome, to find out the association of marker with the burden of the disease, values were not found to be statistically significant, but we found that there was an increase in numerical value of the parameters, increase in burden of the disease, and highest stage of the malignancy. So, strengths of the study was that, as I've already mentioned, these are part of a routine clinical evaluation. And compared to previous studies, which have only seen NLR and PLR, we have also included MLR, and this was also found to be statistically significant. Limitation is that this was a single center study, so in the future, large and multicentric studies could yield better results. So in conclusion, NLR, PLR, and MLR can be used as diagnostic biomarkers individually as well as in combination with good sensitivity and specificity. Thank you.
Thank you, Dr. Can you go to your inclusion criteria? How you selected the inclusion? You said patient with known gastric cancer excluded. What are the inclusion criteria?
Inclusion criteria was patients who were referred from OPD for endoscopy with symptoms, suspicious symptoms like dyspepsia or mass per abdomen.
So the blood samples were taken before the endoscopy or after the endoscopy?
Before the endoscopy, sir. In the endoscopy room itself on the same day. On the same day as endoscopy.
Okay. So since your introduction or aim says stated that it can be a diagnostic marker for gastric cancer, right? So, like, do you really think the endoscopy it can supplement or it can replace endoscopy like that? No, how it is going to add up to the diagnostic value?
This is not a surrogate for upper GI endoscopy. It's just that we can keep patients who are under high risk for close follow-up, and in areas where upper GI endoscopy is not available, maybe we can use this for screening and then refer them for endoscopy to a higher center, where places where upper GI endoscopy is not available.
My question is, like, in a patient in whom the high risk status, as you said, maybe the patient is the high risk of developing gastric cancer. Is it the markers you are going to follow up with, or with the endoscopy? Like, you diagnose a pre-malignant condition in endoscopy, pre-cancerization, as you said, and are you going to do a biomarkers for a serial follow-up, or you're going to do endoscopy? What do you suggest from based on your study?
We will continue with the endoscopy, sir. Like as I mentioned, endoscopy is a more invasive thing, so we can keep them. A blood investigation could be a simpler thing to keep them under follow-up, and we can.
It's good you look at simple measures and maybe like a population screening tool. It may have potential application. You have a large group of people, you screen them and find out those varicose. I'm impressed that you tried models, but the models were too simplistic. That is one flaw. What is the other flaw in your models? So if you have to develop models, you'll have to use more sophisticated tools to use, factors to improve weighting. Without that, just saying 1 or 2 or 3, that's a very simplistic model. That is one flaw. What is the other flaw? You use the same population to test the models.
Yes, sir. Same.
So that can't be acceptable. You have to test your models in a newer population because these values have been derived from this population. If you use the models to test on the same population, it is not a valid way of testing a model. You have to use a new population, test and see whether they are able to give you the answer that you're expecting. Yeah.
In your study, have you seen any association of these markers with non-malignant conditions?
Yes, in patients. In our study, it was not significant because we have excluded patients for whom we thought those things could be elevated, like any other infection or any other acute state of inflammation. So we did not find anything significant.
It is not even a primary or secondary objective of yours, but as a while going through, whether you have found any association, that's my question.
Some outliers were there, but it did not prove to be significant.
Thank you, Dr. Rajalakshmi. For the next presentation, we have Dr. Sagar Prakash, Junior Resident, Department of Surgery, JIPMER.
Good evening, Madam Present here. Myself, Sagar, second year junior resident in JIPMER. I'll be presenting the following thesis paper. Clinical utility of METU chart for the assessment of severity of corrosive ingestion, a prospective observational study. So coming to the introduction, corrosive ingestion is a widely encountered method of suicide that is practiced worldwide. Actually, it is found that about 45,000 individuals consume corrosive acids in the world per annum. So for these conditions of the corrosives that is there, we usually go ahead and do an upper GI scopy to grade the severity of the corrosive damage that is done. But unfortunately, such facilities are not accessible throughout the world in discrete areas that are there. So the novelty of this study being that in underprivileged conditions and areas, we could go ahead with a non-invasive test that is being tested over here, the METU chart, to compare the similarities in results versus the gold standard upper GI scopy that is there. So the components of the chart that were included over here were relatively simple. That was an oral cavity examination, pooling of saliva, and a total WBC count that is there. There is no Indian study up till now that used the METU chart for severity of assessment of corrosive acid injuries that is there. Moving on to the aims and objectives of the study, the primary objective of the study was to assess the clinical utility of the METU chart in the assessment of severity of corrosive ingestion as compared to the standard UGS copy that we have. The secondary objectives were to identify the association of severity of corrosive ingestion with social demographic factors and also other clinical outcomes that were there. So we went going on to the methodology. The study design was a prospective observational study which was conducted in the Department of Surgery in JIPMER between the time 2020 and June 2022. Inclusion criteria for the study being patients with a history of corrosive ingestion who are aged 18 years and above, and exclusion criteria being the patients presenting 48 hours after ingestion of corrosive substance, because that would lead to perforation if we proceeded to endoscopies. And also patients with clinical or radiological signs of gastrointestinal perforation, which is already established since the patient is unstable. And also patients with supraglottic or epiglottic burns with edema, again, because of respiratory compromise, we cannot go ahead and wait for diagnosis. So the sample size calculation that was there was calculated with expected agreement on severity of corrosive ingestion between the MET-TU and the UGI scopy as 0.75 with a population agreement of 0.5. The level of significance here was 5% in the power of 80%. The initial estimated sample size was found to be 82, and considering a 10% addition, we went ahead to find out that the final sample size would be around 90. So the statistical analysis, the diagnostic accuracy of the two methods were assessed using sensitivity, specificity, the positive predictive value and the negative predictive value. And also a measure of agreement between the two methods was done using kappa statistics. The association between endoscopic severity and quantitative variables were done using independent student t-test and categorical variables with chi-square and Fisher-Exat. All statistical analysis were carried out with a 5% significance level. Moving on to the study procedure, we included the patients that were fulfilling the inclusion criteria, then examined them for symptoms and physical examination. Findings were noted, and routine blood examination and radiological tests were performed. Once they were included, severity of corrosive ingestion was graded as per MET-TU score, which is our study over here. And then endoscopy was done within 48 hours, and severity was graded as per Zargar scoring that is there. MET-TU chart findings were correlated with the findings on endoscopy. Any finding in Zargar which was graded less than 2B were discharged after symptomatically being managed within 24 hours. And anything that was more than 2B had to be admitted and treated according to the course of the disease. So this is the MET-TU chart. We have two categories here. The one patients which do not have drooling, the other where patients have drooling. And then we're going to examine where there are no findings. Grade 1 is there is erythema alone, and grade 2 will be with ulcers. In each subcategory, we're going to look at the WBC count that is there. The WBC count, as mentioned over there, anything above that would be categorized as a high-grade injury that is there. So endoscopy-wise, we know the Zargar staging already, which is the gold standard that is being used. So the results that we saw were on endoscopy in the 90 patients that we recruited. About 75 patients were found to have low-grade injuries according to our endoscopy, and only 15 patients were found to have high-grade injury, out of which the high-grade 12 were acid and 3 were alkali. Only 3 were alkali. So this is a drawback that will be coming further ahead in the study, that only 3 of them are alkali injuries over here, but the original study that was performed was mainly based on alkali injuries. Comparison with corrosive acid, both acid and alkali, we can see that only 3 patients, it is a false negative that is given on MET-TU score. Rest of all were detected accurately by the MET-TU score. Going on to subclassifications where we talk about corrosive acids alone, again 2 patients were given a false negative result by MET-TU score, which was a high grade on endoscopy. Again, coming to corrosive alkali, 1 of them was given a false negative. Going back, we can see that agreement as per kappa statistics is still significant with 0.87 agreement. And for acids, it is a little more on 0.88. And for alkali, it is come down to 0.78. Socio-demographic factors, we could not find any significant difference between the 2 groups. And coming to the symptom comparison, we found that epigastric pain, dysphagia, hematemesis, and oral cavity lesions have a higher propensity to occur in high-grade lesions, and also higher WBC counts were found in patients with high-grade lesions. And diagnostic accuracy of this study was found to be high, and none of the previous studies have noted epigastric pain and hematemesis as predictors, which we have included in this study. The limitations of this study were that it is a single-centered study. Pediatric populations could not be included because of ethical issues. Only 37 alkali burns are there, and 75% of the patients did not underwent follow-up, only 75. There is a less sample size, and inter-observational differences would be there between endoscopic findings. Conclusion being, MET-TU chart is a quicker and easier method to assess the damage that is caused by corrosives, and it can be used by paramedical personnel also, and hence we can use this in a non-tertiary center to pick up severe injuries and refer them and make sure they get early and better care of that is required for them.
Good presentation. Can you take us to the slide where you show the sample size calculation?
Yes.
So here you have mentioned that your sample size is calculated as per a formula with your assumptions. And you said 90 was your size.
Yes.
But in your final summarizing slide, you said your sample size was less.
Yes.
Can you tell me what the discrepancy is there? Because you have calculated the sample size, you conducted a study, but in the end, you're saying the sample size is less.
For us to establish,
no, but you calculated the sample size with the aims in mind, isn't it? And you got it. Why would you be apologetic about having a less sample size? Do you see a flaw in this?
there is no flaw in this, sir, but
Are
then
you sure there's no flaw in this? Did you take into account the proportion of severe versus mild while you made the calculation for sample size?
that is not taken.
Should you use that?
Yes.
Because unless you do that, you will not get adequate number of severe. Suppose you find that in the population that you get, it's a 1 in 4 which is going to be severe. You have to account for so many severes and then use that to calculate the sample size. Otherwise, you'll end up with a proportion of a very large number of mild injury and a small number of severe. So that is where you need to tweak this. Otherwise, you went by the sample size calculation.
Yes.
Sir. You said upper limit was 48 hours. Did you have a lower limit because you're looking at WBC? Suppose somebody comes 2 hours after injury. Would you expect the WBC count to go up? So did you have a lower limit to say that at least 12 hours after injury, you'll take the blood count?
No, so there was no lower limit. At presentation, whenever the patient came to us, we were drawing a sample.
Maybe it's worthwhile saying what is the gap between the sample time and the injury time to see whether you have given adequate time for the counts to actually go up.
Yes.
Did you think of CT scan for assessing the injury? Because that's an upcoming area where they say CT cross-sectional image may be a better prognostic indicator.
Maybe we could consider CT if it is classified as a high-grade injury.
You calculate the samples based on some references you have given. Looks pretty old, 2007. Is it the same? They have calculated the agreement of Matthew score and
yes, it is based on.
Okay. What is the reason why it has not been taken up, been published so earlier? And
their sample.
what do you think the score? Why it has not been widely used?
Their sample size, according to their calculation, was also around 147.
No, I'm not talking about the sample size. See, the study, what you quoted is 2007, and which they compared our MATU score with the endoscopic severity. And based on that only, you you put up an expected agreement. What I mean is like, if this score is easier and used, so why this is not widely used more than a decade? Now, what do you think? Why you think it is not been widely used? Any limitations using, any difficulty in using?
No particular definite limitation as such. It is relatively easy score to perform, even in a paramedical personnel having just a RAC or a lower center.
Okay, Dr. Sorry, thank you.
Thank you, Dr. Sagar. For the next presentation, we have Dr. Varsha Raja, who is the MRCS resident at KIMS Kingsway Hospital, Nagpur.
Good evening to one and all present here. I am Varsha Raja NR, MRCS resident from KIMS Kingsway Hospital, Nagpur. This is a randomized control study on cool lignocaine during urethral dilatation, which improves patient satisfaction and comfort. So urethral dilatation is the most common performed procedures in the urology department, and it is done on an office setting and also IPD basis. It is done for patients who require immediate catheterization due to obstructive urethry. And the most commonly used anesthetic agent is lignocaine, and it reduces procedure-related pain. So the hypothesis behind the study is that the tissues can be cooled to enhance the effects of local anesthesia. And this study is done to investigate if using cool lignocaine jelly to 4 degrees Celsius will significantly reduce the patient discomfort during urethral dilatation compared to using the lignocaine at room temperature. So the study design, as already told, is a prospective randomized trial, and the power of the study is 100 patients. The male who were above the age of 40 were included in the study, and those who were less than 40, male who were less than 40 years of age, and women and children were excluded. Other than this, the most important reason why we excluded women was because they had different urethral architecture, and people who used continuous analgesics were also excluded because of perception bias. And individuals who had previously undergone urethral surgery or pathology were eliminated because they might have altered local anatomy or pain perception. Counseling was done prior to the procedure to the patient, and to avoid any response bias, all the patients were counseled and the research protocol was explained without mentioning the anticipated benefits. And self-reported pain experience during the procedure was measured as the study's primary endpoint using the standardized and verified visual analog scale. So the visual analog scale is a chart with 0 to 10, scale of 0 to 10, in which 0 to 3 is considered as mild pain, and 3 to 7 is considered as moderate pain, and above 7 it is considered as excruciating or unbearable pain. Once the VAS score is determined, we ask the patient 2 questions about their level of satisfaction with the procedure and if they would come back to the OPD to do this procedure if it is deemed necessary. Consent was obtained from the patient, informed consent document and consent form was signed. And the procedure included the usual Teflon dilatation method in which basically the patients were divided into 2 groups. One group which contained patients who were getting full lignocaine of 4 degrees Celsius, and the other group which contains patients who got normal temperature lignocaine. The patients were painted, raped, and the one who were in full lignocaine got 4 degrees Celsius lignocaine intraurethral, and the other group who were in normal lignocaine in room temperature, they got the normal lignocaine. Penile clamp was applied for 5 minutes on the coronary region following the intraurethral administration of lignocaine, and the clamp was released after 5 minutes, and urethral dilatation was done using the seated Teflon dilatation method. While the procedure is being performed, the pulse rate was also monitored to eliminate any perception bias and confirm the experience of pain by the patient. The procedure time was noted by the nursing assistant. This is the observation chart which was used, which had the name of the patient, age, group in which they were allotted, time taken for procedure, pulse rate, and VAS score after performing the procedure. So the main observation of this study was the procedural discomfort was comparatively less when compared to the patient who received normal lignocaine jelly. And in this pie chart, we can see that the patients with full lignocaine jelly, they had the VAS score mostly around 3 or 2. And the one with normal lignocaine jelly, they had VAS score of 4 or 5. This is the same result which I already told. The mean pain scores were 2.82 plus or minus 1.03 and 1.8 plus or minus 0.08 respectively for the groups in LI and LI 2 degrees Celsius. So basically there was 3.6% reduction in the mean pain score as compared to the room temperature lignocaine when used full lignocaine to 4 degrees Celsius as an.
Thank you. Good presentation. One, how did you ensure the lignocaine was actually 4 degrees? Did you measure the temperature of the jelly, or you just kept it in a 4 degrees Celsius refrigerator for say 10 hours or 12 hours? But you can't be like dead sure that was 4 degrees Celsius lignocaine. But you never measured you didn't think there would be a difference? So if you're doing a randomized study, that is an important measure. You cannot assume that something is 4 degrees just because you kept it in a 4 degrees Celsius refrigerator. Did you grade for the severity of strictures? Because strictures can be various types, and the very tight strictures could have more pain versus a not so tight stricture, or multiple strictures could have more pain. I didn't see that. So did you actually control the strictures?
We selected the patient. We did an RG for all the patients. So with that, we graded the patient.
But you've not showed that in your results, because that would have actually told us if there's a difference between the two groups, no? Yeah. Then I somehow, looking at the results that you showed, I feel your study is underpowered because the difference in pain is small. If the difference in pain is small, then the expected sample size will be much more than what you have shown. So did you get a statistician help to arrive at this number, or? Okay.
Calculate the sample size. I don't know whether I missed the slides. Is it there? How did you calculate the sample size? Because it's a randomized controlled trial, and as I've said, you have to calculate the power of the study and what's all fiber you need to keep. That's the important one. And why did you exclude the men of less than 40 years? Any particular reason?
Mostly men less than 40 years and not structure.
No, exclusion criteria is usually based on some scientific explanation or criteria. It's something like more than this age or less than this age, patient are more prone to develop, something like that. It's not that patient presenting with these symptoms are more commonly this age. Usually not like that. Okay. Did you register your trial in CTRI? But you've already completed the study. Hope you know what is CTRI. Okay, thank you.
You compared this one. So it was a single validation in each group for a patient or both? So whether the procedure was done once only with a single procedure, or it is with
it was only
single procedure. So it was the first dilatation in each group. How is the
first time.
when the patient was
Thank you.
Thank you, Dr. Varsha. The next presentation is by Dr. Veda Prakash, Junior Resident, Department of Surgery, JIPMER.
Good evening, I'm Veda Prakash. I'm going to present my dissertation topic. It's about the effectiveness of low molecular weight heparin in the reduction of severity of inflammation in patients with acute pancreatitis. It's a single-blinded randomized control trial. We included moderate and severe pancreatitis patients. As you know, since pancreatic microvascular impairment is an important factor in the determination of severity of acute pancreatitis, the severe inflammation associated with pancreatitis causes impairment in microcirculation because of the virtue of microthrombus in the microcirculation. It leads to necrosis of the pancreatic tissue, leading to the conversion of edematous to necrotizing pancreatitis. So low molecular weight heparin is a potent anticoagulant, can inhibit the blood coagulation cascade and improve microcirculation. It also independently shown to inhibit inflammation during the disease progression. So it has been shown that it inhibits production of pro-inflammatory cytokines and induces a profound change in human neutrophils to control inflammation. So in this study, we have used our aims were to study the effect of enoxaparin as compared to standard care on the modified CT severity index, local and systemic complications, as well as clinical outcomes in case of acute, moderate, and severe pancreatitis. We included all patients more than 18 years who presented to our emergency with moderate and severe pancreatitis as per revised Atlanta classification. Patients who presented with symptoms more than 7 days, who are hypersensitive to low molecular weight heparin, coagulopathy, CLD, patients with thrombocytopenia, and patients who had hemorrhagic pancreatitis or pseudoaneurysm at presentation are excluded from the study. A total of 62 patients were included. Sample size was calculated based on a previous study done in 2019 in Germany. Enoxaparin was administered at 1 mg per kg via subcutaneous injection twice daily between day 1 and 7.
And CT was taken at presentation on day 1 as well as on day 7 of the admission. We compared radiological parameters like modified CT severity index, pancreatic necrosis, lengthening vein thrombosis, and peripancreatic fluid collection before and after administration of enoxaparin, as well as clinical parameters like time to oral intake, duration of stay, percutaneous and surgical intervention done, ICU stay, systemic complications like ARDS, shock, multi-organ failure, and acute kidney injury were compared. Coming to the results of our study, totally there are 31 patients in each group, randomized to each group. So the baseline demographic characteristics were same on both the groups. On admission, the clinical laboratory parameters and CT severity scores are comparable between both the groups with no significant difference, as well as the distribution of moderate and severe pancreatitis were similar between both the groups. This shows the most important graph of the study, which shows the primary outcome. Here you can see this shows a progression of CT severity index as compared to the initial CT of all the patients. The orange bar shows the low molecular weight heparin group, like the patients who received the enoxaparin, and the blue box shows the patients who received only the standard treatment. Here we can see in 10 patients out of the 31, we could see a regression in modified CT severity score after 1 week, as compared to only 2 patients, that is only 6.4%. But in 32% of the patients who received enoxaparin, there was a regression in CT severity score, and progression was seen in 7 patients. That is 22.5% of the patients who didn't receive any enoxaparin, but the CT severity score progressed only in 2 patients who received the enoxaparin. The next graph shows the clinical parameters among each of the groups. The duration of hospital stay, median duration was 12 days in patients who received the standard care, and it was only 8 days in patients who received the low molecular weight heparin, as well as time to take full orals was 4 days in patient with standard care and 2 days for patient who received enoxaparin. Both were statistically significant, the difference. And the duration of ICU stay, we can see it was 4.5 days median duration for patients on standard care and 4 days for patients on enoxaparin. However, the difference was not significant. This actually slide shows the comparison of complications. I'll explain only one which was significant, the ARDS. Here we can see at presentation in standard group, there are 12 patients who are having ARDS. After 7 days, only 6 out of 12, 6 patients ARDS was resolved, but 6 patients had persistent ARDS and 2 had developed new onset ARDS. Totally, at the end of 7 days, 8 patients had ARDS. However, in low molecular weight heparin group, there are 11 patients initially had ARDS, out of which 9 patients fully recovered at the end of 1 week. Only 2 patients had persistent ARDS, and none of the patients developed ARDS during the course of treatment. And at the end of 1 week, only 2 patients had ARDS. The difference was statistically significant. And we observed similar reduction in complication in AKI, shock, as well as multi-organ failure, but the difference was not significant. The next slide shows the local complications in both the groups. Here we can see the splanchnic vein thrombosis, which includes splenic and portal vein thrombosis, the pancreatic necrosis, as well as acute peripancreatic fluid collection. All three were actually we noticed a reduction in patient who received low molecular weight heparin, but the statistically significance was noted only in acute peripancreatic fluid collection. However, SVT and necrosis there was not statistically significant. This was mainly because since it's a tertiary care center, we received patients with advanced disease, like referred patients who already developed venous thrombosis as well as necrosis. So we are not able to study regarding new onset necrosis in these patients. So the difference is not significant. Other than that, we could see a reduced rate of percutaneous intervention in patients who received low molecular weight heparin, and no hemorrhagic complications are noted. Only one mortality was observed in low molecular weight heparin group. So coming to the conclusion, it reduces the severity of inflammation associated with pancreatitis as compared to standard treatment. It reduces incidence of local and systemic complications and also improves clinical outcomes. So it can be routinely used in patients with pancreatitis with the good safety and low side effect profile. Thank you.
Thank you, Dr. Prakash. Yes, this is a randomized control trial, right?
Yes.
So did you include the slide on sample size calculation? What are the effect size you expected?
I have not included the slide of sample size, sir. Actually, it was taken from based on a previous study published in 2019, where they have included 100 patients in total, 50-50 in each group. And based
No,
on
I'm not talking about the study which was already conducted. You have chosen to do a randomized control trial, and you were expecting some improvement, right? One control arm compared to the control arm, your intervention arm should have something better, right?
Yes.
So is your superiority trial or a non-inferiority trial?
It's a superiority.
Superiority trial. Then you should have calculated sample size based on superiority margin. What was the effect size? Like how much improvement you expected?
It was based on the improvement in modified CT severity index, which is the primary outcome. We took power of the study to be 80%. And we calculated.
No, your aim is to see whether it is progressing or regressing, right?
Yes.
Okay, so that's progression and regression based on the CT severity index. So how much you consider it significant? What was this?
Even if there is a reduction in 1 point, that is considered a regression, like 2 points.
Like, did you register in CTRA?
Yes.
Because it was not mentioned in CTRA. And CT you did for all the patients at day one.
Yes.
Okay, for the study purpose.
Yes.
Because usually we never do it like as a routine.
Yes, sir. But the average duration of presentation was 4 days, sir, in this study. So most of them already had a symptom onset of 3 days in our study.
And many places you written just less than 0.05. It's better to write up absolute value so we know how significant it is.
Yes.
That enoxaparin was given when it was on first day and seventh day.
No, continuously from day 1 to day 7.
Okay. So, but you are telling that mean period of presentation was 3 to 4 days, no?
Yes, sir.
So there must be some patients must be presenting after 8 days, few must be presenting 1 day. Whether that was taken into
We excluded patients who presented for more than 7 days. Like the duration of symptoms more than 7 days, I have excluded in my study.
So all were less than 6 days. Okay. There was no among these patients. All the patients he was able to do the CT scan on the first day.
Yes, sir. Like on the day or day 1 of admission.
What about the patients with organ failure?
Organ failure after stabilization, usually like ARDS, AK considered.
No, for the first day CT scan.
Yes, sir.
Whether that is not the exclusion criteria, no?
Not the exclusion criteria.
And all were all severely acute pancreatitis.
Moderate and severe.
Moderate. Okay. But you have not found any patient, all the patients in your study, you have not found a single patient who was in renal failure where the CT scan was not.
No, like if the patient has adequate urine output, I have considered for CT after hydration.
Okay, thank you.
Mortality, I think no mortality in your study. You had included moderately severe.
Only one mortality was there in the low molecular heparin group. No mortality was found in the standard group.
It was not reflected in your.
Yes. Only one mortality. I couldn't.
Okay, fine. Thank you. Thank you, Dr. Ved. Thank you.
Thank you, Dr. Veda. Next up, we have Dr. Vidyat Shetty, Junior Resident, Department of Surgery, JIPMER, for presenting his paper.
Good evening, everybody. This is my thesis dissertation. Actually, done under Dr. Vishnu Saksar. Liver volume variation in patients with pre-sinusoidal cause of portal hypertension, a retrospective and prospective observational study with semi-automatic liver segmentation done using multidimensional CT. So basically, how this research question developed was, we are having a lot of upper GI bleeds patients presenting to OPD, that is varicose upper GI bleeds, predominantly male patients who had very insignificant alcohol history, but had been branded upper GI bleed secondary to varices, probably due to DCLD. Only because of that alcohol history. So since we are routinely doing splenectomy with shunt procedure,
when we evaluated these patients with CT scan for pre-op, we saw that like patients with these patients had very significant volume redistribution on CT, which was not correlating with the cirrhosis. And later on, these patients are also meeting the criteria for NCPF and EHPV, which I'll be telling later. So later on, we found a bunch of NCPF and EHPV patients. When we went back and did CT for all these diagnosed patients of NCPF and EHPV, we found that there were very specific liver volume redistributions which are happening in these patients without any outright feature of chronic liver disease in this patient. And they were having all the features of portal hypertension, that is variceal upper GI bleed as well. So we wanted to look more into this volume redistribution, and because more importantly in literature, being a prehepatic cause, both NCPF and EHPV, which are the two most important causes of NCPH, have been reported to have normal liver morphology. So what we found in our imaging was grossly different. So we wanted to investigate to this. And according to literature, according to APASL guidelines, NCPH almost accounts for around 25% of upper GI bleeds in the Indian subcontinent. And it is also mentioned that this has been wrongly tagged as liver disease without proper workup. So this is what we wanted to investigate. We're using liver volumetry. For liver volumetry, we had taken 6 simple steps of liver segmentation, which was advocated by a Dutch article by German et al., based on which we calculated the liver volume. So the aims and objectives was to conduct liver volumetry using multidimensional CT in patients of pre-sinusoidal causes of portal hypertension, that is predominantly HPV and NCPF, and find out if there is any change or liver volume redistribution when compared to normal individuals. And then analyze the association of various qualitative and quantitative characteristics of the patients with the liver volume scores to find if there is any association. So it was a retrospective and prospective observational study conducted in our department. All patients coming to surgery, OPD or emergency and getting diagnosed with pre-sinusoidal cause of portal hypertension, that is EHPV or NCPF, either by clinical, radiological or with or without a liver biopsy. Exclusion criteria, because we are doing CT purely for the purpose of thesis, patients who did not have a previous CT scan and were not willing to come back for a new CT scan or were not available to come back for a new CT scan were excluded from the study. And because CT requires contrast injection, patients with deranged RFT were excluded and pregnant patients were also excluded. So we collected the data of diagnosed cases of NCPF and EHPV predominantly from the endoscopy registers of medical gastro and our surgery department, and patients who have previously undergone surgery like open splenectomy and shunt procedure in our department. And the total liver volume was whoever were recruited, history was taken about how many number of bleeding episodes, banding sessions, who has undergone splenectomy, and then we took routine lab investigations for them, took a triple phase CCT of liver and portal venous Doppler. Total liver volume was calculated from this CT using Singovaya software, which we usually use in our institute. And standard liver volumes were calculated using a specific formula, which was advocated by Urata and Chandra Mohan, 2 different formulas, which has been advocated based on the height and weight of the patient. And then lobar volumes and sectional volumes are also calculated using the Singovaya software. Since we didn't have any control liver volumes in our study, we took the reference as article published by Abdallah et al., which said that the right lobe to total liver volume ratio was 2 times when compared to left lobe. And that was used for looking at the atrophy hypertension. So baseline indication characteristics, as we can see, it is in line with the literature. That is, age at first UJ bleed in NCPF is in the 3rd decade, and EHPV is in the 2nd decade, as 4th decade in NCPF and 2nd decade in EHPV, as per literature. Most of the literature has been given by APASL and headed by Dr. S.K. Sarin, like in an Indian medical gastroenterologist. And one very important thing to consider is out of 45 patients which we recruited via convenient sampling in our study, whoever was operated, that's a total of 34 patients, and now at present, it was 23 at the time of recruitment, all have undergone liver biopsy, and all the liver biopsies which were taken were normal, without any features of cirrhosis. So ultrasound characteristics, again, you can see one of the NCPF and none of the EHPO patients had liver nodularity. Only mild altered liver echoes were the only finding on ultrasound. But we can see that liver RP was slightly elevated in NCPF, that is 1.6. It was normal almost in EHPVO. Other characteristics were not significant. Collaterals were seen in almost 80% of EHPVO and 50% of NCPF. So proper features of portal hypertension was there, but there are no features of gross liver involvement. So this is just a snap of the CT liver volumetry, which was done using Syngovia. So the green part is the left lobe and the orange part is the right lobe, which is segmented using semi-automatic method. So this is actually the CT volumetry analysis, which was found out in our population. Actually, more than the numbers, I would like to show you the, this is just that we found that the hemogram, there was significant improvement in all the patients undergoing splenectomy, further strengthening the diagnosis of hypersplenism in these patients. So this is the one which I would like to stress upon. So the normal liver proportion, like I mentioned, based on multiple studies, was decided as a right lobe 66%, left lobe 33%, caudate lobe 2%, and left medial and lateral section to be 16 and 16%. We found that in EHPVO patients, there was if you look at the left lobe to total liver volume ratio, there was significant left lobe atrophy. So left lobe was only found to be 26% in that population, and we saw that caudate lobe hypertrophy was there. And in NCPF, there was right lobe hypertrophy along with caudate lobe hypertrophy. Yes.
Can you go to conclusion?
In conclusion, like I said, there was significant volume redistribution in both NCPF and EHPVO. Though the literature states that the liver is predominantly normal in both NCPF and EHPVO, we have found that there is significant volume redistribution in these patients. And although there is no gross features of CLD in these patients, maybe there are a lot of cirrhotic patients, or a lot of patients with portal hypertension in our population with splenomegaly who have been branded as cirrhotics without a proper
cutting short. Like you are already cutting short.
So we large scale prospective studies are required to conclusively prove these changes in a bigger population.
Okay, thank you, Dr. Vikir. Only one question, like your states to medical fraternity to allow the existing medical fraternity to consider this disease also as significant cause of liver disease. What does that mean? Like so already we consider EHPVO and NCPF as a significant cause of liver disease. Like what's the application of your study?
So as of now, according to the existing literature, NCPF and EHPVO is considered to be a cause of portal hypertension without liver involvement. Liver is considered to be normal in according to all the studies. But in our study, liver is functionally normal, but there is significant volume redistribution. So probably a lot of patients who are presenting to us with CLD with insignificant alcohol history, or females who are.
No, I'm asking about the application. Like you found out this significant volume discrepancy is there.
Yes,
so what is the application like? How it's going to be applied in therapeutic aspects?
As of now, when we consider therapeutic strategies for chronic liver disease, or with respect to transplantation, patients who are long-standing CLD with not known causes are not considered in a.
So these patients are expected to have a normal liver function, and only the volumetry is different. So how it is going to help in prognostication, therapeutic and prognostic point of view?
Yes. No, they have been treating these patients like shunt. Many of these patients, the pancytopenia, the hypersplenism is reversible with splenectomies. But because they have been taken as chronic liver disease patients, the splenectomy is not advocated in these patients because of risk of encephalopathy and other problems which you would normally consider for a cirrhotic. So they need to be considered as non-cirrhotics and then treated with splenectomy so that the hypersplenism is reversed.
The question is, instead of taking history of alcohol consumption, is there a better indicator for you to differentiate? Is that what you're pointing us towards?
Yes, sir. In patients who don't have, who are seronegative, who do not have any reason to develop liver disease, we should suspect more of non-cirrhotic portal hypertension when there is just a splenomegaly present. And that would lead us to go to a treatment option of splenectomy. So as I told, we have done it for 34 of the 45 subjects.
So what do you need to do to strengthen the evidence in support of your point?
So, first of all, is high index of suspicion, especially when a female comes to us with upper GI bleed. or a male for that matter without any risk factor to develop chronic liver disease. So instead of just diagnosing them to be cryptogenic liver cirrhosis without proper workup, a definitive workup with the imaging, which would thus prove a normal liver, would lead us to consider therapeutic options like splenectomy and shunt, so that they can have a better quality of life.
You used one reference article to talk about the liver volume distribution, isn't it? So that is from which region?
So that was it's an Egyptian article.
So did you think of something from a more local population, because that is your study population?
Yes, sir. Actually,
because you don't have control.
Yes, I did consider. The issue was there is not much studies done in India. There is one MRI liver volumetry done in PGI. Other than that, there are no articles published on CT liver volumetry done for NCPF and EHPV or like liver volumetry per se. So we could not get a reference article from Indian populations.
Thank you. Yes. Thank you very much. We have given our scores, and I just want you to realize that these are purely subjective measures. As far as I see, all 6 of you presented extremely well. It requires a lot of courage to come here and put your study open for dissection by us, and we are no experts. So a big hand for all the 6 who presented here. As far as I am concerned, all 6 of you are winners. So well done, all of you. And also, as a disclosure, each of us, if we were guiding or co-guides for a given study, we have not marked, and we have excluded ourselves from that process of judging. Thank you very much.
Thank you, Dr. Vikyas. With that, we come to the end of the oral paper presentation session. The results of the same will be announced shortly.
To end this eventful day on a high note, we have eagerly awaited JSU surgical quiz. I kindly request Dr. Ilamurugan to take charge of the stage henceforth.
Good evening, all. We come to the last part of the update. ASU quiz. So I request Saikaran to distribute the papers. So this will be 25 questions or 25 markings. So you can write your name, college, and answer them. So it's either true or false or filling or the diagnosis. So there is 1 mark for each question. There is no negative marks. Some questions has 2 parts. So if you answer 1 part, you may get half a mark. So eligibility criteria, all JRs can attend. SRs, I think, may be easy for you. So it's only for junior residents, and UGs also can attend. Any UGs here? All categories is paid. So if everyone has got a paper, everybody has got a paper. Let me know the participants. Please raise your hand. 1, 2, 3. Yeah, we can have space between you so that your opponent or the next one doesn't get your marks. Yes. Everybody has got a paper now. Shall we start? Everybody has got a paper. There are some index questions which we have marked. Suppose we get same marks, two people get same marks, then based on the index question, we'll choose the winner. Shall we start? Okay.
Yes, identify this personality. He related to these two pictures there. Can you make the speaker? Anybody is on online? Only online. YouTube page. Some triangle and I don't want to reveal
Spotlight.
so that you
Just remove it. It will go. Just put that.
I was initially planning to give a minute for each, so but we are at the back end and all are tired, I can see. So if you're okay, we'll go to the next question and after 30 seconds. Most of them are easy, you just have to think. Okay. Identify this disease. There is a celebrity there and there is a histopathological picture. If you connect both, you will get the disease. Okay. It's Wolverine. She says that. Okay. What is the finding in this contrast X-ray and what is the diagnosis? So this, if you write the finding alone, you will have point half a mark. If you write the diagnosis alone, you will get the lower GI contrast study. Okay. Next. This is true or false question. In insulin stimulation test, rise in acid concentration in any 15-minute sample of more than 20 millimoles per hour is taken as a positive response. I understand you know what is Hollander's test. When is it done? Post tracheotomy, or you want to check completion of your procedure. We like to know how much is the acid secretion to stimulus. So is this value of 20 millimoles the cutoff, or it is less or more? Please don't use step or update to see the answer. Okay. Shall we go next? What is this instrument named? I don't want to pronounce it. Modified and used now as. What is the current modification of this instrument, or where is it used currently now? That was originally it was designed like this. Later it has undergone several modifications and change in change. Now it is being used as what? It's called Lich lighter. Next. Name this vascular surgery. There are two pictures here, what he did and what he got. Okay, next. What is among, there are ribbons for each cancer for our awareness program. So what is the ribbon? Which option is the ribbon for thyroid cancer? This is easy. Okay. This is spot question. We'll have to wake you up. Anybody who answers will get on the spot prize. What is the condition called when you have humeral hernia with this structure as a content? Anybody? First, what is the structure? You should not answer. Yeah. Yes, sir. Huh? Litter yeah, yes, good. Come to cycle. Both Beppel's diverticulum in inguinal hernia as well as hernia is got litter hernia. Good. Question 8. What is Marine-Lenhart syndrome? This investigation is, you can find out this by this investigation about this syndrome. Radioactive iodine uptake study. Will help you to pick up this abnormality. Okay, next. This MCQ type for necrotizing fasciitis is due to which group of organisms? Parasites, polymicrobial, monomicrobial, fungal, vibrio. Type 4. Okay. You want time? Raise your hand. To identify this condition, commonly affects breast and penis. Please write the name of the disease rather than the pathology or clinical picture. Clinical diagnosis. Name of the diagnosis. Name. You got a name. Okay. Identify this device.
You're not contesting? This is easy. I hope many of you will easy. I'll give you a clue used in malignant patients. That's what. If you give the clue, it is more because 99% easier. So what is this worm? It's usually called as a seeker. You can write its common name or its scientific name. Common name on seeing itself, on seeing that itself, you can know how does it look like. So that is the common name. And scientific name, if you know the common name, scientific name is easier. So I'm giving clues so that you get closer to first prize the second. Okay, next. Identify this minimally invasive surgery. Oh, what is this surgery? Clue, the upper part, what you see appearing like a fascia. I'm giving away the answers, I think. As soon as I give the clue, many are blooming. Good, let's see it. So what is the diagnosis of this upper GI contrast study? You need this diagnosis has got two types, so I need the exact type. That's the clue. You just write the not the type, then you may not get the marks. You may not get the marks at all, because otherwise it is easy to diagnose. See, until next. The recommended tumor marker for clinical utility of breast cancer are all except TA53, urokinase plasmid activator, cathepsin D, and P53, which is not a marker. Okay. You need time to raise your hand. I will come back to the side. This is thought question. Anybody connect all the pictures and tell me the name. Connect. Each picture has to be connected. You will get a name. You pick the sound of the last picture, then it is easy. Anybody? One pen drive is there. Two more pen drives are there. This is to play connect game, no? Just use the sound alone. N. What? What is the last picture? C. Surgeon, you should be familiar with C. NC. NC. N. N is the starting word. C is the last word. What is the next picture? What is the third picture? Dam. Dam water. Quickly. Hydro. You said hydro? Hydro seal. What is there before? Yes. Who said?
Encysted hydrogen.
W. Good. Okay. So now we are on. Next, identify this clinical type. Identify this clinical type. Seen in acute abdomen. That's the clue. The region is thigh bar inguinal region. What is the name of this condition? So this patient had a swelling in the inguinal region. Something was done for that in his previous admission. He comes 1.5 months later or 1 month later with intestinal obstruction. So on opening, we find this. This was the finding. So what is the diagnosis of this abnormality? Okay. Next. What is the name of this procedure? The picture is self-explanatory, so I'm not. The clue can be done in filaria. Okay. Identify the common word between these two pictures. The clue is there is a triangle which happens in liver disease. Okay. Next. What is the diagnosis here in a patient, adolescent patient with unilateral limb swelling? Basically asymmetric of limb. In adolescent, shorter duration, asymmetric limb. I given the clue in the CT picture. Clue is the same group. Okay. This is an MCQ. Transplantation of human organs act was found in the year. There are several modifications. I'm talking about the original act when it was introduced. There was a major scam in Tamil Nadu. So then they came out with that act. So if you can remember that time, you have a clue. Okay. Name this sign seen in upper GI endoscopy. This is a sign of impending rupture of varices, esophageal varices. There are few common signs. This is one little rare sign. Okay. What is the name of this device? Used for upper GI therapeutic procedure. I need the name, not the action. What is that or the use of it? Name. Okay. Name the sign seen in Doppler ultrasound of Burgess disease patient. Patient with Burgess disease, you do angiogram, you find an abnormality. In same place when you do Doppler scan, you will get this abnormal, this finding. What is this finding? Okay. What is the name of this procedure done in patient with ascites? I want the name. Uncontrolled ascites. What is the surgical procedure? I think I've done 25 questions. Okay. Okay, collect the papers. Kirti is there. Kirti, collect the papers. Thank you. Once all the papers are collected, then I will display the answers. If everybody is given the paper, first is Rudolf Virchow. That's Virchow's triad and Virchow's lymph node. Basal cell carcinoma. We had basal cell carcinoma. The other one is showing classical peripheral palisating of basal cells. Left by colon. The finding is There is no features in the colon. It looks like a lead pipe, single pipe, and then seen in ulcerative colitis. This is the finding is true because minimum amount of elevation should be more than 20 millimoles. This is now being used as endoscope. It can be laparoscope, endoscope. Basically, the fiber optic thing has been developed from this basic instrument. This is Alex Carroll. He revolutionized the vascular surgery. Whatever is a circular vessel, he made such a way that it becomes into a triangle and easy for anastomy. That's for that he got Nobel Prize. And this is thyroid. Thyroid cancer is T. It's got T, blue, and pink. The top part, the horizontal part is teal in color. The blue on one side, pink on the other side. The syndrome is in a patient with Graves' disease. You might normally you have a diffuse goiter. Suppose you have a nodule in that, then that you can see on radioactive study, the nodule will be hyperactive. Type 4 is fungus. Type 1 is monomicrobial, type 2 is polymicrobial, type 4 is fungus. It is not just this is there in Bailey. A similar picture is there in Bailey also. This is chemoport. Many of you would have seen, that's why I just wanted to keep it simple, that's why I kept. This is chemoport where everything is placed inside the body. You just have to poke and start giving. This is done as a daycare procedure. Every time patient comes with chemotherapy and get it done. This is JIPMER, trichuris. This is subfacial endoscopic perforator surgery. What you see above is the fascia, you go below that. You see the base is the muscle. So pierces the fascia and reaches up. This is gastric volvulus, organoaxial. Organoaxial type of gastric volvulus. P53 is not a marker for CA breast. This is spark sign. So you correct it. This is spark sign. You would have seen Cullen sign, great Turner sign. Similarly, if you find in inguinal region, this is spark sign. This is called Gary's stricture. Gary's stricture, you have a strangulated inguinal hernia and resident, so somebody manipulates and pushes it inside. The segment which was impending gangrene might heal and form into a stricture. So patient can present to you later with a stricture, Gary's stricture. This can also happen due to chronic herniation, which is irreducible kind, where again the blood supply is compromised, leading on to stricture formation. This is Homan's procedure, where debulking. There are different types of surgery for filariasis. You debulk, you shunt, or combination of shunting and debulking. So this comes under debulking, Homan's procedure. This is easy Charcot's triad. Triad in liver, obstructive jaundice, and Charcot joint. This is May-Turner syndrome, where the crossing common external iliac artery compresses on the same side iliac vein, leading on to venous edema, DVT. Classically happens in adolescent patients. So, Organ Act was in 1994. Later, it was modified in 11. Then again modified in 14, basically to increase the donor population. And this is white nipple signs. Other signs are red vein sign and cherry red spot. This is Maloney's UG, used for esophageal dilator. The other one commonly used is Savaricula. I hope many of you would have seen Savaricula, which is available in our endoscopic room also. This is Maloney's. This is snake sign or dot sign. What we see as corkscrew collaterals in angiogram. When you do a doctor, it will be seen as snake sign or dot sign, depending on how much is the bend between the collaterals. This is Levin shunt, peritoneal venous shunt, from peritoneal cavity to subclavian vein or in the IJV. Thank you. Yeah, I'm done. Thank you. BCC, ulcerative colitis. This endoscope. Any scope is okay.
Thank you, Ilazar, for a wonderful quiz session. We now request Professor Dr. Vishnu Prasad to felicitate Dr. Rabaran.
This bag has given us the laptop.
Where we are keeping our stuff.
Our stuff. This we will have to find another way. One of our people files. Initially got plastic. We'll take so.
Validity we have to record.
Why that work for you?
No. Recording is nothing on YouTube only. If you want to record.
This everything in the battery is only 2 are left in the. I'll put it in this lead numbers. One is written that I saw. Nobody is using pointers. What is it? Makes us get along very acceptable.
In Alex's pointer.
Three, yeah.
One pointer.
Will be there in the computer. Oh, this is my pen, bro.
Pointer. No, one pointer is there.
One pointer is there.
Okay, that is a pointer.
One I gave to
Abhinay sir gave me.
that also is there. Abhinay sir gave you one. Then this is not good.
So you have one pointer there. Okay.
I got it, sir.
One this is the one you took from my bag.